as well as all the delegates. Now we start with the free paper session, and I must tell you a few rules. The total presentation will be for 7 minutes. At 5 minutes, a buzzer will be sounded, and at 7 minutes completion, it will be blackout from the screen. So we now invite Dr. Sajak Kumar Gupta, the first presenter, who will be presenting on comparison between minimally invasive percutaneous pedicle screw fixation versus open pedicle screw fixation for geriatric osteoporotic spine fracture in a rural hospital. I think he's not there. I invite Lieutenant Colonel Yamuna CB. She'll be presenting on a nurse-led initiation to prioritize enteral nutrition during critical care neurotrauma illness in intensive care unit.
A very good morning to one and all present here. I bring greetings from Army Hospital, Arundar, Delhi. So as you know that the severe traumatic brain injury ranks among the most common cause of death in the young adults, which is followed by a pronounced pathophysiological cascades like hypoxemia, arterial hypertension, intracranial hypertension, hypothermia, hypo and hypoglycemia, thromboembolic complications. So a critical care team or a neuro team looks at which the aim is to minimize and to control these consequences of this potentially fatal cascades. So now the management is mostly concentrated on the hemodynamic monitoring, which is invasive or non-invasive, or ventilator management, surgical management, medical management, it goes on. So what is missing in it? So isn't it, you'll not think that the nutrition is very, very important. Nutrition is not a rocket science, but it surely helps the recovery of any traumatic brain injury case. So at this time, my small study is a nurse-led initiation to prioritize enteral nutrition during critical care neurotrauma illness in intensive care unit. So as you know that the effect of nutrition has been rather underestimated as a means of improving the outcomes after traumatic brain injury, and it should be started within the first 24 hours after a trauma. Enteral, whenever it is applicable, should be the route of administration for nutrition. And now this enteral administration of the whole calculated calorie requirement on day 1 after trauma lowers the infections and overall complication rates. There are many studies in regard to this. So this provision of adequate nutrition supports for patients with traumatic brain injury has been a critical challenge for decades. So this has got to many accompanying issues also. So these nutrition therapies should include exact nutritional resuscitation goals specifically for traumatic brain injury and strict electrolyte monitoring to avoid extreme fluid or electrolyte imbalance which can harmful to the patient. Now, during critical illness, gut dysfunction is promoted by different mechanisms and intestinal permeability and dysbiosis that lead to downstream migration of pancreatic enzymes, free fatty acids, and pro-inflammatory cytokines into the systemic circulation, which leads to organ failure. And then in this, which leads to poor wound healing, ICU-acquired muscle weakness, and other negative outcomes for the patients. So in this, early enteral nutrition leads to fast recovery of the patients, less complications can be there, and it leads to less mortality. So now the aim of my study was to assess the effectiveness of nurse-led nutritional interventions and monitoring the outcomes of critically ill patients of the ICU with an objectives to assess the effectiveness of this nutritional interventions and to find out the association between the effectiveness of these interventions and the socio-demographic data. So it was a descriptive study with the critically ill neuro patients of intensive care units with a sample size of 25 and with a simple random sampling at the Northern Command Tertiary Hospitals duration of 8 months. So now what all things were considered was that the gastrointestinal intolerance, screen and manage patients for any refeeding syndrome, and a micronutrient supplementation was started, and during critical illness 1.3 gram per kg protein equivalent per day was delivered, and when there was hemodynamic instability, the enteral nutrition was held. So the inclusion criteria was patients admitted in ICU with TB and on mechanical ventilator. With the exclusion was with a SOFA score more than 12, and pregnant women, patients who transferred in from other civil hospitals, and patients who were on double vasopressors. The result was that out of 25 patients, 82% of the patients were benefited from this nutritional support, and however, 18% were given nutritional support in the same way, but due to the poor outcome due to other comorbidities and the conditions, they were more susceptible to mortality. So, aggressive nutrition therapy brought faster recovery in patients with high risk of malnourishment with the Nutrix score between 5 to 10. And the statistical evaluation with ANOVA tested the association with the socio-demographic data and the nursing interventions. Despite this, some delays to enteral nutrition are always happening in our critical care setups, and this we can be recognize this and we can advocate that these patients have to increase the visibility of enteral nutrition. And in the clinical practice, it's very relevant because these findings demonstrate that enteral nutrition is often prioritized lower than the other competing care needs in the critical care ill patient. Now, mostly it is agreed that enteral nutrition was an important aspect. However, it was acknowledged less because other aspects of care were prioritized more highly. So, in this way, a nurse-led nutritional plan to be made and followed strictly. This emphasizing the priority of early nutritional support with a multidisciplinary team may be the crucial key for successful provision and tolerance of nutritional support. So, early enteral nutrition, a way forward. So I just would like to say that with this, I come to the end of my presentation. So these enteral nutritions can be early started and initiatives can be taken with a good Nutrix scores, and assessing the Nutrix score of the patients accordingly, it can be calculated for the patients.
Thank you,
sir.
Lieutenant Colonel Yamuna, for the nice presentation and finishing it in time. Just one comment.
Yes, sir.
Because of the exclusion criteria is included, the sample size, I know it is small because
Yes.
of the exclusion criteria.
Yes, sir.
Maybe you can continue the study and
Yes, sir.
make it. I open the talk for the floor. Any questions from the floor? Sir, Amit sir. Sir, no.
So my question is,
Yes, sir.
how often at your center you are doing a PEG?
Pets are a patient who is for a longer care, like in we have combatant casualties get evacuated to our hospital. So they have a longer duration in our place. So maybe the rise to feeds we continue for 2 or 3 weeks. Then we find that it's for a longer time, then we go for PEG. So
Okay, thank you.
yes, sir.
Dr. Amit Agarwal sir.
It's a very interesting concept actually nowadays, that it's very nice to know that all our nursing colleagues, they are doing a very good job. How do you identify the algorithm, or you have any algorithm that how you will identify that this patient's nutritional needs, and then what kind of intervention, and how you want to continue once the patient is being discharged, go to the ward or to the community, back to home?
Yes, sir. So, in the critical care setup, we identify them because those who are on a mechanical ventilator, we identify that their nutritional needs are more because they have to fight with the infections and everything which they are. So, according to their daily recommendation, we calculated the protein intake and the how much over the micronutrients, and including the vitamins, everything is calculated accordingly. And as you asked that how you identify once they go to community, there is a newer concept which is called a nutritional rehabilitation. So it comes like spices, like what all you can do as a nutritional rehabilitation once this traumatic brain injury patients goes back home. Maybe somebody sir asked me about the PEG, so it can be continued in the home setup also. So we make a dietary plan for them as per that. Like if it is a rice to feed, it's for 2 hourly if you are covering it. So then how many scoops of proteins you need to be? So one protein scoop contains of 30 gram protein, sir. So that much protein, so 60 kg if you take a weight of the patient, 60 into 2, so 120 grams of protein is required for that particular day. But only thing, we also see that the Nutrix score of the patient, that is calculated from 5 to 10, sir. So if it's more than 10, then that is considered that you need to aggressively treat them. And there are something called interleukin test which we do. So Nutrix score, when you calculate it, it can be with an findings or without also. So in our hospital we are not doing interleukin, so without that we are doing. So this planned program is done on a patient, sir. So as I said, the nurse-led nutritional program is this. So you are deliberately making an attempt to look into the nutritional aspect of that patient, calculating how well this can heal that patient. So,
Thank you.
Thank you, Dr. Yamuna. Oh, question? Please make it quick, please.
thank you so much, sir.
Thank you. But just one more question.
Okay.
I'm Ahmed Al-Fay from Egypt. I just want to ask about the high protein diet.
Yes, sir.
Does it matter for the patient of vegetative state of coma? Because as you know, these patients usually by time they get cachectic and the muscle wasted. So if the high protein diet, does it matter for this wasting, or they also need physiotherapy to make it more?
Yes, sir. High protein diet matters for a patient, but only thing over feeding of high protein, when it is given to some patients, they can go into renal impairment. So you need to monitor along with that all the parameters of the patients when you are planning like this 2 gram per kg body weight of protein. But protein, because in an ICU setup, they go into muscle wastage, sir, and it is said that ICU developed muscle weakness of the patient. So many of the researchers have said that these all these critically ill patients over a period of time they go into. So you need to consider giving them 2 gram, but you can start with, because they go into refeeding syndrome, you can start within a lower dose, that's 1.2 gram per kg body weight, and then over a period of time it can lead up to 2 grams.
Thank you, Dr. Colonel Yamuna. I now invite Dr. Manoj
Thank you so
Agarwal.
much.
He'll be presenting on a prospective study of novel therapeutic targets, interleukin-6, tumor necrosis factor, interferon as predictive biomarkers for the development of post-traumatic epilepsy.
Good morning, everyone. Myself, Dr. Manoj Agarwal from RML Hospital, New Delhi. We are going to present a prospective study of novel therapeutic targets. As already So introduction is 5 to 7% of traumatic brain injury patients reported at least an episode of seizure. As post-traumatic seizures classified in 3 groups: immediate seizure within 24 hours after injury, early seizure within less than 7 days after injury, and late seizure 8 days and after the injury. Our first study have narrowed that definition as immediate seizures occurring within minutes after injury, and late seizure to as late as 1 month after injury. And the morphological and the biological changes causing hyperexcitability and epileptogenesis, risk of recurrence after a single late post-traumatic seizure is more than 70%. Single episode is sufficient for the diagnosis of post-traumatic epilepsy, and the risk factor, we already know that severe head injury and certain type of brain injuries. Post-traumatic epilepsy, 20% of symptomatic epilepsy is in the general population, and first episode of seizure occurring within first year of injury. The objective of the study, to study the age and sex distribution of post-traumatic epilepsy in our patient population, to analyze the results of cytokines like interleukin-6, tumor necrosis factor alpha, and interferon gamma levels in the blood sample from our study population in the terms of serum levels at the time of injury and their association with the development of post-traumatic epilepsy. Relative sensitivity and specificity of these cytokine marker and their role as a pro-seizure or seizure proactive mediator. Now the inclusion criteria is all the patient more than 18 years of age with the post-traumatic epilepsy, patient with the close type of traumatic brain injury only, patient not on any immune-mediated treatment or immunoglobulin therapies, and patient with no history of previous epilepsy or seizure. Where's the exclusion criteria? Patient with a polytrauma, patient with a systemic disease and malignancy, patient with the ongoing fever or history of fever in recent past, patient with the penetrating head injuries, and the pre-existing cranial disease. Now, what the methodology we followed? 254 patients of moderate and severe traumatic brain injuries, in which 41 patients with the seizure episodes, 35 patients without pre-trauma seizures, and 30 adults without seizure used as a control group. Now, interleukin-6 association. Interleukin-6 levels were significantly higher in this seizure group with a mean of 121.36 picogram per ml with the standard deviation of 89.23. Tumor necrosis factor alpha levels was 11.42 picogram per ml with the standard deviation 7.84. there's no statistically significant difference was detected between these three groups. Interferon gamma, although the level of interferon gamma in the seizure group tended to be higher, with the mean value of 1.88 picogram per ml with standard deviation of 2.13 in the seizure. The median value of interleukin-6 tumor necrosis factor alpha and the interferon gamma in the seizure group was 98.70, 9.52 and 0.89 picogram per ml respectively, whereas in the non-seizure group it was 30.02, 7.43 and 0.6 picogram per ml. So now the come with the discussion part. With the initial insults of, we are divided into three phases, like acute phase within minutes to days, subacute phase hours to week, and the chronic phase weeks to months. In the acute phase, there's a modification in the receptors regulation, in ion channel kinetics, post-translational alteration to existing functional protein, as well as stimulation of immediate early gene. So these are factors which lead to the development of epilepsy into the chronic epilepsy. Now the role of interleukin-6 in our study, an increased interleukin-6 level showed a statistically significant association with the post-traumatic epilepsy and can provide a potential target for anti-epileptic medication, preventing incidence of post-traumatic epilepsy. Similar results was found in other studies that we quoted below. And now tumor necrosis factor has a dichotomous role in the inflammation. Seizure activity is mediated by the P55 pathway, whereas the anticonvulsive activity is through the P75 pathway. Balacetol in study of mice found that the protective effect of tumor necrosis alpha to cause a decrease in the seizure frequency, and this action was mediated by the neuronal P75 receptors. These are the study we quoted. Now, Grail et al. Showed that the in vitro picomolar concentration of tumor necrosis factor alpha and could trigger a P55 pathway, whereas activation of P75 pathway required relatively higher concentration. After traumatic brain injury, increase in tumor necrosis alpha has been reported in the CSF and the serum by Goodman et al. In 1990 and Rose et al. In 1994. In our study, tumor necrosis alpha level increase in the serum samples of both cases and control, but there was no statistically significant association with the post-traumatic epilepsy. Now, the limitation of this study, sample size is limited, no long-term follow-up was there, and possible impact of subclinical injuries. Subclinical or non-convulsive seizure may have been missed. The conclusion, interleukin-6 have a strong association with the post-traumatic epilepsy, and higher levels are associated with increased seizure susceptibility. Interferon gamma levels may be associated with the post-traumatic epilepsy, and more extensive studies required to prove the possible role of interferon gamma in the post-traumatic epilepsy. Tumor necrosis factor alpha levels fail to show any association with either pro-seizure or anti-seizure activity, although tumor necrosis factor alpha has a dose-dependent effect in the animal volumes. Thank you for your patience hearing, and this is a barcode. This article is already published in the World Journal of Neurosurgery, so you can go through with this barcode also.
Thank you, Dr. Manoj. Just one question from my side. Does the timing of the sample has any effect on the levels?
Yes.
Like after a few hours or at the same time you receive it in the emergency?
If we take the sample early on, there is a higher chances to, because there is an inflammation rate is very, because is the patient having the trauma and patient comes to us earlier, there is a there's a higher level of these inflammatory mediators.
And was the sample taken after maybe 72 hours or was it included?
Few samples was taken.
Okay. I invite any questions from the floor. Dr. Amit Agrawal, sir, please, sir.
It's an interesting study. See, you have included all TBI cases.
Yes.
But your analysis doesn't show any cases of mild head injury. Only moderate and severe it is showing.
Yes. Moderate to severe head injury.
So we presume that there were no mild head injury cases were included?
In case of mild head injury, there is a less chances of the seizure.
No, my question is very clear. Only moderate and severe are there. No mild cases are there.
No mild cases was there.
So you are not getting any mild cases?
No.
Other thing is there are certain high-risk group cases of who has post-traumatic epilepsy. One is penetrating head injury.
Yes.
That you have excluded.
Excluded.
So the next question comes, did you correlate with whether this interleukin was increased in those high-risk group cases or any other than? So because the imaging finding severity is already a marker for prognostication and the prediction of PTE. So what new the IL-6 will add?
So this is the limitation of the study. We'll definitely work on it.
Unless we take that, because if you can tell that IL-6 is associated with this, so rather than going for a biomarker in peripheral or where the resources are limited, we can use the clinical marker and we can justify scientifically.
Yes. Thank you.
Thank you, Dr. Manoj. There's one more speaker. Maybe he hasn't arrived. Dr. Saurabh Singh. I think we'll end the session now. Thank you.
Department of Neurosurgery, Gujarat Cancer and Research Hospital, Ahmedabad, and a consultant neurosurgeon at the Sterling Nidhi and BAPS Hospital. The experts for this session are Dr. V.S. Mehta, Chairperson, Neurosciences, Paras Hospitals, Gurugram, and Dr. Andrew Reisner, Professor, Department of Neurosurgery and Pediatrics, Emory University School of Medicine, Atlanta. I request Dr. Nikhil Modi to please take over the proceedings.
All right, very good evening, very good morning to everybody. Dr. Andrew Reisner is about to join over here, and we have legendary Dr. V.S. Mehta, sir. The basic idea is to draw some tinge of knowledge or experience from such a senior neurosurgeon. So we have some young brigade over here. So my role would be to synchronize bilaterally. It would be exchange of knowledge more from this side to that side, from the stage to the juniors. I would request anybody to share his experience or to ask any question related to neurosurgery, be it trauma, tumor, or experience, whatever problems is you encounter in your daily practice, be it at government setup or any institute setup, any trust hospital, any corporate. So it would be fascinating to get his answers. Anybody? Remember, it will be a golden words from Mehta, sir. Yes, please. Can somebody offer him mic, please? Please introduce yourself in one or two lines.
Myself, Dr. Mayank Sinha, neurosurgeon, and I passed from SMS Jaipur. Sir, my question is, what are the minimum equipments or things required for a young surgeon to establish a good neurosurgery in their hospital departments?
So to answer this, I would first suggest that anybody who has passed out MCH or DNB, he should not immediately rush to the practice, independent practice. It's always better that he does few years under supervision, because till yesterday you were not doing an independent surgeries, and next day you start independent surgeries. So first is that you should spend some time with some experience neurosurgeon under supervision, and once you do that, then of course the minimum requirement of surgical all depends on what work you are going to do it. Suppose you are doing only head injuries, then the requirement will be different. But if you want to do vascular surgery or brain tumor surgery, brain tumor also, which type of cases you want to take, so the requirement of equipment would be entirely different. But during training, I would suggest that you should expose yourself to the microneurosurgical training as well as endoscopic neurosurgery training, so that whenever you have opportunity to do the microneurosurgery, you should be able. Because today the neurosurgery without microneurosurgery is not possible. I mean, you will not be able to get all the result which you want. So that is what I would suggest. As far as equipment is concerned, of course, the essential equipments are, because today, unless you are in an absolutely remote area, you need, without that, suppose you don't have a CT scan, how will you do the thing? you don't have a cautery, you have a microscope, you have a bipolar cautery, you have to have a CT scan, you have to have ventilators. All those facilities has to be there. Without that, it's very difficult to do a neurosurgery. Because today the days are very bad. And if you don't have those facilities, then it is better to send the patient to the higher center. Then you treat under no facilities or under facilities, and then you produce harm to the patient.
Thank you very much, sir. Yes, may I invite few more questions? I can see a lot of, bunch of enthusiastic upcoming neurosurgeons.
Can I ask a question?
Yes, sir, please.
Dr. Sridhar is very senior neurosurgeon.
But I'm still learning from people like you.
Your learning never stops. Yes. At any age, learning continues.
Sir, would you think that in the current scenario, it is essential to have exposure to endovascular training for neurosurgeons?
Yeah, I very strongly feel that, in fact, I have written one of the article also in Neurology India, the requirement of hybrid neurosurgeon. So I very strongly feel that neurosurgeon, those who are interested in vascular surgery, they should take the neurointervention as well as surgical. I very strongly feel. Because we have seen many a times, of course, that's also true that one become an expert by exposing himself to the same cases. But once you don't know the surgery or you don't do the surgery, you always become biased. So you always go to an intervention procedure and don't do the surgery. So therefore, if you have knowledge and experience of both, it is always in the better interest of the patient that a hybrid neurosurgeon should be there.
Yes, yes, sir.
Good morning, sir. I am Dr. Sumit, and I'm from.
Sir,
Gurgaon.
no need to introduce yourself, sir.
Thank you so much. So, I am among the very few who have had a distinct honor and privilege to be trained under this legendary neurosurgeon. And I happen to live in the same era as he is walking on this earth. Sir, for all the last years of my training under you, I have been hearing from you quite a lot of wisdom words, which I try to imbibe in myself and grow myself into practice. One of which was a good surgeon should know where to stop. So, sir, this I may be still learning as to where to stop, and how much is too much, according to you, and what message will you give to me and to the audience here, sir, regarding this?
So I have always said in neurosurgery, when to stop, when not to do, and how much to do. If you know these three things, you should not harm the patient. That is. So sometimes we have to take a decision that you don't do anything. So, for that, a clinical examination and clinical history taking is the most important. Sometimes you start investigating and treating the investigation and not the patient. A patient is asymptomatic and your lesion is non-progressive, and you also think that it is unlikely to progress, don't do anything, you just keep under observation. As far as next, that when you are operating, when to stop, I think that comes with an experience. But wherever a surgeon feel that I am going to produce a harm to the patient, I think there you have to decide that I should stop. But sometimes, now for example, my policy in high-grade tumors, glioblastomas, I will not be very radical in these patients and produce a hemiplegia or hemiparetic patient, because his life is limited for, say, a few months. And if I make him hemiplegic, but I remove little bit more, what I am going to get? Nothing. I will produce probably a a patient who was walking, I make him vegetative or hemiplegic, and he survive for a few weeks more. I don't think I'll get an advantage of it. But suppose it is a meningioma, it's a benign lesion, and patient is a young person, then I would attempt that I would do a complete excision. Because he has a capability that if I give a time, he is likely to improve over a period of time. But in glioblastoma, there is no point of doing it.
Noted, sir. Yes, anybody?
Thank you, sir. I'm Sir Dr. Jitin Bajaj. I'm from Jabalpur. I've been fortunate to have good mentors like Professor V.D. Sinha, Professor Y.R. Yadav. I have been trained in All India Institute also. So what I have seen is a good institute is formed by good people. Now, there are many departments in the country where there are some problems. Now, neurosurgeons have an inert sense of rush, urgency, type A personality, and they don't lack inertia from other departments or other allied departments. Now, how do you make a good institute for yourself?
I think very good question. See, you should always be complementary to each other and not competitive to each other. Once this feeling comes that you are competing with each other, I think that destroys the department. You should be complementary to each other. That's the most important. Similarly, usually we hear when there is an interventionist as well as neurosurgeon, they try to see that, okay, this is my patient, I should not give it to him. And this is his patient, it should not be given to him. I think that it should be the best interest of the patient. What is in the best interest of the patient? You either take a combined decision or unilateral decision, but it should be in the best interest of the patient. And sometimes you discuss with your competitors and take a conscious decision which is in the best interest of the patient. If you have this feeling, I don't think there will be any problem. But once you start competing, then the problem arises. So don't compete. It's a complementary to each other.
Good morning, sir. I'm Dr. Sarang Rote from Pune. I wanted your opinion about the status of neurorehabilitation in India. Status of neurorehabilitation in India. Are we up to the mark?
No, I think we still need a lot of development of neurorehabilitation. Still, even in the best of the centers, we don't have all those facilities which is required. And it needs to be aggressively developed, no question about it. So whenever I say to the students that how do you develop the expertise? You choose the one department or one subject which others are not doing, and then go on doing work in that, and you will develop that specialty. So suppose you are interested in neurorehabilitation, don't think, initially you will find the problems, but after some time you will develop expertise and develop the specialty.
Thank you, sir.
Max Meter from Germany. May I ask to this, contribute to this discussion, since I'm working also a little bit in neurorehabilitation, although I'm basically, of course, a neurosurgeon. What would you think from your Indian perspective? What is the best way to do it? Send patients, once you have done acute surgery, send them to a specialized neurorehabilitation unit somewhere, or would you prefer, as neurosurgeons, to have neurorehab in your center integrated? That's totally up to the
Yeah,
discussion.
absolutely correct. And of course, during the acute stage, it should be inbuilt. Once the acute stage is over, then it could go to separate rehabilitation centers.
Okay, so you would prefer to send them somewhere else?
Yes.
Okay, thank you.
Thank you for this excellent session. I had 3 questions. I'm Partho Rai, neurologist, Kolkata. The first thing was basically, I attended a morbidity mortality meeting in a major center in India very recently, and compared it to my experience somewhere outside Bharat, for many, many years. And I found it to be very neutral, very educative experience, where there is the scope for having lots of different specialists who have treated the patient unsuccessfully or suboptimally, share their experience and take it as a learning experience. What do you think? Should we be rolling out morbidity, mortality meetings in non-academic and in corporate private hospitals as well?
No, I'm not. I think we should look back at all cases which have complications.
Yes.
And you see, you always learn from your complication and not from success.
Yes.
And if you recognize your mistakes, then only you can learn.
Yeah.
So it's always better, whether within the house or outside the house, that is your prerogative. But you should look back your complications, always, and remember them. First, you identify those complications, and then remember it, then only you can correct next time.
Yeah.
It usually happens in usual practice. If any complication happens, you try to pass the buck on somebody else.
Yeah.
Never do that.
Yeah.
Look back and find out where did I made mistake so that I can improve.
Yeah.
If you try, or no, it was because of anesthetics or because of this, or no, that's not.
If it's held in the whole unit with all the members who have participated, so that others can also learn from my mistakes.
Absolutely.
And don't repeat it.
That is what I'm saying. That depends on your
no blame culture.
Your people are competitive or complementary. If they are complementary, you should include them, because sometimes the mistake which the others can recognize, you may not be able to.
Absolutely.
Because you always see that, oh, I have done my best. I can't be wrong.
Yeah.
Which others will say, no, this is the wrong. You should always take the opinion from others. If they are friends, your friends.
Well, they are my colleagues.
Yeah.
We are all after the patient's best
Colleagues
interest.
should be good friends. That's most important.
It's professionalism.
It is the colleagues only who harms you most of the time.
Okay. Professor Weissner has some questions. I'll ask my 2 questions next.
Good morning.
It's not working, sir.
Good morning.
Yeah, we can.
Good. First of all, I apologize for being late. I was sending over the school kids on a
walkathon
program walk, so my apologies for being a little late. And thank you. It's an honor to be here with you, and an honor to be here with you. Do you mind if I answer your question for 30 seconds, 2 minutes?
Oh, please do.
I will get to it. You know, here's the way I would answer the incredibly important question that you asked.
Thank you.
When I train residents and fellows and somebody else, and I look around me, I look for partners, what is the number one characteristic that you want? Of course you want somebody to be particularly skilled, who's hardworking, but for me, the number one is honesty. Honesty. You're probably going to say, just what are you talking about? I mean, of course, if you're honest, very few of us go to rob banks. But the honesty I'm talking about is the honesty with yourself. With yourself. And you just need to be honest with yourself, especially in times when you've made mistakes. And certainly, M&M is a good forum to, if you like, confess or own up to mistakes, or discuss your mistakes. And I really believe that we're all humans, we're all going to make mistakes. We all carry our complications to the grave, and Lord alone knows I've had my fair share. I think it's okay to make a mistake, kind of okay, not good, but that's part of being human. What's not acceptable is you keep on repeating the mistakes, and the only way you will not repeat mistakes is if you're honest, especially with yourself. Get your ego out the door, understand you're not doing it right. You may need new training, you may have not paid attention. Whatever the cause is, just don't make those mistakes again. And M&M is a wonderful forum for cleansing and just reforming your honesty.
and progressing the department's activities. Thank you for that, sir. The second question was that, sir, you just mentioned about different treatment modalities, like, endovascular treatment versus open surgery for an aneurysm, for example. I take the most basic, there's some gray areas, and I've seen that regularly being discussed between interventionalists and my open surgeons. And you mentioned about the best outcome from the patients, and in a self-paying situation like we have in Bharat, there's always a payment quotient that gets added in to the factor of decision making. So should we be adding, when there is a intervention being planned, be it open, endovascular, or whatever, the patients or the patient's advocates in the decision making process, and we put up the data of success of surgeons? Because in another country where I have practiced once, they used to have a sort of a batting list of the surgeon's current operative rates of success, how many operations is done. So it's a transparent process whereby the public knows that Mr. XYZ has done these procedures and these are the options. So that's a very hard thing for anybody to declare. So do you think, as a part of credentialing or quality control, that could be something that could be considered? And I invite both professors to comment.
What you are saying is probably maybe true within a lot of experienced people.
Okay.
But those who are newcomers, they will talk of the literature only.
Right.
Because they will not have the experience. So it should be number one, as I said, a combined decision, what is in the best interest of the patient. And he should be given whatever the literature available, all positive and negative points of the treatment. And then patient has to take a decision.
Or the patient's next of kin in the circumstances.
I agree, and I don't have much to add. I think the patient should always be involved in these decision-making as they can. Obviously, there are times that they cannot, for example, acute setting in the emergency room, and just your basic training and principle will guide you. But yes, there will be qualifications for any decisions that you can.
And the last point I'll raise, leave the floor to others, was the rehab. And I'm surprised that even in Germany, there seems to be a shortage of rehabilitation. I, as a neurologist, and you as a neurosurgeon, know that we can't treat and cure or get the patient to the right level of functioning by our interventions or by my medicines after a stroke or what have you, multiple sclerosis, Parkinson's. But neurorehab is rarely taught to us as part of our training program. We don't have access to those very crucial facilities immediately post-op or immediately post-thrombolysis or thrombectomy that we're doing. So how to integrate these services as part of the regime of post-operative care? And we are not, again, neglecting it like TBI has been for 40, 50 years. We discussed that yesterday. But I accept there is a problem with manpower, person power, and we are very much reliant on our allied health professionals, physio, occupational, cognitive, speech and language therapists, and that often reduces complications like, aspiration, pneumonia. So should we be inducting those trainings into a surgical program, as I'm doing for our neurological program to NMC, and encouraging neuro-rehab people to stay back in Bharat and not scoot away to elsewhere? That again is the problem. So neuro-rehab is important as part of the treatment spectrum that surgeons offer and certainly neurologists offer to our patients.
So neuro-rehab itself is in a subspecialty.
It's a separate specialty,
of a neuroscience.
Correct.
And of course, basic idea, you can have it as a neurosurgeon or a neurologist, but you have to develop as a subspecialty. And it has to grow significantly in our country. Still, it is lacking. Still, a lot of things are required which are not available or not practiced.
Thank you for taking time to answer my questions. Thank you.
Good morning, sir. Sir, myself, Dr. Manoj Agrawal, working in assistant professor in RMS Hospital, New Delhi. Sir, I want to share my experience in a case and I need your opinion also.
Please speak a little louder. Please.
Hello. So, sir, a 40-year female came to us with no comorbidity, came to us with a complaint of frontal lobe signs, and there's a right side weakness with a power of 4/5 with a 6 months duration of the GTCS also. So, we did investigate her, and we found there is a left frontal subcortical intraaxial lesion On the contrast, we get a interaxial lesion, which is ill-defined lesion, basically. So we make a diagnosis of left frontal space occupying lesion, mostly a high-grade glioma, sir. So we did a lesionectomy of frontal lobe science, and we discharged the patient on post-op day 7 with a acceptable neurological deficit, sir. So she able to do her routine work, and after the 14 days, we get the biopsy of the grade 2 lesion of glioma, sir. So we sent in for the adjuvant therapy. She completed her 20 cycles of the radio chemo. So after the 6 months of duration, she again came to us with the same complaints, like right side body weakness again, and there is an apathy and agitation also. So we investigate again, and we found there is a new location lesion, which is now the lesion is well defined, attached to the falx of anterior side, sir. So we plan again surgery, and we excise again the whole tumor, and we suspected this time this is maybe a radiation-induced tumor, or so we excise again the tumor, and now the biopsy came, sir, anaplastic glioma grade 3, sir. So again, patient discharged with the acceptable neurological deficit. Now again, the patient is able to do her routine works and all. So we again, so after the 6 to, and now this time patient came to us after 1.5 years, sir. And now in 2023, we investigate again, and now the patient having bilateral hemisphere supratentorial lesion, which again the well-defined lesions. So now the patient came to me with the power of 3/5, sir. So now I'm not able to understand what abhi mujhe kya karna chahiye, sir. Why need, so I need your opinion in this case, sir.
So I think the first biopsy should be reviewed. First biopsy is probably wrong because it doesn't happen in, sometimes it can happen that there are sampling error. The tissue which you have taken is probably not the representative slide of the actual tumor. So now the patient has come after 1.5 years, and I want to see the exact location of the tumor, because 1.5 years is a good time.
Yes.
If it's still resectable, one would like to resect it.
Thank you, sir.
Yes, please.
Good morning, sir. Sir, as you are the people who will be guiding us and
Please
making the
introduce
guidelines.
yourself. Please introduce yourself.
I am Dr. Gaurav Jain, sir, as Associate Professor working in SMS Medical College. So the question and my request from you to give us the guidelines also. In neurorehabilitation, so TBI and other spinal injuries always has some morbidity left. So neurorehabilitation is a very important thing which is needed post-surgery or even in conservative management. In India and other socio-economically less developed countries, there's a question of economics there. And working at SMS, we did a study in which we included the family members who were the primary caregivers because they couldn't afford a neurorehabilitative center. So this led to decrease in the cost, because one is the cost of the treatment, other is the loss of the professional income of the patient, and the other third loss is the loss of the family income, because the other person who is going to work has to take care of the patient. So we drastically reduce the cost by teaching and making the bystanders and the caregivers understand neurorehabilitation. And why can't we include the teaching program to them also, sir? Like we in our small study did. We also published a chapter with Dr. V.D. Sinha sir and Dr. Amit Agarwal sir as a neurorehabilitation book with economic dynamics in neurorehabilitation. And we found that the cost was reduced drastically, and it came to 40 to 50,000, inclusive of the income of the poor man who is in the towns. So your comments regarding
So
that?
I totally agree with you till we have those facilities and of course the affordability in which in our country it's an important factor, because you can't take out the money and make the family hungry and do the rehabilitation. So ultimately, who is a physiotherapist? Is a person, human being. And if you can teach the human being who is his relatives or attendant I think it's absolutely correct. No question about it. And that is what normally we practice. And sometimes a family will probably do better physiotherapy and rehabilitation than those who are professionals, unless really good professionals are there. Otherwise, they just do khana purti, what we call it.
Also, the cost incurred by the government of India by the road traffic accidents was 12.5 lakh crores. This was the cost estimated yearly in the stats of 2017. So that's a huge economic loss, and
absolutely,
with this we can reduce it.
Absolutely.
If I could just add,
please.
I agree with what you said. Even in areas where neurorehabilitation is available, and just by the way, it's sparse and it's just the need is not met in high-income countries as well. But even in hospitals that are fortunate enough to have a rehabilitation centre attached to it, the family is key. And so the philosophy that you are espousing now about the family and the community getting involved in rehabilitation is sound and is valid, whether you've got a good facility or not, they need to be part of it. So I just wanted to make that point to you. So agree with you and more.
Thank you, sir.
It's better to remain full for 2 minutes rather than to be full throughout the life. So please, last opportunity as we are running short of time. Yes.
So I'm Dr. Deshmukh. I'm from Pune. I work in a private hospital. We have a DNB program. So
Please speak louder, sir.
So I'm associated with the DNB program since last 2 decades, and now I'm guide for last 8 years. When we gave exam, and right now when exams are done, I have a feeling that exams have become more lenient. Like we see candidates which are not up to mark. Even our candidates, they are getting through in one attempt. And I remember I was grilled by Dr. Mittal thoroughly. So is there a policy decision or a political decision? Why is it happening? Because ultimately it trickles down to patient cares, largely in the society.
But it is we neurosurgeons have to be blamed for it, not the government. Because it is it also depends on what was your training. Like those who are examined today, how they have been trained, how they have practiced, they will take the same exam. If they were not trained well, they will take the similar exam.
But this has happened very recently, and I mean there has to be some policy decision. Like
no,
we need
policy,
more neurosurgeons.
Policy decision.
Pass anybody.
Policy decision ultimately it boils down to the neurosurgeons, isn't it? Policy you make, but ultimately if you are not doing the same, then it will be a problem.
For mid-level neurosurgeons like us, we always think that people, stalwarts like you, Dr. Bihari, Dr. Sinha, you are in the policy making.
No, it's not mistake of policy. That's what I'm saying. It is the policy. Nobody would say that it's not in a policy that candidate who does not perform well, pass him. No, never. If an examiner satisfies that he has done well, then you pass. Now it happens. Sometimes I myself experienced one those days. That when as external I would say, no, he is not fit. But as the internal would say, no, sir, he does our all work, he is good. This type of compromise should not happen. Then you will have that is the fault lies in us only, not in the policy.
Thank you, sir.
Agree. So we are closing the session. And thank you very much, Dr. Andrew Reisner and Dr. V.S. Mehta, sir.
Thank you for this wonderful session. Thank you, Dr. Sinha, for inviting us for this wonderful session. Thank you.
Thank you so much.
Thank you.
So thank you, Dr. Nikhil Modi, for that session. We now move on to the next session on epidemiology, legal aspects of traumatic brain injury, and organ transplant. The chairpersons for this session are Dr. Sixto Ordono, who's presently the head of section of neurosurgery, Philippines, and Dr. Amit Agrawal, from Department of Neurosurgery, All India Institute of Medical Sciences, Bhopal. I request the chairpersons to take their place, and I hand over the proceedings to the chairperson to take us through this session.
This would be Dr. Y.S. Poon from Hong Kong talking about the ethical issues in modern neurotraumatology. Dr. Poon, please. How about the other one? Okay. So, if he's not yet around, can we have our next speaker, Dr. Manish Sharma from Jaipur? He will be talking about brain death, certification, and InGen scenario. Dr. Sharma, please. He's not also here. I think for the sake of time, I might as well be the first one to take a crack at the lecture.
Please, you start.
Thank you, sir. Hello. Hello. So good morning to all of you. Today I'm going to talk about the uncommon neurotrauma cases from my country, specifically from the northern Philippines. So as you can see, from the Philippines, the cases that I'm going to present now will be coming from my country, and now here we are here in Jaipur. So this is our map. The gray with the blue arrow there represents the place where these cases came from. It's a population of 5.5 million. It's around 300 kilometers north of Manila. In our country, this is the place that I'm presenting to you is a surfing capital of the northern Philippines. And if you're going to look at the slide on your right side, this is the usual scenario when it comes to holidays and weekends. We have a lot of local tourists, international tourists with the locals. And with all the merrymaking around, this is a very good recipe for neurotrauma. And in fact, this place was once the host of the surfing competition during the Southeast Asian Games, 30th Southeast Asian Games. And this is the hospital where the patients are coming from. It's the Ilocos Training and Regional Medical Center. It's a government hospital, and by law, it should be taking care only of 400 patients. But in reality, we're taking care of 800 to 900 cases. So with the anatomy or with the nature of the place, it's obvious that 70% of our admissions are trauma in neurosurgery. So let's go to the first case. This is a 34-year-old male, and a spear accidentally hit the patient. He's a fisherman by profession. Physical exam, the patient was a bit tachycardic with preferential movement on the left. Of course, the CT scan showed hyperdense metal artifacts in almost all the cuts. But on the skull X-ray, you could already see I'll just move fast. You could already see that the tip of the metal has almost transected the whole part of the brain, but the more important one is the notch there. So in the OR, we planned the probable trajectory of the spear because it's really impossible to take it out from the point of entry because of the notch. And this would be the BJO. During the time we started removing the spear. And lucky for the patient and lucky for us, there was no gross bleeding during the axial extraction of the patient. So immediately post-op, these were the pictures. And lucky again for the patient, there was very minimal intraventricular hemorrhages and also very minimal subfrontal frontal bleeding. And this is the patient 24 hours post-op. I don't know if you could hear the local language in our place. It's an Ilocano language. So it's obvious that there's paresis of the right extremities. But but before the discharge of the patient can now walk on his own. So let's go to the next case, a 27-year-old male single at the ER, normal vital signs. There's a 4/5 right lower extremity, and there's a metal that is embedded in his skull. And on the skull X-ray, it's now obvious that this metal has transected the skull layer and including the dura. Again, metal artifacts, but it's obvious that the brain parenchyma is injured. This is another part of the CT scan. This is the skull images of the patient. And the more important one will be the CTA, and it's obvious now that the mid 1/3 of the superior sagittal sinus, or the SSS, is injured. And we measured the depth from around 5 to 6 centimeters from the tip up to the inner layer of the skull. So this case now, we did craniectomy, 2 centimeters around the foreign body, 2 units of blood given, hook pre-incision, and post-op another 2 units of blood transfused. And this is already the scalp closure that we did after the surgery. And again, it's obvious that there's a weakness in the right lower extremity initially. Again, it's the local language, Ilocano language. We're not able to totally close or blur the face of the patient. So now let's go to the third case, a 32-year-old male single. 2 years ago, had a motor vehicular crash, and this was sutured from a lower level hospital. And you could see there the scalp hematoma. Then the patient lost to follow-up. The wound was claimed to have healed, but after a few months, granulation started to grow over the scar. It was non-healing and rapidly growing, hence the consult again and readmission. And lucky for the patient, a plain CT scan showed that the tumor did not penetrate the skull grossly, including the brain. And this is also with contrast. Again, the skull looks clean grossly. A biopsy was done. It revealed squamous cell carcinoma. Metastatic workups were negative. Intraoperatively, just to be sure, we did a frozen section, a wide excision, and the finding was grossly the outer table of the skull was not involved. So this is now the picture of the scalp pre-op. So we did the excision, we're able to remove the tumor, and then with the plan of closing it after several weeks, we started to do, we did burr hole to the spongy layer of the skull. And then 1 to 2 weeks, it started to granulate. By the 3rd week, it has complete granulation and the patient is ready for skin grafting. The donor site was the patient's thigh. So this was 1 week after the skin grafting, and this was prior to discharge. 5 years down the road, there's no noted recurrence, no noted metastasis. We also have other uncommon cases there, like this young girl with a knife embedded in her right cheek, and the skull x-ray, you could see that the tip has almost reached the foramen magnum already. And lucky for us and for the patient, we were able to remove the knife. And this was the picture post-op, few hours after extraction of the knife. And she went back to school technically or by PE normal. And this is another case. There's simply, the only thing you can do here is that debris and then resuture the face. We also encounter some hacking wounds. Some survive, some don't. And also some vehicular accident. This is a boy wherein a wheel ran over his head. And there are also moments wherein we have to do this kind of incisions for a better decompressive cranie. I think that's all. Thank you.
My name is Ahmed Al-Fay. I'm from Egypt. I want to ask about the first case with the metallic dart, where you pull the dart from the back. Do you face a CSF leak from the entry point? And if that happens, what will you do? Do you re-explore the base and close it again? Or because I have one experience like this with a pen for an infant, and when we pulled it out, we have a lot of CSF coming down, but it stopped likely after 2 or 3 days. So do you have that experience in that case?
Okay, number one, for as long as there's no hydrocephalus, I think majority of these cases will heal or the leak will stop by itself. Number two, you should have a very good closure for this. And sometimes you need a fascia or a periosteum to cover the point of entry or the point of exit. And if it won't stop and you repeat a CT scan, there's not much hematoma, there's no hydrocephalus, we put a lumbar drain for at least 3, 4, maximum of 1 week. And most of the time they are successful. Anything, sir, you might add? So, no more question. Again, for the sake of time, we need to go to my former colleague. Actually, it's not a former colleague, former batchmate when we graduated in the Philippines. She's Dr. Aline Lourdes Lucena, and she will talk about establishing a neurotrauma society and how to create awareness in neurotrauma. More than her credentials, actually, for those friends of Dr. Lucena, in our country, she's the youngest boarded female neurosurgeon.
Okay. Okay. It's a pleasure again to be back to Jaipur. Thank you very much, Professor Sinha, and the organizer of this ICRAN. And thank you so much, my batchmate. You always flatter me. Thank you. So I am here to talk about establishing Neurotrauma Society in the Philippines. So disclosure. This is my institution. I'm in the Bicol region, and I have a very active volcano on the background. And this is a tertiary hospital. So despite all the advances that we all have in neurotrauma, we still lack, especially in the Philippines, we lack a lot. We don't have a neurotrauma registry. The pre-hospital emergency services are not that good. You know, all these things, that acute treatment has not been really protocolized or anything else. And we all know that neurotrauma is a global health problem. In fact, 11.8% of total global disability in adjusted years according to WHO. And again, it's the leading cause of death in disabilities, especially in people younger than 40 years of age. And 50% for severe injury, they will suffer from 80% mortality for severe TBI in 1950s. It has decreased actually in the last 5 years. But then again, if you take a look, the highest and lowest proportion of road traffic accidents and TBIs are in African region and Southeast Asian region, and lowest is in the United States and Canada. So in the Philippines, we are now currently with 117 million, 2023 estimate, 13th most populated by density. And we have an archipelago of more than 7,000 islands. So we don't have that recent data. So I'm presenting here that from 2006 to 2015, there was a 45.76% increase of deaths from road crashes. So what, with this scenario, it's a global health burden. Around the world, there has been a lot of brain injury awareness, programs to address this in other areas, in other countries. But in the Philippines, we don't have that thing, as I've told you. It's all in one institution or the next, you know. And despite the fact that we all know the effects of traumatic brain injury is not just physical. It's not just physical, it's behavioral and also cognitive. A lot of people, especially relatives and even young doctors, do not comprehend yet this scenario with traumatic brain injury. So now, with these physical complications, of course, we address it with physical therapy, occupational therapy, and neuro rehab. And also behavioral, there is already what we call cognitive therapy. But that is not known in other areas in the Philippines. I mean, maybe in the tertiary hospitals in Manila, in the National Capital Region. So recognition is very important. But then again, how will they recognize if they don't have yet the education and the training and the awareness? So how can they seek help also if they don't know where to seek help? So sometimes, if I'm the neurosurgeon, if I treat my patients, of course I know it. So I sort of institute to them, for example, the rehab at home exercises, behavioral. I will advise them family support and therapy, play therapy, voice therapy, and also neurocognitive rehabilitation if available. So being alone, me, a neurosurgeon, what is the advocacy for neurotrauma? I cannot do it alone. I mean, I cannot address everything alone. So it has to be a multidisciplinary and a team effort. So with that team effort, I became the chair of the Asian Australasian Society of Neurosurgery Neurotrauma Committee. So with that, I started the first Philippine Neurotrauma Boot Camp in the Philippines. This is the module. So we had everything from pre-hospital, acute care in the emergency room, critical care, and even on the neuro rehab side. This was a 3-day thing. And so we had everybody, EMT, then internal medicine, neurology, and rehab. So this was a sample of the module. We even had breakout topics and focus group discussions on the combat and mass casualty, because we held this in a region south of Manila, meaning that the southern Philippines, there's a conflict area there. So we had to discuss also combat and mass casualty. So there's first responder EMS protocol and also first contact physician management protocol, and even the nursing aspect. So with this, we had published this already in the World Federation of Neurosurgical Societies newsletter. And as you can see, Professor Sinha and Professor Punya were our guest speakers. Professor Sinha here is demonstrating the the egg. You know, like if you break it without any helmet, that's how you're gonna crack your skull if you don't have a helmet. So it was a big hit with all the participants. So this is some shots of the neurotrauma bootcamp. So with this, the virtual attendees, actually, we got 1,052 unique viewers from days 1 to 3, with most of them coming from Vietnam and the Philippines. It was broadcasted in Southeast Asia. The top 6 specialties who attended were GPs, nursing, pediatrics, neurosurgery, general surgery, and neurology. So the speakers, as I mentioned, included Secretary General of the AASNS, Dr. Virendra Sinha, and Chief Consultant Neurosurgeon Dr. Nemichan Punya. So Dr. Igal Sushan, the chair of the Education Committee, also gave his lecture virtually. Professor Kate Drummond also personally welcomed the attendees to virtual platform. So lecturers were all fellows from the Neurosurgical Society of the Philippines. So what's next? There has to be more boot camps. Actually, we are holding another boot camp this May 1 and 2 in the northern Philippines. They're actually the host, Professor Ordonio and others. So, and then after that, if we keep on doing this, this has to be sort of an advocacy. So we are establishing the Neurotrauma Society of the Philippines. And we will have a website for education, awareness, and advocacy. We will tie up with other neurotrauma societies, in particular Neurotrauma Society of India, and participation in conventions, advocacy videos on road safety, policies on neurotrauma, and guidelines for local government and other sectoral involvement. So it will be from injury to recovery, a multidisciplinary team approach that will comprise the Neurotrauma Society of the Philippines. So cooperation embodies the means to solving any problem we have, the resolute endurance to resolve. So with that, thank you for your kind attention, and invite you all to the 18th Asian Australasian Conference in May 2026 in Manila, Philippines. Thank you so much.
Thank you so much, Dr. Aline. I think I could see the time. There's still 3 minutes left. Please, sir, you have the floor.
Thank you, Dr. Lynn Lourdes Lucena. Very good lecture.
Thanks.
I'm Partho Rai, neurologist, Kolkata. 2 questions. One, statistically, 29% is the least amount of road traffic accidents in the Americas. One of your slides showed, and 34% is the maximum. I'm just wondering how surprised I am with the only 5% difference between the highest levels of RTAs leading to TBI and the lowest levels. Any comments on that?
Now, what happened now is we don't have a lot of data yet. So I'm presenting like a very old data from the Philippines. That's one aim that we will have for this Neurotrauma Society is we need to have a neurotrauma registry.
Yeah.
We cannot rely on the road traffic institution or something like that.
Yeah.
So I just got it from what we have on the web.
Yeah.
So
it looks too close for the highest and the lowest
I don't
percentiles.
think it's really that that much.
Yeah. Moving on to the next question, since neurotrauma is actually a societal problem, I was just wondering, with countries like India and Southeast Asia, which is having about 60% of the world's population, as part of the AOCNR, Asia Oceania Neurorehabilitation, which is also headed by Joy, who is our president of the society.
Yes.
Whether we should be digitally enabling our populations to carry forward the neurorehabilitation for the better outcome in the longer term, because I don't think any country in the world has the adequate number of professionals to provide them with the services. As long as we signpost our population and the caregivers and the partners to proceed with well-designed, functional, realistic applications on their smartphones, that will make a realistic difference. What is your comment on that as part of the societal development?
I think that's a very good point and a very good suggestion that we need to take up those kinds of more. You know, like, for example, the Asian Australasia Society, since we are comprise a lot of the neurosurgeon member societies, we need to promulgate this kind of advocacy, not just in my country, but over all these areas.
Southeast Asia, yeah.
Yes.
Asia, Oceania.
Yes, yes. Asian, Oceania, Asian,
60%.
Australasian.
Thank
Yes.
you. I wish you luck and we'd like to collaborate.
We will make it one of the projects.
Thank you for
so
making it
much.
happen. Bye-bye.
Thank you.
Thank you, sir. Yes, sir. Go ahead.
Hi, Igal.
Hi, thank you. this neurotrauma bootcamp. I think it's a beautiful initiative that you and your colleagues started last year, and I hope that will be a continuous tradition. My question is, how much is the government of the Philippines is involving in terms of financing, in terms of supplying what you need, and in terms of public awareness for that? It's just an initiative of you and your colleague with local resources, or the government really support it?
So yeah, that's the purpose. We have the neurotrauma boot camps, and now we are raising the awareness. So we are establishing the Neurotrauma Society of the Philippines to connect with the Philippine College of Surgeons. They are now aware of this. I have brought this to the Philippine College of Surgeons, which is actually the one accredited recognized, an umbrella society recognized by the Department of Health. And this is very timely because the Minister of Health right now is an emergency trauma surgeon. So we will bring all these things. I mean, I can already present something. You know, we have this neurotrauma, and this is the result. Blah blah blah, and then we can have now a neurotrauma society, and I can present all these things to him. I hope we will have very more. As you can see, the policies that we would like to propose. For example, some insurance for these neurotrauma victims. We don't really have that. So I think this is a long-term plan.
Does the Education Ministry involve in this program?
Now, the Education Ministry, not yet, but the Ministry of Health. We will already present this to the Minister of Health because he is an emergency room, and he was one of my mentors when I was in the Philippine General Hospital.
Thank you.
Thank you so much, Iga. So it's up.
Okay.
I think there's another one. Just one.
Just a quick thing. Wonderful initiative, Dr. Lin, for starting this Neurotrauma Society in the country. And my specific question to you is, it's a serious problem to get the government to agree to collaborate in these initiatives. So how do you plan? Because if we talk about our situation, the major problem is how to enforce the government people, the people in charge, to direct the society and to take it further forward in terms of legalization of the things that you decide as a society, and in terms of enforcement.
Okay.
So because any type of guideline you make, it is ineffective unless until a legalization and enforcement is there. So how do you plan to take it up with your government?
Yeah. So that's a very good question. That's why the neurotrauma boot camps is now it's just an initiation from the Asian Australasian Society and the AFN, which is the Academy of Filipino Neurosurgeons. But as I tell you, we raise money from the start, and also we contact our partners, so they support us. But how will we take this further? So now the Neurotrauma Society of the Philippines, as an outcome of these things, we are establishing it, and we are actually launching it with the website, and we are partnering with the Minister of Health, and we will show them if we have a society, then you can actually have a more powerful stand to present, especially that you now have data. We will use the society to gather data to start a neurotrauma registry, and we will partner at the same time with the Ministry of Health. So I think it's a little bit one step at a time. We cannot do it really fast, but I think it's getting there. At some point, I may report again in the future what we have achieved. Thank you so much.
Thank you so much, Dr. Alain. So we go now to our next speaker. I hope I pronounced the name right. Dr. Krish Sridhar. Okay. He is a group mentor in neurosciences, Director, Coveri Institute of Brain and Spine, Coveri Hospital, Chennai. He is the Honorary General Secretary of the Neurological Society of India, and he is also the Chairman, Healthcare Committee, India Chamber of Commerce in Tamil Nadu. Dr. Krish, go ahead. Thank you.
Sinha, for having me here. So once more on trauma. So I think the slide is not showing completely. Excuse me, slide pura nahi dikh raha hai. It is the top half of the slide is cut off. So my topic has now changed. Sorry, I've been beheaded. You want my laptop? Yeah, that's better. So the purpose of this talk is to look at whether we can create a standardized trauma care delivery, what are the possibilities and what are the challenges. But to understand this, we first have to understand the trauma burden. And I think Dr. Lin has already spoken a bit about this, that this is the first cause of death between the ages of 1 to 46, and its huge effect on economy. Whether it's in the US, anywhere in the world, there is a huge effect on economy. And almost 5 to 6 million trauma-related deaths occur every year, with 40 million people permanently injured and up to 100 million people temporarily injured. Now, the important thing is that 80 to 90% of these occur in LMICs. But the issue is that whenever these data are presented, there is a zone out amongst many people across society. And that, if you remember Phil Collins' song, is Just Another Day in Paradise, we often shy away from the fact that this is a major pandemic. A study performed in Uganda showed that a person with a simple closed tibial fracture takes up to 3 times longer to get back to work than somebody similar situation in the US. And within 6 months, the children of that man were out of school, and up to this affected almost 30 people in that family. And that is the burden of a single closed tibial trauma. The causes of trauma globally, road traffic accident is the maximum, and 1% of the world's vehicles cause 13% of all deaths. And most important, no reduction from 2013. And it's a worsening situation. We expect this to rise up in the causes of deaths or disease in 2030. In India, statistics from 2022 from the government show that there has been a total of about 4.6 road accidents, claiming about 1.6 lives and injuries to about 4.4 persons. But very significant is that it is not on the national highways or expressways or the state highways that maximum accidents take place, but in the other roads. And that is something which is very, very critical to our understanding about the care delivery. Of course, it is an increasing trend, including the percentage of people killed per accident, the only dip happening because of the COVID pandemic. Overspeeding happens to be one of the major causes of accidents, but you also have other smaller causes like driving on the wrong side, drunken driving not being so important. So what are the challenges? The most important, I think, is diversity in capabilities, geography, and socioeconomics. India is a vast country, for an example, where the terrain itself is different from one region to the other. The number of neurosurgeons available across the world is diverse. You don't have a uniform distribution of neurosurgeons, neither in the world nor in India. If you look at rural development in India, this map shows that there's a variable development across the country. And therefore, what applies to one part of the country may not really apply to another part of the country. Resource constraints, manpower, infrastructure. These are all issues we all know exist, but nothing really changes over a period of time. We also just now spoke about social awareness. That is something we as a society need to look at. we as a body need to look at, and we need to increase social awareness. Because in society, it's a not me syndrome. It won't happen to me, it'll happen to the guy next door. And that needs to change. Politics and regulations. We had the helmet rule in Tamil Nadu made mandatory in 2018, as late as 2018, but still there are press notes saying, people please wear helmets. You need to have proper roads made. Intersections must be made properly. And most important, medical legal aspects. Who should operate on a head injury in the periphery? In Dubai recently, in a meeting in Australia, from Australia, I don't remember whether it was Kate or Sarah, they spoke about a situation where in a remote area, there was an EDH which had to be operated. There was a general surgeon there, but he was not accredited to do the surgery. So what do? Do you fly that person down 200 miles? Advocacy needs to happen. And like you said, we have to make the government aware of this. And I'm happy that there is an additional health secretary going to speak after me, and I hope that they take it up seriously. The WHO and the UN are trying to make efforts. There was a decade for road safety in 2011 to 2020, but nothing happened. So now they made it again up to 2030, where they hope to decrease the effects of road accidents by at least 50%. In the first decade, they had one of the 5 pillars of our road safety as post-crash response, which basically meant a standardized response. But nothing happened. But what has been shown in certain areas, like in the UK, where a national program started in 2010, the probability of surviving a serious injury is better today than in 2009. And the NICE guidelines provide such a guideline, which has been developed for health practitioners and other health allied workers, which says that by encouraging uniformity of care, both mortality and morbidity will fall. And over the last 25 years, this has shown to be effective. You also have the WHO Emergency Care Toolkit on the website, which is meant for resource-constrained hospitals to use. Even the US is trying to get a uniform model trauma care system. In India, we have had the national guidelines. I think Dr. Sumit is going to speak on that, which is brought out by the Neurotrauma Society along with the Neurological Society of India. And very important are these words from the preface by Matthew Joseph, who's also going to speak, is that the most available protocols advise on ideal treatment only, which is perceived as complex and intimidating. We need to encourage even the smallest hospital to perform life-saving interventions, because that would mean a stepwise reduction of the complexity of the interventions. Though these guidelines may be criticized as accepting a lower quality of treatment, we feel that given the vast size of the problem, it is important to provide patients with whatever care is possible in the current scenario until the overall infrastructure is improved. And I think this is a very, very, very important step which we have made in India. Another important step is development of a standardized ambulance service which has come out from the government of India, which is 108, which in most parts of the countries is a very, very effective ambulance service. We need to make sure that this is the sort of trauma-centered development which happens. The level 4 and level 3 are what are important to deliver the standardized care of treatment. The apex trauma centers should be only few in number, and that only is an apex where the most complex problems are treated. But we have to concentrate on the level 3 and the level 4. But why are the numbers not showing an improvement? Because the standardized and systemic care is seen only in pockets. It's not seen everywhere. We need to overcome the issues at each region. It has to be a regional focus. And we need to understand the local need and adapt. One place cannot say that the same thing should be followed at another place. And therefore, I think we need to treat it like a pandemic. We did this for COVID. I think we need to do it for trauma. Let's take action today and let's not shy away. We need to educate, empower, endorse, ensure, and engage. We need to standardize at the macro level, but we need to adapt at the micro level. Thank you very much.
Thank you very much, sir. Go ahead, sir, for the
Thank you very much for an excellent talk, very practical. I think we need to develop a paramedic training program, accreditation, and, on the coalface, as it were, to develop as first responders in any major emergency. As the Neurosurgical Society of India editor and the part of the, hierarchy, what is the NSI doing in regards to developing a paramedical service which will be the first responder, provide the first management for cervical spine injuries, head injuries, because that's where we doctors won't be going, and that will be the golden hour where interventions will determine triaging as well as first treatment. What's your response, please?
Okay, now the Neurological Society of India has a brain trauma initiative which is headed by one of the executive committee members, and we look at various aspects of trauma. There is a EMT society itself.
Emergency medicine, yeah. No.
Not the emergency medicine. The EMT people themselves have a society association. So we are trying to talk to them to look at how they are doing. By the way, the 108 ACLS ambulances have excellent trained EMT people. It's not that they are not trained. So I think we have to be very careful when we say we want to train you. I don't think that's, we should only see whether they are fulfilling their objective.
Right.
And that's what we are trying to do now.
The first, yeah. Thank you very much for that.
Thank you very much, sir. Thank you very much. Oh, sir, excuse me. I think there's another one.
Okay, sorry.
Yes, madam.
Thank you very much, sir, for giving me the time at the end. Dr. Sridhar, I'm amazed as a layman that road safety figures so much in neurotrauma specific conferences. Though as a layman and working in the field of road safety, I do understand that there is a close connection. But sorry to say, we have the health secretary sitting here, that the health department, the laymen, and the general public do not see the connection between neurotrauma and road accident. Road accident, WHO says, is a health issue, but it is not perceived as a health issue. It is not perceived as a health issue, and there are no specific, help in terms of economic help, rehabilitation, and so many issues which I, as an NGO working in the field, do perceive and see that the connection should be there, but it is not there. So how do we establish that? And it's wonderful. Your lecture was wonderful. This conference is wonderful. So how do we establish this connection? WHO keeps saying it, but nobody bothers. The government, at least in India, doesn't see the connection.
I think that there are two aspects to this, madam. Can I just take a minute, please?
Yes, sir.
If you ask me, there are two aspects to it. One is to understand and make the government understand, and that is why I said advocacy. It is important to make them understand that the problem is as big as the COVID pandemic. So we have to treat it like a pandemic. A pandemic means each one of us is involved, is affected. So that is the first step. So if we make the government understand that it's a pandemic and there is a loss of economy and GDP, that's when they will wake up. Let me be very frank, I may be not politically right, but nobody cares. If, we say that the quality of care, that's all blah, blah. We have to talk to them in the language which affects them. And that is when we say it's a pandemic, there is a loss of economy, there is a loss of GDP, and that's the language we need to take to them, number one. Number two, I do not think that they are not aware, because there is a lot of, I showed you the statistics which I got from the Government of India, publication 2022, and there's been a huge amount of effort which has gone into that. And it also, this is a 10-minute talk. I mean, there is a lot of information on how this is being planned. The trauma care centers which I showed about in the 1,400 kilometers, how they should be established, is also from a Government of India publication. So it is all there. But I think the last mile has not been covered. That is the implementation of all this with society's involvement in this is what is not happening. And that is where I think that all of us need to come together, look at it like we did during the COVID pandemic. I think India did one of the best things in the COVID pandemic, and I'm so proud of ourselves of how we handled our pandemic. So we need to treat it in a similar manner, and I'm sure we will make great strides. Thank you.
Thank you, sir.
Good morning, everyone. Good morning, sirs. And I'm sorry to disappoint Dr. Sridhar and also Vidul ma'am, because the original speaker, Health Secretary Madam, could not make it. And but we do assure you that the very important critical points that were raised concerning the policy will be communicated to her by my organization, Mohan Foundation Jaipur Citizen Forum, which works for the cause of organ donation. We'll be talking about the donor perspective. And in this, I will also be weaving the story of the journey of organ donation in Rajasthan. I believe that, like any other human being, we all also see our today and we plan our tomorrow. In India, of course, you've got children, so you make the property accordingly. You'll think about selling a home if you need it, for their education, for their weddings. Abroad, people say, oh, one child, you start thinking about college education, school education, how are you going to save for that? But I believe, and I'm a spiritual person in that sense, that I believe that God sees our tomorrow and plans our today. I was a talk show host on television when I got the chance to interview Bhavna Jagwani. I'll be calling her on stage to share a story. And the cause was eye donation. That was the year of 2011. And that is when I joined her, totally submitted to the cause and to her commitment to it, to join the cause of eye donation. Learned it from scratch. As medical advancements grew, Rajasthan grew, the eye and tissue donation cause was widened to include organ and tissue donation, which is exactly what Mohan Foundation, Jaipur Citizen Forum works for now across platforms with training doctors, hospitals, and the government coordination also in Rajasthan. I, along with my team members, counseled people, trained doctors, and fortunately for me, grew very well in the knowledge field of organ donation. In 2018, July, my 33-year-old son, at that time he was 29, today he's 33, was diagnosed with kidney failure. So suddenly the statistics come home. Suddenly all that data, it becomes, who you are. You're just one of the many. And we went through everything like everyone else does, because this is India. So we went through all the temples and all the prayers and all other things also to our deities. But I think that everyone does. We turn to prayer when we seek this. And then the doctor advised that either we can go in for a preemptive transplant or we can go in and start the dialysis. Because God had seen my tomorrow, what I would be required to do. On the 16th of August 2018, He prepared me well when I started working for this cause. And it was a very, very easy decision for me to decide to donate one of my kidneys to save the life of my son. We had the surgery on 16th August 2018. As you can see, I'm absolutely fit and fine in front of you, and so is my son. The cause has not just given me my son back to me. it has also given us a reason for living. As a donor, as a living donor who gives to a family member, we all know that it is something which gives a daily value and meaning to your life. But Mohan Foundation, Jaipur Citizen Forum has worked extensively for deceased organ donation. The figures of trauma are right in front of you. I do not need to talk about these, not at such a platform. Our idea, our bridge, our request, our submission is that once the trauma has occurred and the brain death has been certified, then the families should be counseled to come in for organ donation. Before we turn to dust, be cremated, or be buried, let us take this chance to save other people's lives. The challenges are many. The brain death certification itself is a challenge. The counseling, telling the family members about the brain death is a challenge. The counseling is a challenge. But I think nobody knows challenges better than this team of excellent doctors that I'm addressing today. And during this journey, Mohan Foundation, Jaipur Citizen Forum, branched out, reaching out to colleges, schools, hospitals, court, bar associations, any and everyone who would listen to us with one appeal, that let us all become aware about organ donation. And as we also start minimizing the number of accidents and the deaths, that remains a very core part of our awareness sessions. We should also reach out to those in need so that at least nobody dies waiting for an organ while we burn the rest of them to ashes. I'll close with a small story. I don't have any PPT or presentations or information to give you. There's nothing we can tell you. We can only appeal to you. My story is of a living donor. But there are many lakhs and lakhs, as you're well aware, where the family is not able to donate. There are no matches, there are other problems. And for them, the deceased organ donation program comes as life itself. And today I would like to invite the convener of MFJCF, Bhavna Jagwani, on stage. And in a very brief, we would like to share the story of Mohit, a 7-year-old child who is the first organ donor of Rajasthan. Information and facts you have. We are only here to tell you a story.
Thank you, Dr. Sinha, for giving us this opportunity to talk about the importance of brain death and organ donation. So I also have my own personal story. I lost my vision, and that got me into starting the eye bank in Rajasthan. Later, while I was in the mortuary and I would look at the eyes being retrieved, I would just think of all the organs that were getting burnt through the mortuary. And I used to think of my father, who was 45 years old, and he was going for a kidney transplant to London. And en route at Beach Candy, we lost him with a heart attack. I was just 14-year-old, and so I understood the importance of getting a kidney, a heart, a liver in donation. So that was my journey that began in Rajasthan. But today I'll just share the story of Mohit. So 10 years back when we started organ donation, the first case was of a small boy, he's a 6-year-old boy named Mohit. So Mohit was a very naughty child, and he used to go to school to study. But he used to trouble all the children around, but he was the teacher's favorite because he used to, in India, the government schools, the children only have to sweep the floors and clean the floors. So when he would sweep the floors of his classroom, so he was the teacher's favorite. After that, adjacent to the school, he had his father's farm. He would go and help over there. And there was a big thrashing machine. There was a big circle that he used to stand on the stool and cool it with a pipe because the machine used to get heated. So he would stand on the stool and cool it with a little pipe. It was winter. It was 5th of February, and his red jacket got stuck in that thrash machine, and he was spinned 6 times before the machine was shut down. And then obviously he was declared brain death in the hospital, and we were called to counsel. And the 35-year-old father was sitting on the floor, and we were trying to tell him what is brain death. We had Dr. Chris Berry from America who had come here to teach us about organ donation, transplant. So he could not communicate in the local language, and I was sitting there and talking to the father. I tried telling him that your son is no more, and he could live in others through so many people. But he could not understand. Eventually, I thought, he will slap me or something, so I was ready to get up and go. But he said, sit down in that local language, and he said, I understood what you said. If we cannot get him back, might as well let's save somebody else's life through him. So that was how Rajasthan had the first donor, a 6-year-old boy. It was very heart-touching, and so what I'm trying to say is that in this day and age when we are recycling plastic, wood, cloth, everything, but we are burning away the most precious things that are life-saving, that is organs. And the primary role in the whole thing is the neurologists, the intensivists. If they can identify brain deaths, this will bring a change and save so many lives who are waiting every day. At least 10 people are dying waiting for organs. In India, our organ donation rate, transplant rate is 0.6. And we need at least to go to the rate of 2 to be little self-sufficient. During the time when Dr. V.D. Sinha was in SMS hospital, the number had drastically increased because he would identify brain death. And so the program had picked up very well. So champions like him are what we need in every state, I suppose. Thank you for giving me time. Thank you.
Thank you so much. I'll just take a minute more and share another part which Bhavna has shared personally with us over the years. When Mohit was cremated and his family, they came home after the cremation, his kidney and liver was donated, but his parents at that time said no for the heart. They said, we'll take the heart back. And when the parents came back from the cremation, they gave a call to Bhavna and they asked her. So Bhavna said, I was very scared that maybe the people in the village had said something. But their only point was, I wish we had given Mohit's heart also. At least it would be beating somewhere today. So organ donation is the light at the end of the tunnel. It's a ray of hope. Thank you. Namaskar.
Thank you very much for that. It is something which is really important. I am from Tamil Nadu, which runs a very robust brain death and organ donation program. And I completely understand what you're saying. And I think the rest of India has to wake up to this call. And this is my appeal to everybody here. Because yes, there are challenges in brain death certification. There are societal stigmas. There are a lot of issues, but we have to do it. We have to keep trying. And I'm telling you, what happens after that, we move away into the background as neurologists and neurosurgeons. because we cannot get involved, but we see it from afar. And that is really fantastic. Thank you very much.
Last few words. I come from Rajkot, Gujarat, and as you said, organ donation. I come from the corporate hospital by name Wockhardt Hospital. Now, in my career, I have seen many hospitals, but I think this is the only hospital who actually forgives the bill, complete bill, if a patient is ready for organ donation post-head injury. I have seen people whose bill is 10 lakh and the hospital has forfeited completely nil. So the people who cannot afford, they also at least, we don't do anything much for them, but at least we can do something from as a hospital side or from the doctor side to at least reduce our bill, our part from their segment, so that at least they can be promoted and they can be pushed for at least organ donation. Thank you.
Thank you.
Thank you, chairpersons. The next session is on the TBI guidelines. And the chairpersons for this session are Dr. Hemant Kumar Bhartiya, who is the Director and Head, Department of Neurosurgery, Fortis Escorts Hospital, Jaipur, and Dr. Hiroshi, who is the Director, Department of Neurosurgery, Sendai City Hospital, Japan. He's also a clinical professor in the Department of Neurosurgery, Tohoku University School of Medicine, Sendai, Japan.
On national TBI guidelines.
Okay. A very good morning, everyone. And at the outset, I would like to thank the organizing committee of ICRAN and Professor V.D. Sinha for giving me this opportunity to present my work and introduce to this audience about this specific and wonderful thing that has happened over the last half decade, national guidelines for traumatic brain injury. So although 10 minutes, it won't be enough, but I would like to sum up and summarize as quick as possible about how did they came into effect into our country and what does it all say about it. And before I start, I would like to mention that this booklet, which encompasses the comprehensive version compiled by the Neurotrauma Society of India and endorsed by Neurological Society of India about 3 years back, this is uploaded on the website of Neurotrauma Society of India for ready reckoning and ready referral by any neurosurgeon or general surgeon working in the country. No disclosures. This has been amply cleared by my previous speaker since morning. Our country is the trauma capital of the world, and this is a menace which our society is seriously facing right now and has to be quickly and urgently dealt with. This is what we expect, and this is what we have in reality, actually. And this is quite a severe mismatch between the resources and the patient load as far as the current scenario about Indian neurotrauma is concerned. And this is what the financial obligation is. As you compare the finance budget of the countries like US and our country, it's a meager 2%. 2% of what the US government spends over in the health budget as compared to what our government spends over this. So, I mean, this is what the constraints are, both resources and organizational. There are at places which are very, very few across the country where there are good ER facilities, good CT scans, ICUs, state-of-the-art, good neurosurgery services, OTs, but they are very, very few in number, mostly expensive and have limited admissions. And however, if somehow the people come into them, they are overwhelmed by numbers. So there is a suboptimal care during the admission, suboptimal discharges happen, and most of them, they are already packed and full. And at the other spectrum, there are basic medical services, variable resuscitation. There is no neurosurgeon in the house. There may not be any ICU. So there is a quite discrepancy in the healthcare providers as far as especially neurotrauma is concerned in our country. At one end of the spectrum, these are these fancy-looking hospitals, corporates, big multi-billion-dollar corporates. And at the other end, this is a meager-looking, pathetic, so-called multi-specialty hospital in our country. India lives in 2 centuries simultaneously, especially the pre-hospital care and the in-hospital care is concerned. And in neuro rehab, which we are talking about since morning, there is absolutely none. So this is the state of affairs, and therefore, there was a need to develop India-centric guidelines. About the nation-centric guidelines, there was absolutely no role of fancy-looking guidelines which cannot be followed in a country like India. And this vision was first laid down or understood by none other than Dr. Matthew Joseph, who happens to be the president of Neurotrauma Society of India at that time. And we sat down together with other people also from America, as I will shortly come, and they were the Association of Neurosurgeons of South Asian origin, AASNS, and they happened to be in collaboration with them and developed these, brainstormed about these guidelines, and then developed about these guidelines, not on the background and the principles of Brain Trauma Foundation. We understood that it was a developed country, it was a developed nation at that time, and those guidelines can never be followed in the country. However, there was an impact of those guidelines, and we wanted that impact to happen upon our India-centric guidelines also. So, in December 2016, it all started. There was a huge meeting, several brainstorming sessions in New Delhi with their office bearers, out of which the most prominent ones were, I have to name here, Professor Jogi Patisappu from Florida, Miami, and none other than Dr. Raj Narayan, Professor Raj Narayan, who happened to have played a crucial role in developing the Brain Trauma Foundation guidelines in US back in 90s. So with their mentorship, we sat down, and a couple of people here I can see sitting in the audience as well, Dr. R.C. Mishra, Dr. V.D. Sinha, Dr. Vara Prasad, and came up with this version after multiple revisions and versions and multiple revisions. And this is, I would recommend this booklet to be read by every neurosurgeon at least, and every general surgeon. And this has been scrutinized multiple times. 4 versions have been come up, and this is the 5th one, and has been edited, and not only edited, has been scanned scrupulously by none other than Professor P.N. Tandon himself. And you can see in his writing, this, I put it on record purposely, he has written notes about the corrections to be made in these when the book was in the upcoming proof stage. So what it is all about, I have 3.5 minutes left, so I have to be quick. This gives about the guidelines about the pre-hospital care, about the hospital care, and the neuro rehab in our country. So about pre-hospital, I cannot, of course, lay down everything what is written here in this booklet, but the essence of it is there has to be defined qualities of the EMS staff who can determine the presence of TBI, who can dispatch the highest level of care to the scene, who can be trained accordingly, who are highly skilled, and especially most important is who are trained for appropriate referral of the neurotrauma victim. Now, the in-hospital guidelines, as Dr. Matthew Joseph said in his preface and what his vision was, it is not necessary that you have to provide the highest level of care. No, because we know that the highest level of care is definitely not available in 100% of the centers in India. So what is more important is give that care that is available at that place where the patient is managed and seen the first hand. If the ventilator is not available, no problem. Establish the patency of the airway by local methods. I'll just come to it. So the guidelines, the in-hospital guidelines were divided into 2. We divided the level of the centers according to this schema. Like the level 1 center, it has to be state-of-the-art, perfect. It has to be around the clock CT scan, neurological and neurocritical care, everything. The neurosurgeon is there, and it has to deal with severe TBI. Please do not waste the workload and the manpower dealing with mild head injured patients in these level 1 centers. And the level 4 center was the basic level, the basic facility available who can deal with the mild head injury patients, but for the severe and the moderate head injury, they need to be referred to a higher center if appropriate referral system is there. Similarly, intervention, diagnosis and intervention. You need not to have a state-of-the-art facility for diagnosis. For example, in the airway, judging the patency of airway, how can you decide the airway is not working? You need not have a fancy instrumentation for diagnosing that. Just talk to the patient. If he does not talk, if he has a noisy breathing, if he has an obvious facial injury, there is an impending or threatened airway obstruction. Diagnose that. So you have to have these flow charts, and this booklet is full of flow charts which can help you in diagnosing and working through the flow of this airway, breathing, and circulation, how to diagnose and how to treat this threatened airway. Talk to the patient. If he answers, the airway is secure. If he does not answer, give him a jaw thrust at least. Remove the foreign body. Perform an oral suction at least. Insert an oral airway. Oral airway is available in every hospital. Insert an oral airway. If it is also not there, then there is a provision. Turn the patient semi-prone at least. Turn the patient semi-prone. If there is a noisy breathing, significant blood in the oral cavity, then at least if you can't intubate, do a cricothyroidectomy and connect at least a high flow oxygen, which is available in every hospital. So these are simple stuff which are there in the booklet, which are there in the guidelines for the people to follow. At least correct the ABC. This is the holy grail of managing a critical neurotrauma victim. Similarly, guidelines for rehab. I'll take 30 seconds more, sir, please. The guidelines for rehab, absolute astute need to develop the neuro rehab centers in the country. We have none. Believe me, we have none. So, addressing the gap, each level 1 TBI, we recommended should have integrated multidisciplinary inpatient rehab services, recommended for level 2 also. So the take home is, the guidelines have seen to reduce TBI morbidity and mortality. We need India-centric guidelines. We have developed these guidelines for the pre, in, and the post-hospital care. And these are simple and easy to adapt guidelines, which are based on availability at hand. Howsoever, there is a need for the pilot projects with Indian guidelines, which are going on at several centers nowadays. And the biggest lacuna, which I was also mentioning in the discussion session, was liaising with the government, which is, I'm sorry to say, which is really, really lacking. And this is the most important aspect of any guideline to come into force. And I'm very, very hopeful from the point of view of Neurotrauma Society of India, from Neurological Society of India also, to have some sort of liaising with the Government of India officials so that this program runs through and our country gets good neurotrauma care. Thank you so much.
Thank you so much. We will ask the questions after the whole speakers have already spoken. And then for the second speaker, Dr. Abhi Agarwal from Bengal, will talk about the guidelines so it will become practice respect.
We will be discussing about the challenges what we face. We are closely working with Professor Sinha and Professor Rubiano, and we had very good discussions yesterday with all colleagues where Professor Resner presented the challenges what they faced when they were starting to implement the guidelines in US. So the challenges are not only that low middle income countries, or the challenges doesn't know any barrier. They are omnipresent. We all know this slide for introduction that TBI is a challenge and it's gradually increasing. So let's see who all the stakeholders when we prepare guidelines should be there in the system. So center is the patient who sustained injuries, and there are some healthcare providers in various forms, and somebody has to pay for it, and somebody has to help to make policy and to implement policy. So whenever we develop guidelines, we have to integrate and involve all these partners from scratch till we get the outcomes. It's a slide what came out after yesterday's discussions, where everything is centered around a person. who is in the society. When it comes to the TBI, this person becomes the patient. And this person is an integral part of the family community, which goes to the healthcare system. And this healthcare system, when he sees the person as patients, turn into pre-hospital, hospital, and post-hospital scenarios. And when this person come in contact with the healthcare providers, then it can be primary health center, community health center, district hospital, hospitals, or teaching institution. So our intention to develop guidelines first that this person should not become patient. If he becomes patient, then he can come in contact with the family, community, or healthcare system at various points. Suppose a person falls at home, the family becomes the first responder or whoever is near to them. So when we develop a guideline, we have to integrate the entire system and make recommendations so all of them can participate at various levels, and these are being discussed in detail. It's just a graphical presentation. When Dr. Sumit has very nicely told, there are basic things, there are intermediate things, there are advanced things. We have to identify essential things at all levels. Suppose if it is level 1, it is a basic system, but there are certain essentials things like maintenance of airway, maintenance of breathing and circulation, A, B, C. And this replicates at every level, where essential will remain same, only the advancement will increase. It may start from the basic care, then it's a neurosurgeon, then CT scan and ICP monitoring and many other things. These are very well integrated in the existing guidelines. So next question comes, do we have guidelines for low and middle income countries? There are enough guidelines are there and continuously evolving. Then what all issues we are facing? I will be leaving certain questions for discussion where we can have more discussions. So if we have guidelines, so after having guidelines, why still we are presenting guidelines, not the impact or results? And today also we are just discussing what all guidelines are there. By this time we would have had the results of those guidelines, what challenges are being there, if it is being implemented, what is the outcome, if it is not being implemented, what are the challenges we are facing, and can we improve or continue to develop guidelines without implementation unless we implement and do a pilot what already is being started. So we have to wait for the interim results to understand what all challenges we are facing. Not only in our country, we are working with Colombia and many other countries to understand how they are able to implement and what all difficulties and how they are making the stratified approach. So there is an ongoing debate, the disparity between countries with a high burden of TBI and those in which of the most research is concentrated, high income versus low middle income countries. Let's see how can we further expand this debate. So the question is it same? High income country has unlimited resources, low middle income countries have limited resources. I would like to put a question, it's always a stratified thing. In high income countries, there may be a stratification of the resources where all the resources are there and where the limited resources are there. In the low income country, there may be resources and there may be no resources. So we have to define those things and allocate the resources, and where the resources are there, we have to get the experience from those places and go to a lower level to provide the optimal care. So in summary, we have to identify the stakeholders and their roles and responsibilities and define and fix the measuring points. If this person has to be in the system, how we are going to make him answerable. Classify each step, what we have to develop, formulate and validate guidelines as per local needs. That may differ from region to region. Formulate strategies for delivery, i.e. implementation, periodic evaluation and continuous research to better understand the needs and rectify the shortcomings. Comparisons across the region, including periodical updating of the guidelines. it is needless to say whatever we do, unless we develop enough preventive strategies and preventive programs, this burden will keep on increasing burden in the society. Thank you for the opportunity.
Thank you, Dr. Agarwal. The last speaker is Dr. Rajesh Chabra, and then we will have discussion and question answers.
Good morning. Thank you, organizers, for the opportunity. Basically, I'm here to discuss the problems, challenges, and solutions in the Apex Trauma Care Centers of India. So, geographically, in the Northwest Zone, PGIMR is one of the biggest high-volume center for trauma. So, as previously have shown in the different slides, but unfortunately, as we know, we are one of the leading nation in number of cases and deaths per year with increasing trend. But if you go by the data, that is not the same. So the data are limited on the aspects such as demographics, cause, severity of injury, process of care, and the final outcome of the injuries. So data are missing in terms of admission, discharge, and Glasgow Coma Scale. So we have not a registry system for all the trauma patients. So that's why the problem of implementation and the uses of resources and what are the problems we are facing, how to allocate the budget and how to optimize our the resources as per the requirement. So if the Planning Commission of India estimate the total societal cost of injury in India to be approximately 3% of the Indian GDP, which is quite a significant number. The low and middle income countries, which bear approximately 90% of the total burden of the injury. According to the budget estimate for the fiscal year 2020, about 1.35% of India's GDP was spent on public health. So the burden of trauma is more than even the percentage of budget which we uses. So in the Indian scenario, the incidence rate is around 455 per 1 lakh population, 9 million people affected, but epidemiological data overtly insufficient. In India, the current data on the demographics, cause, severity, care, and outcome of injury are not well documented. So leaving the government with insufficient data to guide policy decisions. So number of deaths and injuries are not enough to formulate injury prevention program. So there is urgent need to develop these hospital-based registries in every hospital. So this present study, which was done in PGI, is a prospective registry-based observational study in this this tertiary trauma care center, and it presents the relevant epidemiological profile of large head injury database and focus on existing challenge with possible solution from the perspective of developing low or middle income country. So in this, we included 14,888 patients, trauma registry on structure pro forma, 4 years of data. In 4 years, we have registry of 14,888 patients from March 2016 to February 2020, with all the demographic details and injury data. We have a large catchment area from Jammu Kashmir, Himachal Pradesh, Punjab, Haryana, Uttar Pradesh, and Uttarakhand. So this was 90% of patients in PGI are being referred from different part of the northwest zone. So this is so mostly patients are referral patient at our center. But interestingly, if you see, 50% of the patients present with mild head injury, and only 4.4% patient needed surgery. So this is very there is a mismatch between the spectrum of patients being managed and those intended to be referred to the advanced trauma care center. So with this kind of patient spectrum, the existing resources are needlessly overburdened, and which negatively echoes the critically ill and ill patients, which definitely requires tertiary care center care. So this is very important to understand that the 50% of mild head injury patients, they can be treated at the lower centers as compared to referring them to the tertiary care centers. So if you see the time of arrival, the majority of patients came after 6 to 24 hours or even more than 24 hours. So the early referral time of arrival is still, we are lacking because of pre-hospital transportation and the facilities. So what are the challenges? So we have unwarranted overburden of 50% of mild head injury patients, and there is only one-third patient reach within 6 hours. 68% of severe head injury reaches us to us beyond 6 hours, and 18% of patient even after 24 hours. So important factors responsible for increasing secondary injuries and complications are non-availability of first aid. So what are the underlying reasons for that? Lack of appropriate workforce at intermediate hospitals, non-availability of CT scan, and absent protocol for referral. So what are the solutions? So what we think on the basis of this available data, a team-based shared responsibility is required with the delegation of certain neurosurgical tasks to non-neurosurgical specialties so that mild head injuries can be treated there and then only, and robust systematic training and competency-based evaluation for these kind of trainings is required. So one of the viable options in the resource-constrained lower middle income countries is a task sharing. So at least for non-operative head injuries. So patient referrals, that is the most important part. There should be strict trials with defined protocol for patient referral. So patients who need emergent surgical treatment or show CT scan imaging with the potential to worsen, these patients should be referred. Complex cases, polytrauma patients and critically ill patients to be referred to the tertiary care center. So that the distribution of the patient should be uniform and should be beneficial to all the patients who are really in need of tertiary care center. So if you see, we are able to admit in only 8.8% of the patient to ICU, where 30% patient needed ICU. So that is the constraint. So setting up step-down ICU facilities in peripheral hospital is another option which we have to seek. So another thing we propose is a hub and enhanced spoke model. What is that? In the existing system, the patients are being referred, every trauma patient is being referred without CT scan or CT facilities available at the intermediate level. And there is a lack of appropriate workforce at the intermediate level and unintegrated CT scan facility, and patient is being referred. At our center, there is no tab on the patients, how many patients you can take, or there is how many patients you can keep in the trauma center. So, but finally, I can say to understand the existing lacunae in the head injury management, we recommend the solutions and immense need for proposal of referring patient to a tertiary care setup and concepts of hub and spoke model, task sharing and efficient back referral systems can decongest the tertiary trauma care centers. Thank you very much. Thank you.
Thank you. Thank you, Dr. Chabra. We have a request of one more speaker in this session, Professor Dhaval Shukla, Professor of Neurosurgery in NIMHANS, Bangalore. By the time his talk is uploaded, may I ask a question to Dr. Sumit Sinha and Dr. Sridhar, they are here. Dr. Sridhar in his talk said about 23 to 30% incidence because of road traffic accident, the cases of head injury you get. And so Dr. Sumit Sinha said 60%. So what is the 30% or 60% is the... So I got it wrong maybe. Also you can highlight what is the incidence in low and middle income country and in high income country.
I am not an expert statistician to give you these statistics, so I don't know. What I quoted was the cause of global trauma, 20 to 30% is road traffic accidents, not head injuries.
And what is the incidence in low and middle income countries and in high income countries, comparatively?
I think Dr. Gururaj from NIMANS has done extensive work on the statistics part of the roadside accidents and road traffic injuries. What we know perhaps is, this is every minute a patient dies of a roadside accident due to head injury. And about 4 accidents happen in a minute in our country. So this is taken again from the statistics by Gururaj et al.
Why I'm saying this is because in the high income countries with more advancements, more technology, high speed, the incidence may go higher. But at the same time, the following of the traffic rules, discipline, and that may reduce the incidence.
I presented the data presented by the Government of India, 2022. More than 45% of road traffic accidents in India do not happen on national highways or expressways, but happen in roads which are not even state highways. So there is a very big difference in the way the accidents take place in our country compared to whatever you're saying happens in the Western countries.
Okay, so can we invite Dr. Dhaval?
Hello, good morning, everyone. Sorry, I'm substituting a couple of speakers who could not make it. And we have been hearing about guidelines. So one question was raised by somebody that are we implementing these guidelines? What we are going to do to these guidelines? So what we have done, so we have done a survey of whether other districts are prepared to take care of patients with traumatic brain injury. So this is a collaborative work between Neurosurgery Department and Center of Public Health and Department of Epidemiology and District Health Officer of district called Kolar. So why this question arose to us, there is something called secondary over-triage, where a large number of patients are literally dumped to a higher centers from smaller centers because they feel that they cannot treat head injury patients. This leads to a lot of rush in the bigger centers. And when we see that 70% of such patients who come to these big centers can be managed at smaller hospitals, so why they are being dumped to the other hospitals? So what is the reason? Are other hospitals not able to take care of head injury patients? So this was the purpose of guidelines. So the take-home message of this guideline is, first, moment you see head injury patient, in doctor says head injury patient, he says, I cannot manage head injury patients, sent to neurosurgical center. So after these guidelines, the approach should be how I can manage head injury patients with what skill I have, what facility I have. So this was the basis of this study. So this has divided in 4 levels of hospital, which Dr. Sinha already mentioned. So this was done in Kolar district. Kolar is closer to Bangalore, about 70 kilometers from Bangalore, and Kolar has become quite popular in India by a movie called KGF, because it was a legacy gold mine of India once upon a time. So our question was, how prepared are the secondary and tertiary care hospitals in Kolar district to manage traumatic brain injury patients? So that was our primary objective. And secondary objective, what was the caseload in the hospital and what were the outcomes? So this method, it was a cross-sectional study, which was done in Kolar for 3 months. And secondary and tertiary care hospitals were surveyed. And we made something called preparedness assessment score. So we made forms based on the recommendation of NTSI guidelines. So there are 4 levels of hospital, and all the hospitals available in Kolar district were surveyed, and they were graded into whether they fall into level 1, level 2, level 3, or level 4 category when it comes to management of traumatic brain injury. And we assigned scores. So the number of things required, the NTSI mentioned only 4-5 things required for each trauma center, but we added a large number of things from ISCCM and Neurocritical Care Society, and we made a scoring system, what is available in the hospital. So first is level of the hospital with the 1, 2, 3, 4, and the score, what all things are available. And this is how, so we found 11 hospitals in Kolar district which can have potential to manage TBI, and these were the scores given. So you can see it's not necessary that both level 4 hospitals have same score. One level 4 hospital had 11 score. That means that was better prepared. Whether the same level 4 hospital according to NTSI had 7 score, which indicates it is not well prepared. So there are 9 hospitals of level 4 preparedness, 1 hospital level 3 and level 2, and there was no hospital with level 1 preparedness. Level 1 hospital is Medical College Hospital where neurosurgery department is available. So there was none in Kolar district. So we estimated, depending on the survey, medical records, police data, and other sources. So Kolar district should be getting anywhere between 1,600 to 3,700 patients annually. So what should be required for such patients? So input indicators, we made that proportion of hospitals with at least 1 full-time neurosurgeons, CT scanner per lakh population, proportion of level 1 and level 2 hospital, neurosurgeon per lakh population, neurosurgeon per 100 TBI cases, and average preparedness score for each hospital. And process indicator, that number of TBI surgeries per month, TBI admissions in ICU per month, and outcome indicators, pre-hospital mortality, case fatality ratio of TBI in ER, in ICU, and referral proportion, how many patients are sent to Bangalore from Kolar. So this were our, this was the part of our phase 1 study. So this was first of the unique study which attempted surveying the hospital which can manage TBI patient based on the national guidelines. And we did content validity, so it was developed by me, epidemiologist, and we did external validation by sending to a neurosurgeon outside whether this content is fair or not. However, one limitation was that one hospital did not participate in the study, and HIMS systems were very poorly organized in these hospitals, and there was no standard format, so we required a lot of effort to retrieve the data, and the social disability bias may have been there from the administrator of the hospital. So we conclude that about 1,600 to 3,700 TBI patients need hospital care in Kolar. And preparedness is required for level 4 hospitals. There is no level 1 hospital, so it should be upgraded. One full-time neurosurgeon should. There is a medical college, but there is no full-time neurosurgeon, so should be employed there. And average score is very less even in level 4 hospitals. And input process and outcome indicators should be implemented. So we gave this recommendation to the district health officer that conduct periodic assessment and conduct regulatory capacity building programs, and advocate district administration to ensure availability of neurosurgeon on remote consultation basis in level 2 hospitals, and develop a uniform digital HIMS system for surveillance. So in morning we heard a lot about nihilism about government and all. So I'm pleased to announce that government of Karnataka has awarded 450 crore rupees for trauma management in the next financial year. So we are starting with steps. So level 4, that is the lowest hospital. So all procurement has occurred of the equipment which is required for the management of trauma. Then once that happens, then level 3 and level 2. And we have also started hub and spoke model for management of 2 major neurological emergencies, stroke and traumatic brain injury in Karnataka. And we are going to start recruitment. So 33 neurologists and neurosurgeons have been recruited. So each one will be placed in each district of Karnataka, so that stroke and TBI patients need not to come bigger cities to Bangalore, because time is important and they can be managed at that level. We published this study in one of the journals very recently. It is going to come in print. And I request all of you who are working in big cities to go to the smaller towns surrounding your big cities and see how others are prepared. And if you need any help from our epidemiology department, we are ready to volunteer. And I also take this opportunity to welcome you for annual Neurotrauma Society conference in Pune 6 months from now. Thank you.
Thanks so much, Professor Dalla. And I think it's enough time for some questions. Professor Andrew next.
I'd like to thank all the speakers for just a fantastic session and really applaud your efforts. I'm from Emory University and Children's Healthcare Atlanta, and it's basically a pediatric hospital, but the principles are the same. And I'd like to just share a mistake that I made with you so that hopefully you won't repeat them. We also developed a committee, we massaged, we developed guidelines that basically were the same as the Brain Trauma Foundation guidelines, one or two little nuances depending on our resources. And the problem was that for the first 6 months, the compliance was so low. And so what I'm saying to you, the fight that you're fighting, you have to fight with both hands. One hand is developing the guidelines, the other hand is implementing and monitoring the guidelines. Just handing out pieces of paper or announcing it on however you announce it is not good enough. What we did is we had our quality department monitor whether the guidelines were followed or not, and there was a little bit of punitive action taken to those physicians and nurses, frankly, that did not follow the guidelines. It doesn't have to be draconian, you're going to get fired, but we did point out their mistakes, and slowly but surely, the guidelines became followed more and more, and guess what? The results improved more and more as well. So just wanted to share that with you. Thank you. And thank you for your efforts too. I love the way you're allocating your resources. That's fantastic. Congratulations.
Thank you so much, Professor Dalla. I would just like to comment that, like for me in the Philippines, I'm very much interested to do something like that, like the assessment, preparedness assessment for trauma in a certain region, because we don't have that. Yeah. And also, I'd like to congratulate again the Vegan Society for the Neurotrauma guidelines. I am looking to collaborating for our Neurotrauma Society in the Philippines also. Just one comment, the task sharing thing, we already published a paper on that. It's not actually just the non-operative. I was doing that since I started neurosurgery because I was alone. When I started neurosurgery, I was alone for around 4.5 billion people. So I cannot put it by myself. So I taught the general surgery residents to do the neurotrauma. So that's the past sharing thing that and it was published already in the journal. So maybe we can like collaborate, or I can share it with you. Thank you so much.
Yep.
What she's saying is that maybe, but in the other centers it may be conflict of interest might develop, because when I did my first house post 45 years back, I was working in Sion, and so head injuries were done by general surgery, and the neurosurgery used to do the neurosurgical work. Today, with the advancement and more neurosurgeons and more centers, even in the private, even in small centers, as was shown, from a corporate hospital to nursing home type. So they would like to do the head injuries or extradural hematomas and may not pass on these things to the general surgeon. So that will be a conflict of interest with the increase in the number of the specialist itself. I think that could be one reason, that are we really training general surgeons for doing head injuries as it used to be in the past, because in the past the neurosurgery registrar would go and help out the general surgery resident when he is doing the head injury. that
I think that's where the Neurological Society should be doing something. When I started this, it has to always have oversight, and also we cannot. We need to have guidelines also on when they can or when they should not be doing it. For example, if you are in an island very far away, then you have been trained by me, then we can communicate and I can allow that to be done. But then again, when they graduate and I am like 45 minutes away, then they should not do it. There should be guidelines of that task sharing.
And similarly, the talk by Dr. Amit Agarwal, when he was telling the challenges, implementation, and the guidelines. I think these are very important things that you may make guidelines, but there would be different challenges at different levels, and how to implement that becomes a difficult task. If there are any comments or any questions.
So this was a phase 1 study. In phase 2, we are going to implement. So first, before implementation, we should know what is the level of preparedness available. So in next phase, we are going to implement these guidelines in Kolar district.
Yeah, but it's very good, Professor Dhaval, the level of the hospitals from level 1, 2, 3, 4, and different facilities available, different equipments, etc. Available. This is a complex, whatever you have made is a very complex and difficult thing, even to understand for many of us. Thank you very much.
Okay, thank you.
So we close the session. Thank you. Thank you, all the speakers.
Thank you, chairpersons. So we'll now take a very short tea break and we'll assemble shortly.
It's okay.
But Mishra is not. You want to start with this? We start.
Yeah, we start.
Okay. We are going to start our session, which will mainly focus on vascular complication of traumatic brain injury. I would like to call upon Professor Basant Mishra from Mumbai to give his talk on his experience on post-traumatic or surgery of post-traumatic aneurysm.
Good morning. I'm not Franco Servade. He's a big, kind of head injury. We miss him. He's well, but he had ate a little bit more in Pakistan, loved the food, and so he got gastroenteritis. He's back to his country because he didn't like traveling. So there is Dr. Sinha requested me to talk in favor of in his place as a locum. So I thought I'll talk about this, which I have some experience. So I'll give you some cases which we have treated. This is a 5-year-old child. The child had a road traffic accident on the 1st June, and the CT brain was otherwise normal. The MRI shows multiple lacquer and foci of restricted diffusion ischemia, and there was some parafalcine and frontal lobe DW images changes, and the child was managed conservatively. And about 2 weeks down the line, you can see there was a big hematoma there. The child was still okay, conscious, talking. It's another department, it's not with us. And then they did an MRI. You can see there was a small aneurysm there. Which was a post-traumatic aneurysm from which it had bled, and the CT scan showed that. So this was conjured. This was on 15th June, and the child was otherwise okay. They thought this will go away on its own. Until about 5 weeks from the time of injury, the child had another major hemorrhage, multiple evidence of vomiting, headache, and then the child was shifted to my unit. And then we did a DSA, and this was on the, you can see that this aneurysm there, pericallosal. And so the next day, I think, we invited our endovascular colleagues to take care of it, and they did a balloon-assisted coiling of the aneurysm. The child was not too bad. Child was having some headache, vomiting, but otherwise conscious. And that's about it. We didn't have to do anything for the hemorrhage, and child was otherwise okay and discharged after a few days and remains all right. Now, this is the second case. This is a 57-year-old gentleman who had road traffic accident 1 month back, and then he presented to us after 1 month of this accident with recurrent profuse epistaxis, blind right eye, of course, from the time of injury. He also had left hemiparesis. His sensorium had improved over the period of time, and by the time he came to us, he was altered, but he was still responding, and he had left hemiparesis. So this was, unfortunately, I couldn't find in my computer all the scans, but this is all I had in my computer, which I took it out. So you see the CT angio, there is this aneurysm there, which is burst into the sphenoid sinus. There is a fracture of the sphenoid sinus here. We have many other pictures which showed the bone window showing a fracture segment in the atrial aneurysmal wall artery. Now, as the patient was sick, and this was a pseudoaneurysm, as you know, these are post-traumatic pseudoaneurysm, and this was bleeding profusely, so the patient needed some urgent intervention. So we asked our very eminent endovascular colleague to see if he can do something, which is probably the first line of treatment for this pseudoaneurysm today, post-traumatic. So they did multiple other DSA, 3D DSA, 3D CT, and all that, and then he called me, he said, "Basant, I can't do it." I said, "Why?" He said, "There is a fracture segment in the aneurysmal wall, and if they were planning to put a flow diverter there." He said, if I try to put a flow diverter, the whole artery may give way." So he said, "Okay, let me see again." I was very reluctant to do this because it's a major operation to take care of this. Then he tried again, but he said no. He sent back. He was in another hospital, but he's one of the pioneers. He is actually the first neurosurgeon trained endovascular colleague in the country and the pioneer in this field, and he sent it back to me. So we had to do this one. It was a high flow external carotid artery, M2, radial artery bypass graft, and ICA, internal carotid artery trapping in the both in the neck and also proximal to the ophthalmic artery in the brain. Now, so if some of the young neurosurgeons who are interested in the vascular, you can see the short video of the steps we do, very wide opening of the sylvian fissure, critical. You see there is no retractor there, but you can have the M2 exposed. That's the M2. Now we put the temporary clip. These are mini AVM clips, temporary, and we put the temporary first distal, so that the artery remains engorged. Otherwise, just opening these small arteries is sometimes a difficult task. And we have our indigenous instrument, one of this which we called a microport, which has been done by one of the instrument company in Mumbai. And that we use that one to make an incision on the recipient artery. We have already prepared the radial artery beforehand. We have dilated by injecting papaverine through that because the radial artery is one of the most spasmogenic artery in the body. And we do interrupted sutures. In this case, we had put 8-0 nylon, monofilament nylon, with a micropoint needle. The needle should be as small as you have. The smaller the needle, the better it is. But the longer the needle, it takes more time. We have all of us have some physiological tremor, and that can produce more injury to the vessels. It's very critical to first, what we do is first the heel and toe sutures, and then we do both sides, first the side away from you and the side near you, which is easier. And then, of course, we have to be very careful that the lumen is intact. And you can do a continuous suture, but in my practice, we do interrupted suture that helps us not reducing this caliber of the anastomosis by purse string effect. And then we take it out, a little bit of bleeding there, doesn't matter, put a little bit of gel foam there, and that usually stops. And that's the radial artery. You can see the proximal end there, and that's very nicely bleeding there. It's a back bleed from the MCA. And then again, we dilate with heparin, heparinized saline, and you see that that's very, very important. It also helps not only spasm, but also helps if small licks, which you take care before you anastomose the proximal end to the ECA. We anastomose to see ECA, not ICA, to reduce the period of ischemia. If you're closing the ICA for the anastomosis, you have twice you are having ischemia. So we do a end to side. Some people do end to end ICA because you are anyway sacrificing ICA. But the idea of doing to ECA is to reduce the period of ischemia second time when you're doing that. And here we use Prolin, 6-so-Prolin, continuous suture. And we have done an aortic punch. You saw that, the external carotid opening. So you have to have a very, very high up exposure so that you have access to do this end to side anastomosis there. This is easier done, but every step is important. And if some of the young neurosurgeons who do it, is very, very critical. Do not hold the intima number 1. Do not hold the thread. And it's better that you do as little handling of these structures, otherwise there can be disaster. Holding the suture, it can break and post-traumatic hematoma. Holding the intima damages, you can have post-traumatic thrombosis. So now this is, okay, so I'm running short of time. We'll go to the... Now this also you have to do trapping. So you have to open up this, this is the anterocalendar drilling intradural, and then we put a clip proximal to the ophthalmic, and that's the ophthalmic artery there. So we have done that. And then it's a very nice, you see the ICG, and this is the patent post-op, you see So this is the first report in actually the literature. I didn't know that. This is the first report of high flow bypass in a pseudoaneurysm of the proximal intracarotid. So I have 1 minute. I'll just go through a little bit of literature. So this is 1% of cerebral aneurysm, more common in pediatric population. Mortality is very high on medical management, so early treatment is advisable. The histologically, the three types, the true, false, and mixed. The true is disruption of intima, media is involved, but adventitia is still intact. The false is all three rails is involved. Mixed is something which has started with true and becomes false later on. And the anatomical classification is which is followed is aneurysms which are proximal to the circle of Willis, which either could be infraclinoid, the one type us, or supraclinoid, and distal to circle of Willis, the pediatric child one, which is subcortical ours, or cortical. And the mechanism depends where is the aneurysm, it depends on what mechanism it is. Basilar or infraclinoid because of a fractured skull base, supraclinoid because the carotid is fixed in the cavernous sinus, comes out, there is a movement there. Subcortical, the fox or the tentorium is the culprit. Cortical when there is a fracture of the vault. So these are the two examples. We had the infraclinoid here, this cavernous, and subcortical in the child. So the diagnosis, it's very important to early diagnosis. The average time from trauma to hemorrhage is about 21 days. Acute worsening of consciousness, seizure, focal neurological deficit, you should be alerted. For a blunt small patient who is otherwise all right, acute deterioration must be investigated. There is a very recent paper, 2020, of medical management, which should not be done. Mortality is 50%. Intervention is the way to go. And I think the EVT should be the first line of management. It fails. The other modes can be done. There are various types of things. To summarize, suspect traumatic intracranial carotid artery or intracranial artery injury in delayed acute deterioration post-closed hand injury. It can occur after mild head injury. Be aware of that. It's more common in children and prompt intervention is required. Thank you very much. Appreciate your record.
Thank you, Basan, for keeping the time. Any question from the ward, from the floor? I have one question, Basan. Do you have any experience with post-traumatic aneurysm following penetrating brain injury?
No, that is much more common in, this now there is a big report from the war zone, and there's a very high incidence. I don't have any experience, but they are being reported more and more because of penetrating trauma.
Thank you.
Thank you, Dr. I now call upon Dr. Matthew Joseph from CMC Hello. This topic is very, it says where's the money? So I don't know what exactly is going to happen.
Yeah, if I can get this up high enough. Yes. So basically, when I was asked to do this talk, I'm replacing somebody. The previous speaker's talk was quality of death in trauma. So I figured that it's not really a scientific talk. So I tried to make my talk also not pure science. Anyway, so I'm going to basically talk about money, but the source of my information is a database we maintained for 5.5 years in Vellore with a very good rate of follow-up because we had 2 people dedicated to doing follow-up. This is quite rare in India to get over 90% follow-up because a lot of our patients just disappear and are never heard from again. So we didn't obviously admit every patient who came to us because we have limited number of beds. So somebody who came, say 13 by 15, small frontal contusion, no other systemic injuries, would normally be kept in the ER, in the emergency, and sent home the next day if they'd become 15. So our patient population skews towards more severe injuries. This was our admission GCS score. More characteristic would be this, where usually you would see severe, moderate, and mild being very high as a proportion of your patients admitted, whereas for us, most of the milds are managed in the emergency room and sent away. It's only the ones who really needed admission who came in, which is why we are fairly, even as far as categorization of the injuries goes. This is slightly weird data, but this is when I was invited to Australia last year. So the red numbers are the Australian age groups by decade. And the blue is our age groups. You see a totally different pattern of age incidence for our injuries compared to high-income country injuries. We don't have very many people in the 80s and the 90s. Okay. Mode of injury. Somebody was talking about 35% RTA, etc. We are, by far, our largest number of people are the second column, which is people on two-wheelers, either pillion or riding, all right? And of those 2,200 patients with two-wheeler injury, 13 were wearing helmets, and 1/3 of them were drunk. All right, so that is a problem. I'm not going to go into that part of the thing, but just to give you an idea of what our patient population looks like. We have 140 rehab beds in our hospital, and not even 1% of our patients got formal rehab because there's so much demand for the rehab beds from all over the country. All right, so very few of our patients get formal rehab. Right, these are outcomes. Where is Roberto? Okay, the percentages are there, all right? About 20% of our patients died, which goes up to about 35% when you take severe head injuries, and 65% of our patients went back to normal, what they were doing before. As I explained to Roberto yesterday, there are 2 reasons for this. One is a lot of our patients are not really doing intellectually challenging jobs. It's much more manual labor. So even if they are mildly dysfunctional cognitively, they can still do an adequate day's job. That's one reason. The second reason is there is no social service. There's no social security. If they don't work, they don't eat. That is a powerful incentive to go back to work, which is absent in high-income countries, where if you don't work, people will feed you. That doesn't happen here. Okay, so when we're looking at these patients, we have various constraints. I mean, space. A lot of us work in legacy hospitals with no space for new ICUs. Equipment, people, it's all very hard, but overrunning all of that is the money. The problem of finding money to treat your patients. Okay, so we can do some adjustments. This is how I do ICP monitoring. With an infant feeding tube, the total setup costs 2,000 rupees versus a Codman catheter, which costs 40,000 rupees. All right? We do tracheostomies very, very early. If you look at our tracheostomies, by the time, if you've been on a ventilator more than 48 hours, there's a more than 50% chance that your tracheostomy is done. Are we doing them too early? Probably yes. But only if I do the tracheostomy can I empty the ICU to get in the next patient. Otherwise, the next patient has to be sent away. If you look, 1/3 of our patients, we decannulate before they go. So you could make the argument that we are too aggressive with tracheostomies, but really, this is what happens. Right, so there are many other things you can think of, but this is what really we have to do. We play God. If I took 2 patients coming in one bed, I choose the patient who's more likely to survive, not the sicker patient. Okay? Surgery, stop treatment. All these decisions we make on our own with no real backup to help you, which inevitably ends up in a lot of stress. It's difficult. You are every day deciding who lives and who dies. As a senior person, it's hard. No matter how long you've been doing it, it's still hard. The problem is our resource mismatch. We have some resources, but they're totally overwhelmed by the number of people who need it. And we have very much less money than other countries to be able to treat these patients. Okay, so we looked at our data from the crash prognostic model, how well we fit with that. That is, we took the LMIC model and the various requirements for the crash database, and for about 1,100 patients, we matched very, very well. Area under the curve is 88.88. We matched very well. And if you look at it at the numbers, at the lower, see if this on the, I don't know, is my cursor moving there? Yeah, okay. This is a 1 to 10 chance of mortality, 11 to 20% chance of mortality according to the crash criteria. At the the lower ends of mortality, we did much better than the crash. But when you came to say 60% or 70%, expected deaths was 18.58, actual deaths 19. Expected deaths 22, actual deaths 21. We match uncannily well. It's almost like you cooked up the data to get something as accurate as this. Okay, but this is actual prospectively corrected numbers. Now came the thing to see how this matches with their bills, patient bills. This is more difficult because obviously the very sick patients stay in your hospital for a very short time, and therefore they have very small bills. And therefore you're going to say bills for 20% versus bills for 90%. It's very likely the 90% chance of mortality patients' bills are smaller than the 20% patient mortality because they came and died in 2 days. So they didn't have very much of a bill. All right? So I did this by looking at it as a cost per good outcome. So if you look at just the number 1, we had 214 patients, 2 died, 203 had good outcome, by which I mean a GOC of 5 and above. So then if you look at that, the total amount of the bill is that much, and per good outcome is 50,000 rupees, which is very reasonable. As you went up, and the chance of mortality died and chance of good outcomes, that's 2 minutes, right? Yeah. As the chance of good outcomes dropped, you had only 7 good outcomes with that much of a bill. So the bill came to 445,000 rupees. And as you went up, 1.3 million rupees. Oops, sorry. Per good outcome, your cost went up and up and up. All right? As your severity of injury increased, as your chance of mortality increased, according to the crash criteria. What you must understand is here, most patients pay out of pocket. Very few patients have insurance. Okay? And the patient population we deal with may be different in urban centers, but since we are in a semi-urban center, a lot of our patients are just manual laborers. They have absolutely no financial reserves. So they pay their bills by selling things, borrowing money, informal money lenders. I don't know what the thing is again, the rest of India, but our area, the interest rate is 4 to 8 rupees per 100 rupees per month, which is 50 to 100% interest per annum. All right? And what ends up in these people is, even though it's technically illegal, these people end up in generational service to the money lender. That is, the parents work for the money lender, they're unable to pay the loan. The children take over the loan and they work for the money lender at a pittance of a salary, which is what is called bonded labor in India. They bonded to that person who lent them the money. We cause severe harm by making them spend that much money. So now, excuse me, my question is, when you know this, when you know the money is going to be this much, when you know the prognosis is going to be this poor, as a policymaker, as an individual decision maker, as whatever you are, how do you decide where to put your resources? How do you decide who to treat, who not to treat? It is, I'm throwing a question to you. I'm not giving you an answer. I'm just giving you a problem that we face on a day-to-day basis. Thank you.
Thank you, Dr. Matthew. I'm sure it's a very provocative thought. Questions, comments on the floor, please.
Thank you very much for giving us a wake-up call where cash out of pocket is important. Has Ayushman Bharat schemes helped? And was this study done after Ayushman Bharat came in with the 7 lakhs per, or was it before that?
It was done till 2019, and then the pandemic stopped my data collection. So till September 2019.
What's the solution to all this, do you think, sir? You don't have
I'm
one.
only asking the question.
Okay, thank you.
Shall I just answer that? Ayushman Bharat, if the state governments have to be involved in having this Ayushman Bharat implemented in their state. So if the state governments implement that, plus many of the state governments have their own schemes, and if those get implemented properly, some mitigation of the money problem will happen. But this is a huge issue which can't go away overnight.
But paying 100% interest to a sahukara lender is very uncomfortable for any ordinary citizen to know that's going on. It's illegal, criminal, exploitation. Thank you.
Unfortunately, that's reality.
Hi, sir. I would like to add to that and also ask a question. Thing is, like what sir said, that he has a restriction of resources because he's in a different kind of hospital setup. As a private hospital people, we also face the same problem. So what we do is we try to put the ball in the patient attender's court. And when the GCS is between 13 to 15, few patients say, yes, we will pay. But there are a few patients who say, not directly, but indirectly, let go. That's when now the ball comes back to our court. And we are stuck, like should we really decrease the total amount of neurological support we are giving and trying to stretch the patient? Because actually the attendant says if the patient goes bad on a bed rest and comes home, there is nobody to take care, the patient will just die within a day. So how do you deal with that kind of situation?
I'm not saying that we stop or we reduce treatment only for the really, very, very poor outcome predicted patients. Sometimes you think the patient might have a chance, but then the family says, we cannot look after them.
What do you do then?
We have patients whose families are all abroad. There's an elderly couple here, and they are totally helpless. And we have difficulties. What do you do? I mean, if the family says we can't look after, you can't say, no, I'm going to treat, you go away. Yeah? We don't have a choice.
Chairperson's opinion. He's in a corporate hospital.
True. There are two ways of doing this, what practice we do. We have a thing of first 24 hours to 36 hours, we have what's called a pre-channel, which means that we save the life of the patient, we stabilize the patient, whatever. And then there are two channels which then open up. One is like what he's saying. We don't think patient will survive. We don't think resources need to be spent on the patient. There we actually take a call on whether this patient would be good brain dead and would serve society better. I know it's a very harsh thing to say, but that's what we sometimes do. The other one is where the patient is going to survive, cannot afford. There the patient is stabilized and then shifted out to the government hospital because they can't afford it. They are stabilized, so they're going to survive. That's what we do.
Yeah, meaning our patient population, 2016, I looked at it, 13% of our patients paid their full bill.
I think
87% had some amount of concession.
Thank you very much.
Okay, we'll continue to our next speaker, Dr. Andrew Reisner from Atlanta, USA, who will speak on, in my opinion, a fascinating topic of post-traumatic aneurysm, rare and devastating consequences of traumatic brain injury.
Good afternoon. Thank you very much for inviting me. It's such an honor and a privilege to be here. If I may add a little humbling and daunting following Dr. Misra on a topic that he is such an expert on. I'm also going to speak on post-traumatic aneurysms, perhaps from a pediatric neurosurgeon's perspective. And let me start off with perhaps the most important slide. A huge thank you to Virender and Ashok for such a fantastic meeting. And again, it's just an honor to be in Jaipur and in your beautiful country. So thank you very much. Some greetings from my hometown, Atlanta, Georgia. For those that know the history, it's a history known for both the Civil War and civil rights. This is our children's hospital, started off 100 years ago with very humble beginnings, and now it's a big modern hospital. We do approximately 1,500 pediatric neurosurgical procedures a year. I'd also like to bring greetings from the WFNS Neurotrauma Committee, the now current chair, Dr. Andres Rubiano, and co-chair Laura Lipper, as well as what I call our secret weapons. Really, 33 amazing people who've done such a great job from 29 countries, some of whom are in the audience. Eve, I think she's here, Eve Sai, Dr. Alfiki. I know David Adelson's been involved in this committee and certainly involved in the WFNS in the past, and a huge thank you to all of you. I have nothing to disclose. All pictures are with the patient's permission. So with that probably too long introduction, let me jump right in and say post-traumatic intracranial aneurysms are, as the name would suggest, aneurysms that follow trauma. They are rare. They are less than 1% of all aneurysms. They can occur after mild or seemingly trivial head trauma. Dr. Misra, I don't know if you had any mild cases or traumatic aneurysm after mild, but I think you may be interested in a couple of the cases I'm going to present real quickly. As you said, they're associated with significant morbidity and mortality as high as 50%. So let me jump in and give you a couple of cases. This is my first case that I was intimately involved in, a 3-year-old female, high-speed motor vehicle accident, ejected through the windshield, GCS of 7, high ISS, multiple fractures. She required a craniotomy. That was done. Transferred to the ICU. 12 days later, and she was progressing well, 12 days later, sudden loss of consciousness, and I think the CT scan tells the whole story, just a blowout. Took her, did a larger decompressive craniectomy, did an aneurysm the following day, and sure enough, she developed a post-traumatic aneurysm of the ACA, which you can see on both the lateral and the view. This is a poor quality picture of the angiogram, but I think you can see the aneurysm filling nicely from the anterior cerebral artery, both on the AP and the lateral. This is the selective view. And we elected to treat this endovascularly. As you can see, our endovascular group did a fantastic job, excluded the aneurysm and got good distal runoff. These are the snapshots afterwards. This is autumn, a couple of months later. She required a shunt for delayed hydrocephalus. The bone flap was put in, and she's doing relatively well, although has some cognitive delays. A couple of other quick case reports. This is April, a 2-year-old female, initial Glasgow Coma score of 14. One more time, Glasgow Coma score 14. No surgery is needed, just a left parietal skull fracture. She was sent home. 10 days later, she had a seizure, came in with this GCS of 4. This was a scan, this was an aneurysm, and I took her to surgery and put a clip on it, and it went relatively well. Surgery went well, but she had improving hemiparesis. The next case, Brandon. And this one sort of gives me some of my gray hairs. 8-year-old male, fell off a bicycle, GCS of 15. There was something unusual on the initial scan that I'm not showing you, a little bit of subarachnoid hemorrhage, nothing to write home about, but got my attention in the basal cisterns. I did an angiogram on this kid. It was negative. We sent him home. A month later, came back with headaches, contusion, That's his CT scan, a frontal contusion, that's his angiogram and aneurysm. I was young, inexperienced, had one or two successes. These are easy. I'll probably just go into hemispheric and put a clip on it. It was not. These aneurysms are friable. It ruptured. I struggled in surgery, and he woke up with a dense hemiparesis and significant cognitive delays. So when you review the literature, intracranial aneurysms are infrequent, but are well described, and I'd like to just share a couple of nuances with you. As Dr. Misra suggested, they are classified anatomically, proximal and distal to the circle of Willis, and it's a little bit more than just an anatomical classification. It also got to do something with the mechanism of injury. Usually the injury is where the vessel has been injured or stretched. For example, with basilar aneurysms, usually the infraclinoid carotid are affected. A very common, or a protected space, if you like, is the supraclinoid segment, where there is a little bit of mobility, but it doesn't usually hit a structure. Perhaps the most common place where it's affected is the anterior cerebral artery, and in any series, those are the most common aneurysms, and it's probably related to its proximity along the edge of the falx, that with the traumatic event, there's injury to the vessel. Likewise, posterior cerebral artery aneurysms against the tentorium. These have a few, but good examples have been described. There have been case reports, I have not had one, where aneurysms have been described following skull fractures, and just for completeness' sake, believe it or not, one or two superficial scalp injuries with whatever hit the scalp, and they get superficial temporal artery aneurysms. A emerging and very common category now, if you like, is this iatrogenic post-traumatic aneurysms. And they can occur after any surgical procedure. Most commonly, though, it's usually transnasal, anterior skull bases, they get lost, something happens, those occur, repeated subdural taps, endoscopic third ventriculostomies. This is an example of a pseudoaneurysm following epilepsy probes that were placed. I mean, you know, these are kind of blindly placed. Sure, sooner or later, somebody's going to get a aneurysm, and that's what happened to this patient. This is CT angiogram. This is the patient positioned at surgery. This case was due to my head of our department, Dr. Barrow, shared this video with me. He did a bypass on this procedure, a bypass procedure on this case. Clipped the aneurysm. As you could see, there was some bleeding, which is common with these cases. Finished the bypass, and there's the aneurysm on the field. So not to take everybody back to medical school, but what's important about these aneurysms is that they are false aneurysms. And as you may recall from your pathology studies, false aneurysms are disruptions of all three layers of the vessel wall. There's often a hematoma that holds it together, and that false lumen can rupture easily, hence the high propensity for intraoperative ruptures. How do these people present? Well, most commonly acute decrease in level of consciousness, a seizure or focal deficit. Just about every study in our experience, although we have not compared our experience from our adult to our pediatric group, but traumatic aneurysms are more common in children than adults. There appears to be a male predominance. Other nuances of the clinical presentation. The time of the trauma to the rupture is very variable, but approximately, if you add it all up, 21 days, so about a month. They should be diagnosed if there's an acute setting, as was the case in Dr. Misra's cases and my cases, after any type of traumatic brain injury. Obviously, they need to undergo CT scanning and angiography as soon as possible. The differential diagnosis. Well, it's fairly long. Let me just share a couple of quick cases. This is little Janaya, a 2-month-old female. I was called down to the emergency room, and I was told that she was abused. She was shaken, And I looked at a scan, and that was very atypical for a child abuse. The bleeding pattern just didn't fit with that. We got a CT scan, followed by an MRI and an angiogram, and sure enough, she had a pica aneurysm. Endovascular embolization failed. I took her to surgery and put a clip across that aneurysm, and she's doing well. John, a recent case, an 8-year-old male, rode his bicycle into a tree, came in with severe headaches and vomiting. His GCS was 15, no deficits, was in the ICU. This is, scan showed a intraventricular hemorrhage. Dr. Mishra, forgive me, but before we got the angiogram, I was telling our residents, this is an aneurysm, this is typical, this is how they are, intraventricular bleeding, and by the way, anterior cerebral artery aneurysms are so common. Look at that sort of fuzziness near the genu of the corpus callosum. It's almost certainly an aneurysm. Well, unfortunately, I was wrong. It was actually an AVM that had ruptured, and did not feel that was surgically amenable. And after much discussion, he ended up getting gamma knife treatment, and there he is getting the gamma knife before and after the gamma knife procedure. A lot of people ask me, well, how do you know that this patient never had an aneurysm before the trauma? Well, I mean, short of getting an angiogram the day before you have your bicycle accident, you don't really know. But there are different characteristics. First of all, the temporal relationship to the trauma. Secondly, the location of these aneurysms is different. It's usually along the course of the vessel, near dural edge. There are false aneurysms, and intraoperative rupture occurs commonly, rather than the aneurysms that typically occur at bifurcations. Radiographs, should we follow them up? Short answer is I don't know. I don't think that the literature is definite. There have been several cases that have been described where these develop after a post-op angiogram was obtained, as was my third case. So the timing of the follow-up is important as well. Some authors recommend a follow-up 2 weeks after injury. We have not done this and usually do it on a case-by-case basis. Certainly we'd do it if there was a major penetrating injury like that gunshot wound. We do not do it routinely with blunt trauma, as this group in Arizona recommended from Tucson, Arizona. This was a large study of blunt trauma, and they found that the yield was so low, didn't warrant it. In contradistinction, if there's penetrating injury, something about stab wounds, and this was shown by Dr. de Villiers from Cape Town many, many decades ago, stab wounds seem to have a high propensity of aneurysms and be a little bit more aggressive with those children rather than other forms of penetrating injury. The natural history. 2 minutes and I'm done. Dr. Barrow's predecessor, George Tyndall, actually wrote an article many decades ago which showed the natural history was so bad, 50% of these people died without surgery. It's been shown in other studies as well. The actual treatment is endovascular versus surgical, really should be decided case to case depending on the aneurysm geometry, location, comorbid conditions, surgeon's preference, and perhaps most important, the institutional resources. So let me conclude by saying that these aneurysms are rare, they're distinct, they should be considered in all patients with an acute deterioration following a TBI. They can occur after a mild head injury, more common in children. Natural history is terrible. Surgery or endovascular occlusion are definitive treatments, and if you take them to surgery, be aware there's a high risk of intraoperative rupture. And with that, I say thank you very much.
Thank you, Dr. Reisner. Any question from the floor, please?
Just a comment for penetrating intracranial aneurysm. We have experience of few cases. Few means 4 only. So if there is a hematoma with penetrating injury, okay. If if there is a hematoma, we state plan for surgery. But in volume rendering images of angiography, if there is a bone segment there with the aneurysm, we always prefer surgery because these aneurysms are in children, they are low velocity injury and they cause a lot of infection because of bone segment. So we have very clear policies of our institute. If there is any segment bony or something with the aneurysm, surgery, otherwise intervention. Yes.
Thank you for your comment. Next question.
Thank you, Professor Andrew. I just want to ask about, since they are rare, so do you usually have a committee with the neurointerventionist about the best approach? So you choose in one case to do clipping and in the other case you choose coiling. So what if there is science in the angiography that will favor to start with coiling or clipping?
Thank you. That's an excellent question. It really depends. Our preference is to have an intervascular person do this first. And we certainly encourage them to do that. If they don't, or they try and they fail, then we typically do surgery. And that's sort of evolved over the decades. Before, surgery was the first preference. Now, with more experience, both on the surgeon side and the intervascular side, our preference is to do intervascular treatment first. Dr. Misra, please come up.
For most of my non-traumatic intracranial aneurysm, microsurgery is the first line of management because the long term in my hands and my patients is good. For post-traumatic aneurysms, the first line management in pseudoaneurysm, these are pseudoaneurysms. There are three types actually, true, pseudo, and mixed. If it is a true pseudoaneurysm, they're very difficult to clip because this will just give way. There's no aneurysm there actually. There's no wall, there's no adventitia there. So I think the first line of management should be endovascular and they should have the first right of refusal. If they can't do it, like one of my cases and one of your cases or whatever. So I think this is the way it should be because they're very high risk because there will be, unless there's a big clot which you want to evacuate. Most of the time, the clot is not the problem. The problem is the patient has an acute deterioration and you take care of it, then they're fine. Bypass, yes. If you are sacrificing a vessel, wherever if it's a critical, unlike if it's a cortical vessel, then it's fine, you just excise it. So very distal ACF-A4 sometimes happens, distal P4, you can sacrifice it. But all other, and the cortical vessel, but proximal vessels, you should be prepared to bypass. So you should have a microsurgical colleague who is competent to do it.
So priority will be for endovascular and
or
surgery with
preserve the vessel.
Thank you.
Thank you.
I have a question and a comment for you. Post-traumatic aneurysm, post-penetrating burn injury is completely different from blunt trauma, the post-traumatic aneurysm for blunt trauma. And the focus of your talk was mainly blunt trauma. In penetrating, the situation is quite different. Unfortunately, in Israel, we have a lot of experience with penetration, not from knives, but basically from bullets, from shrapnels and stuff like that. And we have pretty much a low threshold use of angiography in our patient, and every time we do angiography, we find something. So I never regret an extra angiography that I did. I was deeply regret an angiography that I didn't perform. So there, it's pretty easy. But in blunt trauma, I mean, some of the patients that you described were discharged home, and they come later with devastating hemorrhage. Some of them may survive, some of them may not. The mortality is up to 50%. So what, in your opinion, will be any sign? I mean, you was talking about some suspicious signs, but that's very important. I mean, who will be the patient in trauma, minor, moderate, or severe, that we will do, at least CTA?
Yeah. A great question. I don't have a good answer for you because there are two issues. How do you image them and when do you image them? I think how you image them has become a little bit easier now that CT angiogram has become more sophisticated, more readily available, and so that certainly might have a much lower threshold for getting a CT angiogram than a formal angiogram. But unless they're clinical signs, I don't routinely image these children after a simple blunt trauma that they've made a seemingly good recovery, unless they have some symptoms, epistaxis suddenly, or nerve palsy, or some real findings. I don't do that routinely. The one time, by the way, in my third case, where I did an angiogram, and there was no aneurysm on that angiogram, granted that was done in the first week after injury, and the kid came back a month later. So that's a problem with these aneurysms. They're tricky. They can develop over the next few months.
And what we do if you have a trauma patient with normal CT, but have some neurological sign, is this patient is going to have some more advanced neuroimaging in your center? Normal CT, neurological sign.
Yeah, I don't normally routine them. I just don't. I mean, our volume, as I'm sure your volume is, with, especially in pediatrics, all the kids that have concussions and head injuries and falls, I have a threshold if there are objective findings, just to feel on the symptomatology, but no, I do not do it routinely, and fortunately, this is a rare problem.
Thank you. Basant?
Standard teaching, I mean, we've been doing that. If the patient is a head injury, which is otherwise normal, CT is normal, brain CT is normal, and he has a neurologic deficit, suspected dissection of the carotid at some level. So you have to have an angiogram. And the other patient, any patient, even if he's all right, he has a skull-base fracture, most for adults, not for children, because children, you are exposing them more radiation. That's a very important thing. For adults, if you have a skull-base fracture, or if you have any neurologic deficit, for example, any cranial nerve paresis, they must have an angiogram.
So thank you very much for this interesting session. Thank you, Dr. Reisner.
Thank you.
Thank you, Mr. Chairman.
Thank you.
So thank you, chairpersons. We now move on to the next session. This is just a reminder that we have the recent advances and innovations in TBI in Hall A, while we would be conducting the surgical aspects of neurotrauma in Hall B concomitantly. So the chairpersons for recent advances and innovations in TBI are Dr. B.S. Sharma, who is Professor, Department of Neurosurgery and Director, Neurosciences, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Dr. V. Sundar, who is a Senior Consultant and Head of Department of Neurosurgery, Center for Advanced Brain and Spine Surgery, Tamil Nadu Government Multi-Super Speciality Hospital at Omandurar Government Estate, Annasalai, Chennai, and Dr. Young, who's President, Taipei Neuroscience Institute, Taipei Medical University. I request the chairpersons to please take their place. I request Dr. Dhaval Shukla to please take his place as chairperson of this session. Thank you.
Yeah, good afternoon. Now we can start this session for the recent advance and innovation in TBI. I'm one of the moderators, the Yun Xiao Qiang from Taiwan, Taipei. And the next moderator.
Good morning. So we are going to have one session on recent advances and innovations. I welcome my co-chairperson for this session, and we would like to invite first speaker, Dr. Reisner, who will be talking on utility of biomarkers in TBI in children. Dr. Reisner, please.
Once again, you ready to start? Good. Okay. Thank you very much for inviting me once again. I'm here to talk about biomarkers in traumatic brain injury in children. Huge thanks again to the organizers, and I think I've already gone through the greetings, so I will skip all that as well as the disclosures. I'm going to speak about biomarkers in traumatic brain injury, specifically in children, but actually it's a timely topic. Some of us were at an NIH study about a month ago where there's a move afoot to revise the Glasgow Coma Score, and we won't speak about traumatic brain injury in the next few years just based on the Glasgow Coma Score, but rather the clinical, biomarker, imaging, and environmental, C, I, D, B, and E classification. So biomarkers are becoming more and more part of the management, or hopefully will become more management of traumatic brain injury in the future. I think for those residents and students that are in the audience, if you're going to remember only one slide from this whole talk, this is the most important. This is from the Lancet Commission, which just did an outstanding review on traumatic brain injury. The boxed columns are TBI. So, let's see, my pointer's working. There we are. So this is incidence and prevalence. So just look at TBI compared to other neurological problems. Stroke. This is Alzheimer's disease, which, as you can see, the incidence is low, but they live for a long time, hence the prevalence is high. Multiple sclerosis and Parkinson's disease. So TBI just dwarfs all other neurological problems greatly. Pediatric TBI is a very significant part of the pediatric health problems, even though they only account for 5% of all TBI-related deaths and approximately 8% of hospitalizations. And this is because if you consider TBI and measure TBI in the context of years of lost life and years lived with disability, it's a significant health problem. It's always interesting to me to look at the different injury mechanisms. Again, just a quick little survey, little chat about the difference between adults and children. You can see that falls are shown in this sort of dark brickish red here, common at the extremes of life. There are also regional differences. For example, in this country, as I think we all know, balcony falls are a big problem. In India, Singapore, and other countries, abusive head injury is becoming more and more recognized. And unfortunately, in the United States, we have a problem with gunshot wounds to the head. Dr. Adelson, my colleague, pediatric neurosurgeon, would agree with me when I say children are not small adults. They develop into adults. They are different animals along the way. And this is important in the context of everything, including biomarkers. The brain volume expands rapidly at birth, reaches a maximum, so peaks at about 80% at 2 years of age. Neuronal population at birth is equal to that of adult, but extensive dendritic expansion. The white matter undergoes tremendous development, perhaps more than as much as the gray matter. The issue and the point I want to make is that a TBI, while the child is developing, especially in the first 2 to 5 years of life, can arrest any of these developments. There are other differences that we all know, and I'm not going to labor the points, but differences in the calvarium, the thickness of the skull. The white matter of a child has a lot less myelin than adults, and all of these have significance for traumatic brain injury. So what is the potential role of biomarkers? And to the students over here, Who has used biomarkers? If you could put up your hands. And if any student hasn't put up your hand, you're wrong. You've all used biomarkers. If you've taken somebody's blood pressure, that's a biomarker. If you've checked somebody's glucose, that's a biomarker. If you looked at a chest X-ray, that's a biomarker. So I just want to dispel this notion that biomarkers are some esoteric black box that, in the future. Biomarkers are real. The exemplar that we use in TBI is troponin for heart attacks. Pain is a pleurisy or heart attack, and the troponin will answer that question. A question that I'm often asked is, why do you need a biomarker for head injury? I mean, let's face it. We know what's going on with this patient. We know what's going on with this patient. We know what's going on with this abuse patients. Why do we need a biomarker for diagnostic purposes? And the short answer is you don't. But after that patient hits the emergency room, the next steps is still a conundrum, and biomarkers hopefully can guide us in the management. This is from Track TBI. These patients with CT scans all had the same Glasgow Coma score. Completely different diseases, and this speaks to the heterogeneity. I'd also like to mention, just in passing, that neurotrauma right now is best defined as not precision, but rather imprecision medicine. There have been 40+ failed clinical trials, and we really need to, and we are making our way to precision medicine, as has been done in other fields such as brain tumor, breast cancers, etc. So how could a biomarker change TBI management? Well, maybe a subtitle of this slide should be, what's our wish list? Well, a biomarker could triage patients effectively. We've just heard many great talks about resources, and resources are limited in every country. How many patients, adults or children, should be transferred urgently and are not? But more importantly, how many patients are transferred but really could be managed at home? And if we had a magic biomarker that could tell us that the patient's safe, could be managed at home, that would be a huge cost saving, let alone many other things. Perhaps could guide medical management, streamline surgical decisions, let us know if whatever we're using on the pathway is effective or not. So what we need is the ideal biomarker. So what is the ideal biomarker? It's biologically stable, it's accessible, inexpensive, reflects ongoing pathophysiology, can be measured at the point of care, and specific to that tissue. It only comes from the brain. I hate to disappoint you, but that biomarker does not exist. We're looking for it, maybe a panel, maybe a combination, but the ideal biomarker, the troponin, if you like, of the brain does not exist. Efforts have been made, mainly by adult colleagues who certainly have advanced the field a lot more than us pediatric neurosurgeons, but whether it's pediatric or adults, we still look at the same biomarkers currently, whether they are neuronal based, from the glial cells, the myelin, the axon terminals, blood-brain barrier, or from the microglia or inflammatory cells. Our particular group has been interested for a variety of reasons in microglia. Microglia are the inflammatory cells. One of the substances produced is a substance called osteopontin, which is produced by the microglia. We found it overproduced in preclinical studies in laboratory mice. We took it to the clinical studies where the nurses here are modeling admission 24, 48, and 72 hours. And sure enough, we found that it performed as well as other biomarkers. And based on that, we got a little NIH grant. We're currently assessing our 600 enrolled patients, and we are finding that it may be supplementive to current biomarkers. We found that osteopontin was promising in predicting mortality and S100B in predicting 6-month outcome. So for a typical patient, what it would look like, it would look something like this. This is osteopontin. This is a child who was run over by a car, was kept alive for 3 days only because of organ procurement. The patient's family wished to donate the organs, and we could follow the biomarker profiles. Interestingly, that inflammatory biomarker and something that needs to be investigated with other inflammatory biomarkers, there seems to be a different pattern with children who are abused. In other words, the shaken baby. They have a different biomarker profile than a kid who falls out of a tree. And probably because this is not their first episode, they've been shaken multiple times. But that's a topic for another discussion. There are challenges with pediatric research. There are regulatory and financial challenges. The volume of blood samples we can get is limited to less than 2 kilograms every 24 hours, and of course, clinical care comes first. There are problems with clinical trials. Half the pediatric trials go unfinished, and I was shocked to learn, and they're complex. This is our little map of the blood samples that go from the patient to the lab, that almost 40% of registered pediatric trials culminate in a peer-reviewed study. In other words, more than 60% do not. These are NIH-funded studies, so it's very complex. To get over this, we need to keep the trial participants engaged. There are a lot of social barriers. Not all patients, family can afford to come back for the studies. And frankly, us neurologists and neurosurgeons do not do a good job as our hematology colleagues, like this patient, again, called down to the ER, this kid's bruising, bleeding, possibly child abuse, took the kid to get a scan, did not look like child abuse, and while I was in the scanner, the white cell count came back 400,000, and this child was found to have acute lymphoblastic leukemia. Because of the mass effect, we got the lab value stable, I evacuated the hematoma, and there's a child. But this child was embarked on a trial the next day. They are really, really good at that. The challenges in pediatrics from finding the right animal model. In other words, is the animal model mature or immature? The ethical challenges. When we go and consent these patients, we need to be very clear that this is not going to affect their treatment in any way. These challenges are highlighted and amplified when they cross cultural barriers, especially HIC, LMICs. And I think the title of this article that occurred in the Journal of Ethics says it best. Ethical approval in developing countries is not optional. If I had one wish list, one wish that could come true, it would be that biomarkers are different in children than adults. The levels of each biomarker is different. We don't know what the normal values are, as was the case in this, as is the case with adults. We just don't know what they are. And huge investigations are undergoing at this moment to determine what the levels are at every age. So what is my hope for the future? That biomarkers get incorporated in the guidelines, be it in the high-income countries or resource-based guidelines. I have no doubt that the technology will be improving. And for many reasons, I regret Dr. Franco Servade not being in the audience, because he would be right up at the microscope and saying, are you crazy? Biomarkers, high cost, which planet are you living on? And my answer to him would be this graph. This is a graph of a chip in your Apple iPod. Whoops, in your Apple iPod. This was back in the 1960s. No country could afford one. It was trillions of dollars, trillions. And with time, you can see how the cost has dropped exponentially, that most of us can afford a small iPad at the moment. And I have no doubt that's going to happen with biomarkers as well. So in conclusion, gentlemen, I'd like to say that despite the epidemiological burden of TBI, our ability to predict outcomes and guide therapy has not changed much over the last decade. Neuro-oncology has made great strides. Adult TBI has made strides to a lesser extent. Biomarkers have the potential to greatly enhance pediatric TBI management, and more robust multi-institutional studies are needed. And with that, I say thank you so much.
Andrew, great talk, as usual. Very, very futuristic, very interesting, hopeful. The problem is the requirement of each country is different. The amount of money you will spend for all this, with a fraction of money, we heard the first talk from Vellore, is prevention. We have in our country, and like many other LMICs, a low velocity injuries, unlike in the West. And many of them, I can't remember the statistics, but majority of them were two-wheeler accidents because they were not having helmets, and half or 30% or something were drunk. So I think the society, the amount of money to spend that to correct would probably benefit the society much more as of today. I'm not saying this is not going to come, it is going to come. But I don't think the LMICs should be spending money on this. This should be coming from the high income countries. And then when we get it to that bottom of the graph we showed, then we should be, right now, I don't think we should be spending money on this research. We're spending money on having prevention, having helmet on everyone's head when having a car or a two-wheeler or something like that. The belt, seat belt, and so on.
If you just wait there for 1 minute, Dr. Mishra, let me say the same thing. A penny of prevention is worth a pound of cure. So absolutely. But again, I would argue and push back just a little bit that if the cost drops and we find the effect of biomarkers, regardless of the country or the resources, so much resources is wasted with unnecessary transfers, of inappropriate transfers. And if the management can be guided to be more effective, I really think it would be a cost-saving thing that you don't need all the ambulance, you don't need all the things. So my hope is that sooner or later, much like the management of diabetes, it's just cost-effective to manage it locally. Thank you. Thank you.
And thanks, Professor Weissner, again for a wonderful talk. The question was about osteonectin. I hear it's a microglial product. It's a osteonectin, the new biomarker you talked about.
Osteopontin, right.
Osteopontin
with a P.
Osteopontin,
Yes,
sorry,
sir.
yeah. So what's the word osteo doing there? Is it a bone stimulation product? I was just curious.
It was just found in the bone first.
It's found in the bone first.
It was initially discovered in the bone. Pontin it's a bridge molecule between the extracellular and intracellular pathways, hence the name osteopontin, but it's actually quite ubiquitous, and that's why it's not an ideal biomarker, because it's not brain specific.
Right, so it's not a specific one.
No,
So
seems to be-
SB100,
seems to be overexpressed in the brain compared to other tissues, but not exclusively.
so we'll have to go for a combination of GFAP, SB100B,
It
which
may end up being
have
a
been used
exactly.
clinically.
It may end up being a panel of biomarkers
Panel of
rather than a
biomarkers.
single one.
So we're nowhere near to wherever we want to be from a biomarker perspective. Thank you.
Thank you.
Thank you, sir.
Thank you.
Can I ask you one question? Like you have mentioned the utility of biomarker for diagnosis and correlation with the severity of brain injury. But what about prediction of outcome, particularly neuropsychological outcome?
Yeah. Actually, these biomarkers that have been discovered have been demonstrated to predict short and long-term outcome quite effectively. The group that's done, two groups that have done tremendous amount of work in adults is Center TBI, based in Europe, and Track TBI, based in North America. And they have high-impact journal publications that have shown that GFAP, UCHL1, both are highly predictive of actually long-term outcome as well. Thank you.
Yeah, thank you. We'll move to the next speech. Is Dr. David Anderson. He will present the future advances in technology to improve following brain injury.
Virendra, wonderful to be here. Ashok, thank you for the invitation, and to the organizing committee. My innovations talk is going to be on neurocritical care, and it's wonderful to follow Andrew because I absolutely agree with his concepts of biomarkers, and I think there are many biomarkers, and we need to recognize that it's not just all bloodborne ones. I have just a minor disclosure, will have nothing to do with this talk. I think suffice it to say is that we all know that the morbidity and mortality of trauma is often due to the extension of secondary injury. I would agree with Basant that we could do more preventative, but I think that we look at brain injury, unfortunately, as not a very complex disease, but it is. We know that the brain is a complex organ, and we know that the pathophysiology is also quite complex. And there's lots of different reasons that we don't probably understand well enough what brain injury and what's occurring. And we know that the clinical trials and studies and practice of today have really been quite variable. And that's really why we need to maybe take another look at how we do things with regards to traumatic brain injury and in the aspects of neurocritical care. So anyway, what I hope you'll take away from this is we understand that worsened outcome comes from second insults and secondary injury. And so if we can mitigate those, then we will potentially improve outcome. And we understand this quite well when it comes to the concept of precision medicine, which is really where Andrew introduced this concept of biomarkers, but it's in developing this concept of a biosignature, which is a conglomeration of the biomarkers that will allow us to hopefully in the future more individualize our approach to care. And where I think the innovation is going to come is not so much in discovering new biomarkers. I think there is the need for that as well, but it's going to actually be how do we integrate those biomarkers into our decision-making in a moment-to-moment basis. Well, we know that traumatic brain injury can occur in a lot of different unique ways, and whether it's traumatic brain injury or acute neurologic injury like stroke, we know that it's due to that impact or primary insult. We also know that that's known as the primary mechanism. This results in the primary injury. There are a number of secondary mechanisms which then can occur, which then lead to the secondary injury. And so these are our different steps. And so we also know that you can add insult to injury, like hypoxia or hypotension. Those can worsen the mechanisms, and that can worsen the secondary injury. So apropos, if we're really quite limited when we sort of think about this, when we're talking about the management of these patients, it's really in this second aspect. We know that if we can mitigate or prevent the injury, then we will have the largest impact in trying to prevent the amount of brain injury that we're seeing, as well as the morbidity and mortality. But once we get to that second concept, what is really the best approaches, and really how do we best deal with these different patient populations? Well, part of the problem is that we don't categorize it well, and many of you are familiar with this. I don't need to tell you that the GOS is quite limited in its approach, but we also have very limitation in looking at outcomes. And so really to try to understand not just the phenotype, but how are we going to measure by outcome really remains a question. And that's why I've left all of these, not only different biomarkers with question marks, but also how do we measure the outcomes in these patients? So having said that, ultimately we need to treat each patient as an individual, and we need to define what is really the optimal approach for each individual patient. Well, we know that our goal in managing these patients is to try to create an environment for neural recovery. And so this will include, and most likely the challenges that we deal with on a day-to-day basis, is understanding the pathophysiology of the injured brain, the ability to measure in real time second insults and secondary mechanisms. How can we then prevent them and show that we're indeed improving outcome, and then develop new and unique aspects to management? Well, many of you are familiar with this slide from Jeff Manley. We do know that, for example, that in the cardiac care unit, we get lots of different biomarkers and different measures of whether the heart's functioning well or not. But in the neuro ICU, we often look at it in a very limited way. We get blood pressure, we get ICP. We oftentimes, unfortunately, we just get CPP as a calculation of that. And so many of us would argue that neurologic monitoring is limited. So we do need more biomarkers, and again, in quotes, as Andrew has pointed out. So again, these are what we get standardly, but we have lots of opportunities. We have lots of different monitors, lots of different biomarkers that we could be collecting, but unfortunately we don't. And I think we don't because many times we don't know what to do with those biomarkers. And so how do we put them into a cogent understanding of what's going on for those particular patients? First, we have to understand, is the data just the data? So we get this data and we're trying to figure out what to do with it. So how do we, kind of uniquely approach these patients to understand what's unique for that data set for that patient? And then how do we integrate all the different pieces of the data that we might get from all of these different biomarkers and create a system and understand what's going on physiologically? So what I would argue is that if we were to indeed start to collect these type of numerous biomarkers in brain, in the injured brain, then in the ICU, we should be able to then start to develop novel therapies that would be able to push us down the road. So that's really where precision medicine comes in. So it's utilizing all of these different technologies and then starting to integrate not only the data from, let's say, one set of biomarkers, but not only that, but all of the biomarkers collectively in order to start to make decisions. So again, just to highlight, with a multimodal approach to neurocritical care, what our goal here is to take all of these different potential monitors, all the data that comes from these monitors, and then we try to take all this chaos and confusion and all the different things that come from that, and then really create an integrated system. And that's really where this comes about, is that we need to now take this data, parse it out, and start to understand how we might manage these patients. So even if we look at something like ICP, so we know ICP, we make decision based on whether it's high or low, we can measure that, we can decide whether to treat or not treat, and we've got a couple of drugs that we can to do that with. But is the data all the data? We classically talk only about high ICP, low ICP, or high CPP or low CPP. But the reality is it's not just about thresholds. We do know, for example, that there is some potential flexibility relative to what is normal ICP. We wouldn't say, for example, in a 2-month-old that an ICP of 22 is normal. So we need to start to look at differences in ages. But similarly, we can start to look at waveform analysis. Well, as many of us who got gray hair and gray beards and everything else, or lack of hair, is that waveform analysis has been around a long time. This is not new, but yet it fell out of vogue. And so why? It's really, what do you do with it and how do you incorporate it into clinical care? And so this is a question that now is starting to come back, because we can look at waveform analysis and start to look at what's the value beyond just a number high or low. We can also start to look at values of pressure and perfusion. Now we start to see CT perfusion and other monitors or measures of perfusion. We can start to look at autoregulation, and we can measure that also with ICP and CPP. We can now start to look at how do we optimize CPP in different patients and in different times within those patients. And so ultimately, in this work from Cambridge, is that if we can start to create a red, yellow, green approach toward understanding what's going on, here's one just looking at the pressure reactivity index. Well, we now start to have a better feel for what's going on physiologically in real time. And then if we start to incorporate other types of ICP and CPP waveform-derived measures, and here you can see almost 20 different measures of autoregulation within the brain, now we can start to look at how could we potentially be treating or not treating some of these different perturbations in our autoregulatory capability. So now I would argue that it's not just about high or low. We now have not just treatment or not treatment, but now if we started to add other measures. So previously I was just saying, just on ICP and CPP alone, we've got a lot of different parameters. What if we added brain oxygen? What if we now started to have a more complex approach toward our understanding and knowing that, well, ICP is normal, but now brain oxygen is low. Now we start to have a different picture of what's treatable or not treatable. And so as we add parameters to this, we start to add whole new levels of complexity and understanding, which then gives us many more opportunities to treat. And in many ways, you can take a 3D approach, not just a 2D as I just showed. You can also take a 4D approach, so adding time. So it's not just we're collecting hourly or by minute or by second, but now we start to get into microsecond or millisecond. And now we start to understand that creating decisions for these patients is not just a simple high or low for ICP, but rather we can enter the matrix and look at a much more rich and complex system of decision making. And so we can take this and visualize this now. This is using Moberg data, which just uses simple parameters that we collect in the ICU, brings that data together, and now creates a much more complex approach. But we need to test this, and this is where the iterative approach comes from. We need to do further data analytics, and we're now starting to see this with artificial intelligence. We can now start to take this data, start to create new decision support systems, and really apply these into our monitoring and create alert systems that now allow us to tailor the care for these patients. So in the future, and again, this section is on innovations, I think we'll start to see continued developments in artificial intelligence that will really apply new ways to look at all of the data that we could collect in these patients, even as simple as pulse and blood pressure, and adding this to our armamentarium. Clearly, we need validation in clinical trials, but I think that as we add new collaboration and unique aspects to this, will bring future successes in these areas. So in conclusion, I say that we need to continue to monitor, and we need to monitor aggressively in order to know where those second insults and secondary injury mechanisms are occurring. I think the future is that precision medicine does require us not just to look at the data, but really start to really delve into how that data integrates and how do we bring that into our decision making. And our interpretation will come, especially with the new advances in artificial intelligence and big data. I would say that we need to measure more, monitor more, understand more, and I think we will do better for our patients. So with that, I thank you.
Okay, any question for Dr. Anderson?
Thank you. Very futuristic. AI. I think you took me to some of my areas of interest. Now, the point is there's a weightage issue. You identified about 20 or 30 different parameters. We do not know the weights of each of those parameters. AI can do all this, but clinicians like yourself need to guide the AI software, which would have to be either natural language processing or generative AI paradigms that will easily give us the answers. But who's going to put the weights on each of those parameters and identify the first top 5 and the second 5 and the next 10 sets of variables that apply to a patient? That the AI cannot do. AI is basically a slave to whatever we direct it to do. It can crunch lots of data, do derivations from that, but to direct it, has that process been started? That's all I'm asking.
Yeah, so I 100% agree. I kind of got a little rushed at the end there, but that's where the human AI collaboration comes from.
Is it already
It's
happening now?
exactly it. I don't think, we don't know the answer yet. I think really what we're trying to understand is which of those parameters has a higher priority, which are most important.
Yes.
Now, what's most important, like you said, top 20, 5, maybe 5, all quartiles. But those parameters may be different in different patients, and it may be different
Subgroup
in different
analysis.
patients at different times.
Yeah.
So we don't know those answers yet, but I think that's where the excitement comes in, is that once we start to now integrate that data, we look at what was important for patient 1, what was important for patient 2, how similar or dissimilar were they? How do we rank those parameters? Where were they important in those individuals? We tend to do clinical trials, big clinical trials with big data and big populations, but we may need to just be looking at Ns of 1 and Ns of 1 on different days exactly, and see what
look
is.
back and look forward day to day, and then
Exactly, and
give
that's
the
where that
AI, the systems,
that's
the data input,
exactly,
and
and
then
that's the
start
iterative
thinking
process.
through
Exactly.
the natural language processing tools it has. NPL will kick in at that point into the AI mechanisms. Natural language processing, it will
Yes.
process the data like we think, and we can guide
And we
it.
can do that now, and that's not just about high-income countries, because now there
Anybody
are
can
many.
do it.
As I said, just with ICP and CPP alone, you can start to look at much more intricate and look at much finer points of electrophysiology and
Imaging.
autoregulation and imaging that really allow us, and so we get that already. So this is
Functional.
not data that a high-income country or a low-middle-income country does. It takes away the differentiation. It's something that can be done with engineering in every country, which is exciting.
Yeah, those terms are prejudicial, I'd like to say. They sort of debar some countries and give some other countries relief when they should be equal care.
Yeah.
Thank
So
you.
I'm very excited.
Thank you. Yeah, the future looks bright. Thank you, sir.
Yeah. Thank you.
Thank you, Chairman. I would like to thank Professor Sinha to invite me here to share our research data here about how to treat traumatic brain injury. So my talk is the new therapy for traumatic brain injury. Actually, it's based on the drug repositioning and also stem cell application. Traumatic brain injury is a common cause of disability and death around the world. And the global annual incidence is estimated around 64 to 74 million. And it's commonly associated with physical, cognitive, and behavioral sequelae, and also is a risk factor for later development of neurodegenerative disorders. Currently, there's no any approved pharmacological treatment. So there's a disorder of significant need new drug development research. Actually, there are two biochemical phases after traumatic brain injury. The first one is external mechanical force applied to the head. That causes acute tissue damage, cerebral ischemia, vascular injury, diffuse external injury. So the brain damage is substantially dependent on the severity of the impact, and there's no any treatment possibility. The second phase is triggered by the primary injury, and it consists of neuroinflammation, cerebral ischemia, mitochondrial dysfunction, and glutamic cytotoxicity and hypoxia. And they are the potential target to be treated. So in our research, we target two areas. One is anti-inflammation, and the second is neuroregeneration. So what is the drug repositioning? Actually, it's an act of taking a drug intended to treat one patient population, and we can demonstrate its efficacy in the treatment of a complete different group of patients. The advantage of drug repositioning is takes less time and also less money to develop a new treatment, especially the less time because it can fulfill the demanding of a new treatment by patients. In the past, actually, there's two repositional drugs put on the clinical trial for traumatic brain injury. One is acetylcysteine, which is a mucolytic drug for respiratory disease, and the second one is minocycline as antibiotics. Yeah, in our group, we just identify pomalidomide, this drug. This is actually is an analog of thalidomide. Currently is used in the medical oncology for multiple myeloma. And also, in addition to anti-cancer treatment, pomalidomide also has an anti-inflammatory effect. And in the previous study, we identified pomalidomide given to the TBI animals and can reduce the inflammation and provide a significant neuroprotection in the animal. So in order to develop this compound to be a potential treatment for the TBI, so we just test the analog for the pomalidomide. the 3,6 cell pomalidomide, actually we try to see whether the anti-inflammatory effect is stronger than the pomalidomide. And so we treated animals 5 hours after the injury, and we give this IV into the animals. And you can look at the MRI for the brain tissue loss is 24 hours and 7 days. Actually, there's a dose response from the 3,6-diacylmide. So that means there's a higher dose 3,6-diacylmide actually can preserve more brain tissue loss. It is better than the pomalidomide. And the protection mechanism is really come from the reduce the pro-inflammatory cytokine expression. So you can see, especially the activation of the microglia can be suppressed, and also as well as the biomarker TNF-alpha and etc. And you can look at the data here. 3,6-diacylpomalidomide can suppress more inflammation than pomalidomide. However, this compound is a major pharmacokinetic effect. It really comes from the binding to cerebrum to act the anti-cancer, anti-angiogenesis, and anti-inflammation, as well as teratogenic effect. So in order to avoid the teratogenic effect, so we try to whether can develop an analog only can have anti-inflammation effect without binding to the cerebrum. So that's why we try to do the changes. Actually, based on the structure, there's 2 structures. There's a glutamine structures, which is a major binding site for the cerebrum. So whether the adamantium 2 is a big structure, try to avoid the binding to the cerebrum. The binding site for the cerebrum is very shallow. So put this big structure on this side can minimize the binding to the cerebrum. So we use the compound to treat the TBI animals. You can look at the data here. It's a very good tissue preservation from the TBI injury. And also, without binding to the cerebrum, we didn't lose the anti-inflammatory effect. Actually, you can see here, the still can suppress the activated microglia, especially the number of the activated microglia cells, and also the expression of TNF-alpha. And another compound called tetrahydropolyamide is also, we try to put this big structure on the glutamide. And that's to avoid binding to the cerebrum. So this compound to the animals, you can see there's a better behavior recovery after brain injury. Look at the beam walking test and also GAIT analysis. Also, without binding to the cerebrum, we still can achieve very good inflammation suppression by using this compound. Because based on the analysis of the morphology of the microglia cells, it has a very good anti-inflammation effect by using this new compound. So in summary, so all these derivatives from pomalidomide can achieve very good anti-inflammation effect, even without binding to the cerebrum. So this we can just avoid the teratogenic effect and push this compound to be highly potentially be used in clinical to treat the traumatic brain injury patients. So the another treatment is a neural regeneration. We use mesenchymal stem cell and carry FGF21, try to improve the functional outcome after traumatic brain injury. I think everyone is familiar with mesenchymal stem cells. These stem cells can provide anti-inflammation, neuroprotection, and also neurogenesis by releasing the trophic factors, and also it doesn't have too much immune rejections by using the mesenchymal stem cells. Because the stem cells, the migration characteristics, it can use as carrier to carry drugs or interesting to treat disease. And the FGF21, this factor bring brought to our attention because when we did a neuroprotection role of the mood stabilizer, lithium, and the anticonvulsant, deparking for their effect. And it turned out these two drugs can upregulate the FGF21. So it's because of interesting to want to know what the role by FGF21. It turned out it's activated cell survival pathway by through phosphorylated AKT1, and also can protect the neuron from glutamate excitotoxicity. So you can look at the panel on the left side. It says very good neuronal protection from the glutamate toxicity. And this is by increased phosphorylated AKT1. And also we did cerebral ischemia animals. And in these animal models, the FGF21 can preserve a lot of brain tissues, and that's reduce significantly the brain tissue loss from the cerebral infarct. So then we try to whether we can put this factor, because the half-life for this factor is very short, it's only 1 or 2 hours. So for practical to use in the clinic, we need to put this factor in a stable condition to be released, especially if we put in the stem cell and also express from the stem cells, and we then put the cell into the brain, probably can get a beta FGF21 release in the brain. And we successfully established the stem cell with overexpressed FGF21. And so in the animal side, you can prove there's enough amount of FGF21 release in the brain tissues after the injection into the brain. So then we did the TBI animal models. It's as 1 hour after the injury, and we just deliver the cells into the brain. So there's a stem cell alone or stem cell with FGF21. So you look at the data here, 3 weeks after the injury. So the stem cell with FGF21 really can get a better memory learning improvement. If you look at the 4 weeks after the injury, actually stem cell alone also can improve the memory and the learning function, but not as good as the stem cell with FGF21. For cognitive function test, both stem cell and the stem cell plus FGF21, both they can improve the cognitive functions. And the mechanism for this functional improvement is really from the neurogenesis. We can find out the number of newly born neurons in the dentate gyrus, and also this newly born neuron carries a normal morphology of the normal neurons. And there's a dendritic morphology defect after the brain injury. Usually is a very obvious morphology change. However, the stem cell with FGF21 can push all the dendritic morphology to a normal population. You just look at the pink color areas, compare, so the normal animals, and compare with the stem cell with FGF21. So it can keep the dendritic morphology in the normal situations. So the summary for the stem cell therapy with FGF21, so it can really increase the level of FGF21 in the brain and induce neurogenesis and improve animals' spatial learning and memory. So in conclusion, so this our research we can identify probably can use pomalidomide derivatives to treat TBI patients by just reducing the secondary injury from the inflammation. And also can use the mesenchymal stem cell with FGF21 to increase neurogenesis and improve learning and memory functions. And all this work is done by my teams, so as I really appreciate their contribution. Actually, because the time constraint is, the talk is very short, but actually it's a lot of time and spending in the lab to do to get this data. So in the end, I will welcome all of you. Save your time in this year, November 7th to 10th. So the 17th Asian Association Congress of Neurosurgeon meeting will be held in Taiwan. Save your time because you're attending to this meeting will enhance our program level. Thank you.
providing best answers to promote neurology. Any questions from the audience?
Thank you.
Thank you very much, Dr. Chen. So I invite the next speaker, Dr. Wang, who will be talking on biomarkers. Dr. Wang, can you come? I think it's not. For talk on conditions of osteoporosis.
I have to say thank you to Professor Signa and all of the committee. I have a disclosure. I have to say that there are no advances about the contusion of the posterior fossa. The first paper was published in 1952, but there are not so many evidence in the literature regarding the posterior fossa contusion. Why? Because it is a rare instance. The incidence of traumatic cerebellar hematoma ranges between 0.4 and 3% of all TBI, and the range of traumatic brainstem hematoma is more or less 1.4. These data are data from tract TBI cohort. The posterior fossa has many anatomical safety features like the paranasal sinus, the angulus of sphenoidus. The steeper the angle, the less the resultant force. Of course, the stiffness of the tentorium, the presence of CSF, and the eccentric atrioaxial joint that can reduce the rotational forces. So, which is the traumatic mechanism? In case of brainstem contusion, the traumatic mechanism is a cope injury. The edge of the tentoria, if the edge of tentoria is very close to the peduncle, cerebral peduncle, can happen that the contusion is in the cerebral peduncle. In case of cerebellar contusion, both high-speed and low-speed accident produce in equal frequency intracerebellar hematoma. Dr. Takeuchi classified the cerebellar contusion in two types. The first type is type 1 in 2/3 of the contusion of the cerebellar, posterior part of the cerebellar, 2/3. And this kind of contusion were due to cope lesion or contra-cope lesion. And the type 2 contusion, 1/3 forward the cerebellar, mainly due to acceleration and deceleration injury. In case of type 2 contusion, the hematoma were more frequent in type 2 contusion and is associated with basal system obliteration and the collapse of foreventricle, which is the contusion evolution. Of course, can be very erratic evolution, up to 96 hours, with delayed cerebellar hematoma that can grow after few days. And be careful, because the posterior fossa has a small reserve capacity, and so it's happened that we can have a deterioration of the neurological status. So many authors suggest a delayed controlled CT scan, and someone suggests a daily CT scan until the lesion is stabilized. But what about the posterior fossa ICP monitoring in case of traumatic contusion of the cerebellar? The current evidence are very, very low quality, but there is no way that ICP in posterior fossa value are significantly higher than ICP in supratentorial. But the role of this ICP monitoring should be established for the posterior fossa monitoring. This paper was published 1 year ago, and it was not regarding the contusion in posterior fossa, but regarding the cerebellar hemorrhage. These authors, coming from Austria, published this paper, post-operative monitoring in posterior fossa, and they found that an elevated ICP in posterior fossa alone is associated with a poor neurological outcome. But the problem is the target ICP threshold value. After that, we can start to treat this patient. Of course, it's a matter of size. For instance, this paper compared two groups of patients, traumatic brain injury patients. One group, 29 patients with brainstem contusion, and another group, 29 patients without a brainstem contusion. They found that these patients has the same outcome after 6 months, but there is the lesion of the brainstem lesion should have a threshold lesser than 1 centimeter cube. So we consider sometimes these patients has a nail in the coffin, but these patients with a contusion lesion lesser than 1 centimeter cube can have the same outcome than traumatic patients without a brain contusion. It's a matter of size even for the surgical indication. Starting in 1982, Dr. Pozzati wrote that surgery is indicated for hematoma greater than 3 centimeters, which is the clinical ID of traumatic cerebellar patients affected. Usually these patients has a skull fracture in 76.5%. The site of impact usually is occipital, and the GCS on admission is, the score is 11. But there are some negative prognostic factors like GCS on admission and the associated intracranial hematoma supratentorial. This is our series. We collected 26 patients from 2011 to 2023 with a mean age of 73. It's quite old patients. Mainly were mild TBI patients, and we detected that type 2 hematoma were significantly larger at the presentation. The hematoma topography is significantly associated with the neurological status on admission. In our series, we had 10 patients that were taking antiplatelet or anticoagulation therapy. 5 patients had a volumetric progression, and 14 patients cases had a post-traumatic supratentorial hemorrhage with mass effect. Just 5 patients were operated, 2 a suboccipital craniotomy to evacuate a cerebellar contusion, and this is interesting. We had no cases in case of supratentorial surgery. We had no cases of post-surgical volumetric increase of the cerebellar contusion. We had 15 patients, 72% of poor outcome. This is the data from literature, and the poor outcome ranges between 50% and 60%. But look at the series of patients are very, very small. So this is a case that I want to escape, just to go to the conclusion. The conclusion are, do not give up to care small brainstem contusion, smaller than the 1 centimeter cube. The posterior fossa ICP monitor is still under investigation. The surgical indication is a contusion larger than 3 centimeters. The control CT scan is mandatory until the contusion is stable, and the hematoma topography is significantly associated with the neurological status on admission. And remember that a singular traumatic intercerebellar hematoma may have a good prognosis. Thank you.
Thank you very much. That was a great talk. Quick question for you. Did you find any concomitant spine injury with the posterior fossa bleeds? And I ask because in children, and I realize it's a different cohort what you're looking at, a posterior fossa bleed, especially small ones, subarachnoid hemorrhage, are not infrequently a sentinel sign that you need to be absolutely sure that there's not an upper cervical spine injury. That's in children, especially in young children. That's what I'm asking. Did you find any cervical spine injuries in the series of posterior fossa hemorrhages?
As I said, we have patients, older patients. The mean age was 73. Okay. We did not have any spinal injury in case of in this series.
Okay.
But they were very old patients.
Okay. Thank you so much.
Okay, thank you. So our next speaker is Dr. Benson Misra. He will talk about the management of head injury then and now, a nearly 5-decade journey. Please.
Good afternoon again. This is a slightly different talk than the talks you heard, the advances and the innovations. Where were we and where are we now? Can I have my slides, please? Yeah. So this is, I did my first neurosurgery house job in 1977 for 6 months and in Delhi. So that time we had the plain X-ray, and then we used to do the stick angiogram, which used to call at the middle of the night, unconscious patient, vocal anesthesia, sometime restrained, 2 people holding it, and you puncture the carotid. And we did manage to save some, but it was a torture, both for the patient and for the doctor. We also had, when the patient did not have time for an angiogram, we did exploratory burr holes, especially if he had a fracture on the X-ray skull. And there was another one which was useful for repeat studies, was the B-mode encephalography. The young people today wouldn't have seen that. All this advanced ultrasound, this was not very unprecise, and you could see the midline shift and decide whether to go in or not to go in or repeat or whatever. And these were the shifts we were thinking, the carotid shifts, you see the ACS shift, and then these were conclusions which would come out of that, and then you could diagnose whether the mass is below in the temporal lobe contusion. You could see the extra-axial hematomas on angiogram. And this was done by a neurosurgery resident, and used to do almost 2 to 3 because I was in a referral center in Delhi. And so 2 to 3 a night. And from 1980, we had the first CT scan, but it was available for about a couple of years only at daytime, but the technician was not available in the night. So we still, in spite of the fact that CT was there, in the evenings and nights, we still had to do this the angiogram, unfortunately. And anybody who had a significant midline shift and in altered sensorium, or a patient was deteriorating or seizure and had come to us, would go in for surgery. And many times we didn't know what we were operating, but there was a mass, it was an extradural, intradural contusion, whatever. So we had to go in, we didn't find the extradural, we open up the dura, we don't find that, then you take out the temporal contusion, we used to remove that. But that was the dictum as a resident you are taught that every extradural hematoma, based on the midline shift where the diagnosis made, should be operated and urgently. And I still remember distinctly that my second year of residency in AIIMS, All India Institute, Delhi, and we had a Delhi Neuro Club. And there was a gentleman, very senior neurosurgeon, very well-trained, American board, and he had one of the first scans also in Delhi. And in one of these, our monthly meetings, he came and showed a CT scan. I don't have those pictures, but it's an extradural hematoma which he had conjured. And that was furor. My professor, they were all jumped on him. How can you say extradural hematoma can be conjured? Because we were deciding the indication of surgery extradural hematoma on the shift. And very often you have this small extradural, we all know that, which doesn't need any treatment. But since this angiogram findings was extrapolated on the decision making on a CT scan, all small extradural hematoma seen on CT was being evacuated then. Of course, it changed, and many extradural hematoma do not need treatment, and that we know that. But that was a kind of a sentinel event in my career, in my residency. We all thought that guy was a stupid guy who was talking that patients said, will die. How can you do that? Now, there was a group of patients which I got interested. This was one of my dissertation in my residency, severe pediatric traumatic brain injury. And these were the children who some of them would come conscious and the CT scan would not show a hematoma contusion, but very tight brain. Whether it was raised intercurrent pressure, the debate was whether there is hypervolemia and management, whether you should be doing hyperventilation or dehydration, so on. So that was going on. And then we had another young consultant radiologist who was interested in this. So we did a prospective, first a retrospective part and then prospective. And we tried to evaluate the CT scan and correlate with the prognosis of these patients. Now, these were some of the characteristics where sometimes they're initially okay, they would deteriorate, and some of them died. And death rate in this group was around 20+%. So when we evaluated this, and this was 1982, we presented in the first Indian Pediatric Neurosurgery Conference in Bangalore, and this was this was what we presented there. And you can see that one of the conclusion on this was obliteration basal cistern is a grave sign in head injury. This, in fact, was the first time reported in the literature. This was published. Unfortunately, it was published in an Indian journal, which was not indexed. And so we never got the credit for this, but I think this is by far the best work in my last 40 years career, because this was a finding which we found out independently, and this was a resident then. And this, of course, was the milestone paper in 1984. Ours was published in January. This was published in September. But JNS, obviously, and so these were the classic paper that compressed our absent basal cisterns, are severe, are grave signs, which we had told in 1982. And then that time, the medical management was based mainly on Glasgow Coma Scale, which is still relevant. I think this was one still we are following. And these were the type of things we are doing: restrain, dehydrate patient, unconscious patient, dehydrate, mannitol. One of the things which we did, and Professor Mehta, I don't know if he's there, he was responsible for this study. And we realized that because of the lack of ventilator care facility, lack of ventilators, the patient had to be managed without the ventilator. So we heard from the Weller group, the early tracheostomy was the norm. Because we realized a lot of patients were dying or becoming bad because of the bad chest, because they were aspirating. So very early tracheostomy. And that time, Dr. Mehta, who was my senior in AIIMS, we had a study between AIIMS Delhi and the Virginia group in US. And there was very little difference between the very high-tech treatment, this was 1980s, and our group of patients, except one group, which is M5. That's why I talked to Dr. Mehta today. That's only one group of patients who did better there than us, but all of them, there were very hardly any difference in spite of the not having so much of technology at that time. 90s, we started doing more and more ventilatory support, ICP monitoring. We were conscious about the CPP and so on. And then 2000 onwards, we started having advanced monitoring. We still continue to do that. How much it's contributing to outcome, I still don't know, but it is done. MRI was available to us in 90s, and very few MRIs were done in head injury. In my practice, I still don't do MRIs, except when we want to prognosticate, but the acute management, we hardly do it. And this was the nursing side, and early tracheostomy is still the mainstay in many hospitals in our country till today. So ICP monitoring, the first we started with feeding tube. One of my colleagues who had a vegetation, my colleague during residency, he used to do this monitoring group of patients. And then I worked with Douglas Miller, who was, as you know, probably one of the best investigators in head injury, ICP, blood flow, and so on. So we used to compare different his patients. Every single patient has to have two kind of ICP monitoring, and we realized at the end of my one-year study, I was involved in that study, there was very little difference between the ICP results and the patient's outcome when you used very high-tech intraparenchymal or fiber optic monitors or the subdural bolt. And till today, since 1987, since I come back, I still do a subdural catheter, though we have the very high-tech intraparenchymal fiber optic monitors available, so expensive. And the difference in the outcome is so little, I haven't changed. So I do a subdural catheter, which costs about maybe $300 or something, available in India. Now, 70s to 90s, most temporal lobectomies were done for temporal contusion. Brain was in the bucket. The anesthetist used to joke about it, and they would kick the bucket and they would say the brain will move. And the thing which we did that time, which is a resurgence of that, was my professor used to train us, and this was the influence of Veller Group and also from Oslo. So every single patient where you had to take out the temporal lobe, we would also tentorial section, we would do CSF, we release what is now being, something which is developed as hysterostomy. And many patients did survive. Now, 90s onwards, the temporal lobectomy almost went away completely, and there was much more of medical management, elective ventilator, reducing the ICP, repeated imaging, and blood flow focused treatment. And then on, the trend of decompressive craniotomy came. I think from 2010, this became more and more people started doing it. And the mostly decompressive craniotomy was intractable refractory ICP, early type of the craniotomy, which is in the West. Now, we started doing a study which is early protocol-based decompressive craniotomy, because many patients would not have two surgery, putting an ICP, wait for the ICP to go up and for a decompression, multiple imaging. If the patient deteriorated clinically, we would put same time decompression and ICP monitoring, and we did publish that. So this is the New England, of course, the classic paper of decompressive craniotomy, which showed that the survival increased, but the morbidity also increased. The rehabilitation took a long time, for 12 months patients to be. So whether it is relevant to LMIC, Dr. Franco Servadi all talks about it. And this is our publication, a protocol-based early decompressive craniotomy in resource conservative constrained environment. And this is our experience. And this is we are not the only ones. This has been published from other LMICs, and they also early DC, which would probably reduce the burden on the hospital. Now, my final thoughts. What is the value of technology? I did talk about it. How much has high-tech, expensive management changed the outcome? And how relevant it is in LMICs? What is the burden on the society? And unfortunately, in many countries like mine, patients do pay from their pocket. And we did that, had that discussion, and the Vellore Group presented, what do you do? It's a very, very difficult situation when you have to decide. You act as God, which is a very, very painful thing. But it does happen. It's a practical thing. We face it every single day in our practice. Different hospitals have different phase. I am in a different environment now, so it's not that painful, but it is. So should we divert more proportional resource to prevention and rehabilitation, at least in LMICs, till the high-income countries show us that this works, and the money, the amount of investment we need to do to have that kind of monitoring is much, much less. Till then, I think the way to go forward would be, we have the data, we have the patients. So all the high-income countries, the multinational studies which are coming up, I would suggest, I would appeal to them, pulling these patients from these countries like the LMICs, our country, other countries in middle-income countries, low-income, you will get the volume of data which you will give, and we have centers of excellence in these countries where you can have reliable data, you can have good follow-up, kind of data to come out with conclusion much faster than, with much less expense than if you just stick your the research in the high-income countries. So to my mind, the future is, there's no question it will be available to majority, but that will take time. I think the current be miles to go. Way forward, as I say, multi-centric trials with LMIC. The leaders are sitting here. I would appeal to you, think about it. Thank you very much.
Any questions?
Actually, thank you very much, sir. Because what you talk, we have a generation of people, very young to the senior people, like Dr. Mehta was gone to the underground ways and beyond the It was really a very good talk. So, any questions from the audience?
What do you think, David? Do you think?
Can I ask one question? Over 50 years, like you presented, has the mortality really changed? The increased availability of technology and monitoring?
No, this is definitely improved. There's no question. It is definite because.
And we have data to support that. Dr. Edison is also here. Like Brain Trauma Foundation, 30 years after BTF Foundation, the mortality declined in America. So it took 30 years even for America for mortality decline after foundation of brain trauma. So do we have such data from India?
What is I? It's a lot of echo. I didn't get it. After 30 years, what happened?
After 30 years of Brain Trauma Foundation, mortality in America declined.
Yeah. So right.
So it took 30 years.
Yes.
30 years even for the developed nations to show the effect of the guidelines.
No, I think in India also it has helped, but to the extent the amount of money we need to invest is probably disproportionate.
Basan, I absolutely agree with you. It was a wonderful talk. I touched on it myself. The ways that we improve outcomes in the long term is avoiding the primary injury or mitigating it, so going with your idea about prevention. It's the second part, which is how do we improve how we manage the patients, because many times we're very nihilistic. We see a trauma patient, and there are many LMICs that if you come in with a GCS of 8 or less, you just put in the ICU and you either survive or not. And I think that you now see that indeed, even adding a little bit of technology can improve outcomes. I think it's more the meticulous adherence to detail and us avoiding those second insults that we make improvements. And then to your third point, I think rehabilitation, that's a whole new frontier. And I know we have some talks this afternoon about neurorehabilitation, but clearly our challenge is how do we really maximize the outcomes for these patients, and where is the money best invested? And I don't know the right answers. I mean, we just in healthcare, we tend to treat what's already occurred. They've already gotten a cancer. They've already gotten a heart attack. They've already had the stroke, or now in this case, a traumatic brain injury or a spinal cord injury or whatever. We're now treating that. But you're absolutely right. If we could figure out how to prevent and then how to improve the rehabilitation and use all of those strategies together, then we'll improve the outcomes.
I just want to add one thing about the ventilation and GCS below 8. You know, I worked in different settings. Now I work in one of the best settings in the, anywhere, whatever you have, I have it, right? And I have worked in centers where you could not, and I have visited centers like GCS 8. So ventilator in centers where a very limited facility is a double-edged sword. So it may be better for them to do a tracheostomy, which like we heard from Veller Group, because then you take away a lot of, you know, kind of, so it's a very, very difficult balance, unfortunately.
Yeah, no, and I think the strategies have to do vary from place to place. And some of the works that Andres Rubiano has been working on, looking at different, and as the United States has done, different levels of trauma centers. And so trauma is local, but they're figuring out how to transport or who to transport using the concept of biomarkers. I mean, I think there's just so much out there that we don't know. And I think that there's a lot available from HIC, from LMIC, to even instruct HIC in better ways to do things. And we could do things much better. We're even where I now work in West Virginia, we have a very low socioeconomic population and a rural population, and decisions for transporting patients, you know, we get patients linear skull fracture, subarachnoid hemorrhage, and like, why did they come? We now end up transporting them 4 hours back to where they came because they didn't need to come. But we also have the converse, which is, here was an epidural which was salvageable and then never got care. And so then, you know, what's the balance act there? So,
Thank you.
You bet.
Thank you.
We have two talks which we are remotely online. First is on biomarkers by Karen, and another is by Dr. Andrews on nanotechnologies. So, can you please introduce? So thank you for organizer for inviting me to the talk. Unfortunately, I cannot today. So it's on our recent advances in neurotrauma. So as we know, there is some phenotypes of EBI, including edema, contusion, different types of hemorrhages, as well as diffuse axonal. And then we can also convert it to chronic neurodegenerative phenotypes, such as chronic symptomatic encephalopathy or sometimes disease. And so we like to think of like blood-based biomarker tests. We can measure some of this brain protein and reflect on some of the subphenotypes I mentioned. So for instance, UCHL1 is neuronal cell body biomarker that's T factors and its breakdown product. So PAD3 biomarker, whereas NFL and NFH are the referment protein for axonal injury, and then how we pick out the neurodegeneration biomarker. On the right side, importantly, they all seem to have different tempo. The UCHL1 is really early followed by CFAP, and then you feel potentially later. So each of the boxes have different tempo. Another important thing is that there are many now high sensitivity assay platforms such as mesoscale discovery and others. They can reach down to the subpicogram now level of detection for these markers. And so that really enable ourselves and our to be able to precisely monitor some of these clinical samples. And so we did all the work on clinical cycle and model. So we actually have a level of confidence of market. But more importantly, we can say that many of these markets, as I mentioned, clinical study and often in terms of using large overall consortium-based study like Liquid Sense, VA population in the US, tracking reality in the US, and central reality in Europe. And so T-value, UCL1, I mentioned, probably the most studied biomarker in history for discovery. And turns out its level is 12 hours after injury, and in mild TBI patients, it says 13 to 15. And really inform on whether they are likely or whether the patient may have a CT detectable injury. So if you look at the left side, the CT possibly, if you like, have relatively high level of UCHL1 from the beginning to the other. And then the delay also high level of the T-FAT over time, so just 24.8 hours. But whereas if you have a patient that are CT negative, they are very similar pattern, except that the delay signal are much lower. So by setting sort of cut off, we conceptualize that potentially can identify CT positive or CT negative. In fact, this was confirmed in this original study, confirmed by Nasserian at our paper using 2,000 subjects. And you can see that those that are CT positive basically have high both T-FAT and UCHL and negative compared to those that are CT negative for both biomarkers. And then UCHL and T-FAT not only can be diagnostic, but also the first 24-hour level. And we put prognosticate. So you can see here basically the combined use of T-FAT and UCHL1 can produce predict the GOSE as an outcome measure. I could want to step the state, I want to forward so we also find that even in addition of using impact score, the additional use of impact research can further improve the prognostication efficiency. And axonal injury marker, your now is gaining a lot of momentum. This is our work that we just impressed. We find that your now has a very long delay of peaking, if you like, in past or in zero. So it's not doesn't peak until around 30 days. It's a genetic analysis. But in the beginning, there's already a higher level of severe pediatric approach. That is really in these weeks after injury, and then followed by that the months after injury, they start declining. But even by 6 months, 12 months, we find that the cumulative value is still higher than longer. So in fact, we also look at the utility differential again as a global outcome data. So here, when we look at acute level, that's the week 1 average of the L and hypothesize GOSE favorable versus unfavorable 1 to 4 versus 5 to 8. And you can see that it's higher acute level of the L with favorable post-etc. And essentially, very similar pattern is found with the peak level of 15 to 44 days, average for molecular level 2 to 6 month average, as indicated by the ROC curve in this area. And the last two biomarker I want to profile is the neurodegeneration marker, tau and p-tau. So they show yet a different chemical profile, and both of them peak around 4 to 5 days for this injury. The p-tau is still in the field in 231 site. And they, so these are the timely before. The other thing I want to draw to your attention is that there's a maximum 7-fold increase on total tau by day 2 to 6 compared to healthy control. However, p-tau actually rises such as close to 300-fold by day 2 to 6. So there is a net gain of 37-fold like p-tau to tau ratio. So that would represent a shift of the pathological form of tau. And again, consistent with that, we looked at global outcome, OTOSD and also PRS, disability rating scale, the minimum disability scale to 4, or intermediate 5 to 14, or higher disability 15 to 30. And lo and behold, the total tau are actually insensitive to distinguish from these categories of PRS. However, p-tau at the 1 to 6 month average level are quite strongly correlated with the PRS category. The higher the PRS, the higher the p-tau level. It's reflected by the ROs. So to quickly summarize, right, so the UCHR1 T bilateral had gone through initial FDA clearance for the fall by Apple. They put it on this tender market on the ISA because this was the Immunity One product sheet, followed by my French company, which is Manufacturing, and adopted as their virus patent. I just want to show you a little bit the reasons that is there. So I said, TBI said, this is how it looks like as a cartridge, and put the plasma sample on currently with an older version. And then after 17 minutes, you were able to detect both biomarker and the device, if you read it, device, the machine, it will give you a value for both markers. And if one of the markers is above the cutoff, as t-tau above 30, or UCHR1 above 360, people can let's consider elevated. Elevated in this case would be yellow arrow. So that indicates slightly to have CT detectable lesion. And one thing that we did was compare the eyes that UCHR1F with those with carcinoma for research testing. So actually, there is a decent correlation. And I think similarly, the GFAP is even a stronger correlation between the ISTEP and the cinema. And this is the, and here is the eyes of this call sheet, by Apple also, which very similar performance. And they think that there's a much larger dynamic range to work with, and the cutoff for both markets are very similar. And this is sort of a random assay for that. So similarly, the blue virus system also have just rolled out the T-FAB and CHR1 serum test. And you can see that the sensitivity is again for detecting CT lesion is close to 97%. And the assay only quite automated at only 39 minutes. So, and again, very similar cutoff to what is shown for the other. So we are trying to evaluate the performance of some of these OLAP and automated machines. And to summarize, there are many utilities of PDFR. We already see the CD recognition correlation, but we think that concussion is another area that was actually used as a prognosticator. Precision medicine comes to mind, and how to monitor the disease score, particularly severe. And then we think about how they can be used to assist the therapy development from dynamic nutrition response of the surgery endpoint. So with that, I thank you for your attention. One more slide is the so Emory University and the Children's Healthcare of Atlanta, Dr. Andrew Reisner, a lot of background. He is also a strong collaborator. Thank you.
Yes, my question to program. We have one more online talk, which is yet to come, and one more person. So we are taking for lunch at present, and we will be receiving after lunch. So I thank my co-chairperson, Dr. for joining for this wonderful session, and I thank all the good speakers. Thanks so much.
A session on CV Junction. The chairpersons for this session are Dr. Visochi, who's a professor in neurosurgery at the Catholic University of Rome, Italy, a visiting professor at the Shanghai University, China, the George University of London, and the Mumbai University. We have Dr. Rakesh Kumar, who's a complex spine fellow at the Virginia Mason Medical Center, Seattle, USA, and ex-associate professor, Department of Neurosurgery, Dr. R.M. LMS, Lucknow, India. Do we have Dr. Girish Solanki with us? Dr. Girish Solanki is the third chairperson for this session. So we have a scheduled tea break in between the sessions, and it will be totally the decision of the chairpersons whether they want to give us a tea break or not. So I hand over the proceedings to the chairpersons. Thank you.
We can start now.
Good evening to everybody. It's a great honor to declare open the presentation in these very difficult neurotrauma fields, craniovertebral junction trauma or injury. And we are waiting also for our colleague Girish Solanki. We hope that he will reach us. Nevertheless, we have to start it a little bit. It is a little bit late, so please, I ask my colleague to introduce the first speaker.
Thank you very much. Yeah, thank you very much. So we are going to start with first presentation with Dr. Eva Shai from Canada, and she is going to speak on spinal cord and brain repair with neural stem with the biomaterials and progenitor cells. Welcome.
So thank you very much. I appreciate you being here. This is a little bit different from the cranial cervical junction, so, but it does apply in that we're talking about trying to repair injury. And so there's been great talks on trying to prevent injury and what to do when you have injury. And so this talk is a little bit on trying to translate and improve therapy. So the reality is that there's so much research out there and none of it actually works. So even with good preclinical animal research, there's an 87% failure in cancer, over 90% failure in stroke, and we all know there's about 100% failure in traumatic brain injury, and essentially 100% failure in spinal cord injury. With respect to spinal cord injury, there's been some promising studies, but nothing's ever panned out. Riluzole, the primary efficacy endpoint of change in upper extremity motor scores at 180 days was not achieved. Minocycline, not established. Lithium, no improvement of motor function. And those are the neuroprotective therapies with respect to brain and spinal cord. Now we look at regenerative therapies. So we can't prevent or minimize the injury. What can we do to actually repair the injury? Bone marrow stem cells, there's a few randomized controlled trials. You often may require physiotherapy. You know, maybe it's the physiotherapy alone and not the cells. Neural stem cells, it was stopped. It didn't meet its primary efficacy endpoint. And Vertex stopped its phase 2B spinal cord injury trial for futility. So what can we do? So in our lab, we've been focusing on not necessarily developing new therapies, but actually translating. And so our program is called STAT to Humans, or Successful Translation of Animal Therapies to Humans. And so where there's people who've been focusing on basic science, and people have been focusing on clinical application, we've actually been focusing on trying to improve translation. So what does stat to humans actually mean? Well, for example, with spinal cord injury, you need to choose the right patient. So as we learned earlier, all head injuries aren't the same. All spinal cord injuries aren't the same. There are some patients, and one of the biggest examples is potentially like a cervical or central cord syndrome versus a spinal cord injury. So those aren't necessarily the same. The cervical versus thoracic may not be the same. The other part to our program, we're trying to identify the correct tracks to fix, and we also want to confirm translatability to humans. And so I'm going to talk about those things in different details here. So, for example, choosing the right patients. So with the minocycline trial, we found out that there may have been an effect with cervical injury, but not an effect with thoracic injury. And that may be because if a thoracic injury, you need to have recovery, you have to generate a whole long distance to get to the motor tracks, to get the legs to work. Whereas in the cervical, you might get some improvement if you just get a level. And so these are the kinds of things we need to understand in order to choose patients properly to actually see a meaningful difference in our trials. So as part of that, and we talked about this earlier with respect to brain injury, people have been developing machine algorithms. And so we've developed a few different types of machine learning and algorithms and trying to subgroup these patients so that we can properly have improvements in our ability to predict, ability to walk after, but also in order to select patients properly for trials. And to that end, we're also looking at different ways of biomarkers also to select patients. So, for example, we have a patient who has a spinal cord injury. We sometimes can get an MRI where we can see, a little white blob and a little black blob, and, but we really, no one in this room can tell me what actually this patient has. Do they have arm weakness? Do they have sensory problems? Do they have leg problems? Do they have leg weakness? Because we can't really tell based on our imaging. We do our best. We try to realign and we try to fix, and in the end we see like this little blob afterwards after the injury. But if we can understand which tracks are damaged, maybe we can improve our ability to select patients and our ability to then choose the right patients for clinical trials. And so to that end, we've been developing a clinically applicable method of doing tractography in the spinal cord. And here you can see there's some disruption of the fibers, and not just the fibers here, but maybe potentially more fibers posteriorly, which means he may have more of a dorsal column deficit. So here's an example of a patient. Normally we look at the imaging and you see that maybe it's a little bit more narrowed on this side, so you'd think that they'd have more deficits on that side, and in reality they didn't. This patient actually had an almost contra coup injury, and we can identify that with tractography, and we can see the disruption of the fibers there. And so we've been actually looking at this in more detail to see if we can actually distinguish this. So we can look and see that there was a difference between the right and the left tracks with respect to, say, the motor tracks, the corticospinal tracks, but maybe not necessarily a difference with respect to the dorsal column effects. So now we can potentially use these measures to pick out which tracks are damaged, and then maybe properly select these patients for a trial that would regenerate, say, the corticospinal tract or regenerate the dorsal columns. The other aspect to this is looking at to make sure whether or not our patients are similar to the animals. And while some of you might think that some humans are rats, and maybe at that buffet table that we had this lunch at, you might think that some of us are pigs. The reality is we don't know how well a human correlates with a rat or a pig. And with respect to the stem cells, it's really fascinating that we've developed all these therapies and we've gone on to clinical trials when we don't know whether or not these stem cells in animals actually correspond or grow up the same in humans. And why don't we know? Because we can't actually get primary human brain cells and primary human spinal cord cells that are healthy enough to test. We can get cell lines from embryos, but those are different. And as soon as you passage them multiple times, they're not the same kind of cell as what you have in a human after they have an injury, especially an adult human. You can have surgical specimens, but those are all usually damaged because we're not doing surgery on somebody who's healthy. You can get autopsy samples, but by the time you get those tissues, the cells are usually dead and you can't do cell culture, you can't do electrophysiology, right? And you can, and so I often ask, and when I give this lecture, I ask, who's going to give me their spinal cord? Nobody wants to give me their spinal cord. Who's going to give me their brain? Nobody's going to give me their brain. But if I don't have human brain and I don't have human spinal cord to compare with animals, then how do I know if these animal therapies even are relevant? So we're going to unleash our limitations. And so this is what we've done. together working for about 3 years, we got ethics approval to obtain live human spinal cord. And how do you get them, you ask? Well, we get them from organ donors. So after they get their hearts harvested or their lungs harvested or their kidneys harvested, we then have get a separate consent, and patients' families agree to let us harvest their tissues for research. And so we've been able to get live human spinal cord, and more importantly, we've been able to culture them. And if you want to see whether or not a spinal cord stem cell is similar in a rat and a human, you should culture them in the same way. And no one's ever done that before. And so for the first time, our grad student was able to culture them in the same conditions. And we were able to culture pigs, which are a normal animal, a larger animal model for spinal cord injury, and also in rats. And we found that we could get neurospheres, or these neural type stem progenitor cells. We could also differentiate them into, so we could find that they proliferated. We could differentiate into neurons. We could differentiate them to astrocytes. We could differentiate them to oligodendrocytes. And what did we find? When you culture a human and a man, they don't respond the same. And so to summarize here, the humans tend to become more neuronal, and the animals become more glial. And so the GFAP was positive in the rats and not in humans. When we look at the things like growth factors and the effect of growth factors on them, sometimes they responded the same. So in retinoic acid, they responded similarly. When we tried to differentiate them into oligodendrocytes, they did not respond the same. And when we tried to use things to develop them into astrocytes, they did not respond the same. We also looked, and interestingly, they talked about inflammatory factors. We looked at that as well. And again, sometimes they were similar, sometimes they weren't, and sometimes they were different depending on the timing. And these are all things that are important if we want to translate these, because we need to know dose, duration, we need to know when to apply. The last aspect of this is we also looked at this with respect to genetics. And to see, we did RNA-seq on these to see if we can find out what are the genes that are required that are similar in animals and humans. More so because if we want to use this animal data, we need to understand what the differences are, okay? And if we want to see what animals have regenerative capacities, we need to know if the humans have that as well. And we've taken this not just with respect to spinal cord, we've also done this with respect to brain. And so I have an animal researcher who's found that if she gives a sequential treatment of compound C, metformin, AMPK inhibitor, and activator respectively, she can turn these perivascular parasites in a mouse, actually she used mice, and turn them into neural stem cells that can actually repair and regenerate after a stroke or brain injury, okay? And so what we've done, she says, okay, well, can you give me human brain cells? Right? And I'm like, okay. So what we did was we took meningiomas, and when we take this, we do our Simpson's grade meningiomas, when we have a Simpson's grade 1, we give them a little sample of the meningioma, of the meninges, and they can demonstrate that. And we can find that, again, these aspects are similar or not similar. So to end here, it's so far, all our results have been a failure, but the other way to look at it is failure is the first attempt in learning. And so with that, our work is trying to improve the translation. And so thank you very much.
Now I would like to introduce our second speaker, Dr. Sushil Vasant Patkar, sir. He is going to deliver a lecture on irreducible unstable odontoid fracture with anterior open reduction and fixation and new technology. He is a consultant neurosurgeon working at Pune Hospital Research Center, Pune. He is a founder, past president of NSSA, former vice president of NSSI, and a member of a spine committee, WFNS, 2009 to 2019. Welcome, sir.
Thank you at the outset, Dr. Sinha, for this opportunity. And I'm lucky that you guys, in spite of the lunch, have come up back to listen to me. And thank you, chairpersons, for being there on the stage for me. So I'm going to talk about irreducible odontoid fractures. This description by D'Alonzo of type 2 being requiring surgery is too simplistic, Because odontoid fractures are, different in elderly and young people. They can be associated with so much of associated trauma, and great forces are required to cause this disruption. I group them like this. Group 1 are the simple ones. Group 2, which requires surgery, but they are unstable, can be reduced. Group 3, which are unstable and irreducible. And group 4, which are not classified, which did not read the textbooks. There's a kind of lateral displacement, locking of the facet, or there's a vertical fracture of the facet, or combination of or they're associated with Jefferson's. So what is the problem in this unstable? That they've got pain, they've got neurological deficit, there's atlantoaxial dislocation, and there is always a possibility of catastrophic death, and therefore they require surgical treatment. But I wish to draw your attention to one point, that all throughout literature, the cruciate ligament has been blamed. It is not the horizontal part of the cruciate ligament which is responsible, but the vertical component which inserts the back of the C2 axis. That is the one which gets disrupted, and therefore you will notice that most of the time the odontoid part is along with the anterior arch of the atlas. Whether the fracture is displaced anteriorly or posteriorly is not important. Irreducibility has many causes. Osseous causes, there is sometimes ligaments and soft tissue getting trapped, but most important is the unrestricted muscle spasm of after the fracture, which keeps them in that kind of reduced position and prevents them from getting reduced with traction. So I'd classify these types as, one which will reduce with prolonged traction, 2 which are definitely going to require surgery operative, and last one which are not going to get reduced. You have to do some kind of decompression where bony fusion has already taken place. So what are the treatment goals? Realign, reduce, fix the joints and fuse the joints. This is not simple surgery. It must be done carefully. If you see the literature, the people began with transoral odontoid excision, then turning the patient and doing posterior fixation, and various such descriptions have been there in literature about anterior followed by posterior surgery. And then from India, the significant contribution by Dr. Praveen Salunke and my friend Sharat Chandra. So essentially, through a very small corridor, trying to put screws between the vertebral artery and the spinal cord and struggling to reduce that, I felt is not everybody's cup of tea. The Rosetta Stone of treatment of these patients is manipulation of the facets. And the facets can be manipulated very well from the ventral aspect without any fear of vertebral artery or venous plexus or C2 root. This joint does not have any capsule. The moment you expose this joint can be reduced, making use of an osteotome or various kinds. I'll show you further. Or you can impale the distal fragment and bring it back in position, provided you have adequately exposed the joints by dividing the longus colli and the rectus capitis anterior muscle. So this was the technique which was described by me. You can also manipulate the odontoid fracture. So as long as in extension the angle of the mandible is above the C2-3, it is doable. Way back in 2013, I had published that both the joints can be exposed from a unilateral approach, reduced, fixed. This was my publication in 2013 in Japanese spinal surgery, then global spine, etc., etc. And over the years, you will see there has been a lot of interest in anterior transarticular screws as a technique for fixation of the atlantoaxial joints, and that they are biomechanically superior to posterior transarticular screws. So you see there's a resurgence of literature. In fact, 2022, there was editorial on my work by Dr. Vinu Gopal in Journal of Neurosurgery. And then I went on to describe this new technique of direct compression, reduction, fixation of odontoid fractures, which got published at various places. And recently there was an article where they talked about this technique of mine. And this technique is essentially very simple. With this position, with the patient in a kind of hyperextended position, in the supine position, it is very easy to reduce the fracture or expose the fracture. And see, it's just like an anterior cervical fusion. You go up and expose the longus colli muscles in the midline without any fear of vertebral artery. And then you will see expose the fracture. And see, the right angles are used to realign the facets because there is no capsule. Just realign the facets, then you can put a plate, you can pass a transarticular screw. So this is, I'm using a kind of instrument to push the fracture into position and getting the joint into position and putting a VSP plate of variable screw positions which can cause compression at the fracture site. The facet is very easily visible. You pass the drill screw under vision. You do not require any special instruments. And you'll find that on table you can check it is rigidly fixed and reduced. So then you can see this construct essentially is two transarticular screws, a plate in the center, and these are examples. And another example, this was the construct treating the fracture and the instability and treating the fracture in compression mode with the plate on the fracture, unlike posterior fixation, which is an external fixator where the plate and rod are far away from the fracture. So this makes use of the VSP principle, whereby the screw, when it is passed at the edge of the screw hole, it is going to compress the fracture when you tighten it. So there are the anteriorly inclined fracture. This kind of fracture would have been treated by posterior surgery because not good candidate for screw fixation. This can be treated very easily with a VSP plate from the front. There's no need to fix the joints if it's not unstable. In patients where there's a displacement, after exposing the joints, it is very, very simple to get this fracture because there's nothing restricting it. And they can be brought and then bilateral transarticular screws. Now this kind of fracture, this patient has come late. You can see it is already going into bony fusion. You refracture it, reposition it by impaling the fracture and then fix it. And you'll see that over a period of time it fuses. Another example and another example. The end point of these unstable fractures has to be joint fusion and fusion of the fracture. Now this kind of patient with the locked facets, which is displaced laterally, this also you can treat by cutting the longus scoli muscles, impaling the odontoid, bringing it into position, and then fixing it. You can see the screw hole in the odontoid, which was used to bring it into position. Another patient with complex vertical fracture with a Jefferson fracture, and not reducing with traction, then reduced, and all this through a small submandibular incision without disrupting the posterior musculoligamental structures. And the advantage of this posterior surgery, of anterior surgery, is that the neck movements remain unrestricted because you are fixing only the C1, C2 joints, and all muscles heal by fibrosis. When you expose to do posterior surgery, you actually end up in destroying the entire muscular ligament in the posterior tension band. So this is the end point of the fixation. Anterior transarticular screws is a part of this operation, but sometimes the anatomy is not in your favor. You cannot pass anterior transarticulars. The screws can go out. There are so many pitfalls. Sometimes the screws can loosen up. Of course, this is a very old slide. So I went back to the drawing board, and then we realized that you could easily pass screws directly into the lateral mass, and one screw or two screws directly into the body of C2. So these are various kinds of constructions we have tried. And then Jeon made for me this plate, and with a locking system where you can pass screws directly into the lateral mass. We calculated the angulation, it was 35 degrees, and in the lateral mass 45 degrees. And you can see these are examples with long-term follow-up. Another case, you can see this bad odontoid fracture with a Jefferson's fracture treated by this technique. There is no need to do posterior occiput C1, C2 fixations. This is another example and long-term result. You can see the fracture has also fused and the joint is also fused. And another example, this is the best part of the anterior surgery, is that you have got the opportunity to drill the joints and prepare them. If you want a good fusion, the essence of the operation is preparation of the joints. Then only you are going to get the fusion. Don't get impressed by implants. So the technique is very simple, where you expose the C1, C2 like an anterior cervical fusion, mark out the points where you are going to put the plate, and then you can put one or two screws. But these screws in the body of C2 have to be bicortical. So this is another example of how it is done during surgery. After having reduced the fracture, put the bone grafts in the joint, I've marked the C1 lateral mass entry points at the anterior inferior end of the lateral mass of the atlas, just a few threads for the tapping, and then you can place the plate. It's a titanium plate of 3.5 mm and CE certified, manufactured by Jeon. I have no financial interest with Jeon. They just make what I like and what I need and put it through testing. So this is a very simple implant. You can see it is going inside. And now it comes with a locking device. Of course, this was published in Journal of Neurosurgery Case Legends as a technical appraisal of the anterior approach. It was also used for treating, see this kind of case of basilar invagination with a abnormal vertebral artery coming dorsally, and treated by this technique, you can see the descent of the odontoid with the opening of the joints and the bone grafts in the joints. A very simple operation instead of the complex posterior surgery, and this was also published. This was published more than 2 years ago. So I feel that a single implant with fixation is more biomechanically stable than the lateral implant. Now this work from China is catching laws and a lot of fire and interest, surgical treatment using the tar plate, but they are doing the operation transorally. And mind you, transorally operations, I don't think they have got a high risk of infection. This was a biomechanical analysis done last year. And their conclusions were that there's no doubt that the anterior transarticular screw is the best technique to fix the atlantoaxial joints, and that the tar plate, similar to my plate, has got better results than posterior fixation. No disclosures, just gratitude to my teacher and my darling wife, who's my anesthetist. So the task is not so much about to see what no one has seen yet, but to think what no one has thought yet about what everybody has seen. Thank you very much, my dear friends. We are going to take the questions later or now?
All these questions on the end of this session. Okay. Thank you very much.
Thank you very much. And now we introduce Professor Atul Goel. I don't think that it is necessary to introduce his role and his value, but I just want to underline among the many information of his CV that I don't see in the screen, that his number of publication indexed in PubMed is more than 700. And he won the Dandy Medal for Distinguished Neurosurgery Service 2018. Among many articles recognized as outstanding in the neurosurgical panorama, 2 articles including the 100 most influential publications in cervical spine research. And Professor Atul Goel will speak about vertical spinal instability, introducing a concept. Thanks, Atul.
Thank you, my dear friend. Max, Girish, and Rakesh, and dear friends. So in the next few minutes, I wish to introduce to you some beautiful, some novel concept, maybe probably an absolutely revolution, a revolution in spine surgery. I wish to introduce to you a concept that compression is never primary. Compression is always secondary to an unstable spinal segment. Compression is always protective or adaptive. Compression is always reversible following stabilization. And believe me or not, my dear friends, decompression is never the treatment. So this is a hugely different kind of version of spine surgery that I am going to present. The problem in spine, whether it is degeneration or whether it is what, is human standing position. And when we stand, all our muscles are focused on the facets. And when these muscles become weak due to disuse, abuse, or injury, there is instability at the facets, whether it is subaxial spine or whether it is craniovertebral junction. Whatever happens to the spine is unstable due to instability, and that is the issue in spine surgery, and these muscles are responsible. I wish to introduce to you an absolutely brand new concept of vertical facetal instability or telescoping of the spine. Your grandfather is shorter than you. Because he has telescoped, the facets have telescoped, the disc space have secondarily reduced. It is the genesis of spinal spondylotic disease. In craniovertebral junction, the entire musculature, the nape of neck is focused on the facets of C1 and C2. And in chronic situation, there is an instability called central or axial instability, which is the genesis of degeneration, that is one, of basilar invagination, Chiari malformation, syringomalia, and huge number of other problems that we consider problematic or pathological, but they are secondary to chronic atlantoaxial instability. So when the muscles become weak, there are three types of unstable spine. One is the facet of C1 comes in front of facet of C2. Atlantodental interval is increased. There is compression of the cord. Instability is the issue and stabilization is the treatment. 20 years ago, the whole world of craniovertebral junction was doing transoral decompression for this. Type 2 is when the facet of C1 goes behind the facet of C2, there is no problem at the atlantodental interval, there is no compression of the cord. The whole world still does foramen magnum decompression for this, but instability is the issue and stabilization is the treatment. The third kind of instability is when there is no facetal malalignment, no atlantodental interval, but the presence of assimilation of atlas, presence of Chiari, presence of syrinx, presence of Klippel file, presence of platybasia, and all those things are secondary. They are protective. They are current neurosurgery or current spine surgery calls them pathological, but they are secondary and protective. They are reversible following atlantoaxial stabilization. So chronic is the word and chronic atlantoaxial instability is the issue. So there are some pathologies I have mentioned here, but they are only some. There are many which I have not mentioned. When there is Chiari with syrinx or Chiari with basilar or basilar with short neck or C2-3 fusion only or in combination or in cohort when there is Klippel file with Chiari or kyphoscoliosis with or without other things, when there is bifid only or with Chiari or odontodium with or without other things are all indicators of chronic situation, chronic atlantoaxial instability and stabilization is the treatment. So basilar invagination is one of the children of atlantoaxial instability. Syringomalia is another very favorite child of atlantoaxial instability. Chiari is another one. Sometimes they live as brothers, sometimes they depart from each other, they are present discretely or in cohort, but everything, whatever is there, is due to unstable atlantoaxial joint and stabilization is the treatment. So this is a hugely different concept. Even when there is Chiari malformation without syrinx or with basilar invagination, look at the facets. This is unstable, stabilization is the treatment. I have no hesitation, absolutely no hesitation to say that if you do decompression in this kind of unstable spine, you have created a disaster for yourself and for the patient. When there is no atlantodental interval disturbance, look at the facet. Even when there is no facetal alignment disturbance, presence of Chiari, presence of syrinx is an absolute, mind my word, absolute indicator of unstable atlantoaxial joint. You stabilize, you learn the art of stabilization, you learn the art of seeing the magic, and that magic is not just radiological, it is clinical, and that is immediate postoperative. Syrinx will reduce in 100% of patients. No problem here, hardly any problem here. Stabilization is the treatment. Magic is the radiological and clinical outcome. So this was my article published a few years ago. Now my numbers go beyond 550. Absolutely gratifying. And there is no need for discussion or argument on this subject. Chiari is secondary. It is protective. It is reversible. Syringomalia is secondary. It is another child of atlantoaxial instability. Whether it is present with Chiari, without Chiari, idiopathic that we call, syringostomy is an absolutely negative and dangerous operation. Do fixation and see the beautiful magic. Reversal of short neck, torticollis, these are, when you see a short neck like this, torticollis of a particular kind, atlantoaxial instability is present, do stabilization and see this beautiful smile. Cervical fusions like Klippel file, C1 assimilation, C2-3 fusion, all kinds of anomalies are protective and potentially reversible, even when there is no compression. So my argument is compression is a non-issue in spine surgery. Stabilization is the treatment. This kind of kyphoscoliosis, multiple screws and plates have been described, but in this age group, central atlantoaxial instability is a frequent observation. I will say more than 50% of this age group needs C1, C2 fixation. Same is the issue in degenerative spine. Degeneration is a chronic unstable spine, chronic long-standing weakness of the muscles of the back. Anterior surgery was being done by me on several occasions. Several articles and chapters I have written on this subject, and this kind of fixation is common. Craniovertebral junction instability or degeneration has never been discussed in the literature, which is most common, and for the first time in literature, we related instability to degenerative spine. Reduction in the joint space, buckling of the ligament, osteophyte formation, osteophyte in the apical ligament, behind the odontoid, in front of the odontoid, are not primary events. They are secondary. Decompression is a negative form of treatment. Stabilization, whether you do realignment or not, that is not the issue. Don't think, don't talk, don't do anything for compression. Identify the unstable segment and do stabilization. Retroodontoid pseudotumor, the whole world was doing transoral surgery, including myself, but we have said for the first time about 20 years ago that this is secondary to an unstable spine and stabilization is the treatment. Retroodontoid cyst can be due to an unstable spine. In this kind of unstable spine, you remove this cyst, you have created a disaster. Never do that. This kind of cyst, you remove this in an unstable os odontoideum, is an absolute disaster. So retroodontoid pseudotumor and all these things are secondary. They are protective. They are reversible. Pannus, we know how to remove pannus by transoral surgery, but this is due to buckling of ligament, due to vertically unstable spine, distraction, reduction, fixation, and immediate postoperative, the pannus will disappear. Stabilization is the treatment. In subaxial spine, we have never talked about facets. Facet is the issue. Facet is the fulcrum of all spinal movements. Muscle weakness results in listhesis at the facets that cannot be recognized on radiology. Reduction in the interbody space, bulging of this disc, osteophyte formation are not primary events. They are due to vertical instability. Stabilization is the treatment. Identifying which segments are unstable and stabilization is the treatment. About 20 years ago, we introduced this facetal distraction technique where immediate postoperative radiological improvement can be seen, and this is an absolute, the whole game of spine surgery changed after this, my personal story on this subject. Bulging of this ligamentum flavum, bulging of the disc, are due to unstable reduction in this interfacetal space. You introduce these spaces and the whole story will change. And of course, the patient will dramatically improve. And this was my paper, which was published in 2011 on the cover page of Journal of Neurosurgery. Same concept for lumbar canal stenosis. We said you can do this kind of facetal distraction. And this was also published about 15 years ago in Journal of Neurosurgery, my experience. So this changed the concept that decompression is not the issue. Vertical instability is the issue. We have been doing decompression for decades, but decompression is not. Whether it is primary decompression by laminectomy, whether it is from front, whether it is from behind, decompression is decompression. In 2013, for the first time, we said even secondary decompression by distraction is not necessary. Only fixation. You fix. This was my subsequent article in 2020 where we talked about, look at the title, muscle weakness related instability is the cause of spinal degeneration and spinal stabilization is the treatment, not decompression from front or from behind. Multi-segmental compression, no question, some people will do laminectomy, some will do all kinds of anterior surgery. Do only fixation and see the magic. patient will improve dramatically. A word drama, a word magic has never been talked about in spine surgery. But enjoy this drama and enjoy the radiology after 6 or 8 or 10 months. The whole story will reverse. And we have got multiple cases now where I can showcase this beauty, which I have talked about on various webinars for a long period of time. And you see here, this is multi-segmental degeneration. Of course, everybody will do decompression, of course, but I'm saying don't do it because it is negative. It is an unstable spine. We should look at degenerative spine with different eyes, with the eyes of instability and with the eyes of stabilization. Not neural deformation and compression, but instability causes the symptom. Most important issue in spinal degeneration is to identify which segments are unstable. These are 2 level of compression here, but I have done 4 level of stabilization. You will ask me why, and I wish that you please read my article, and I can only tell you a magic you can create in this kind of person. Multi-segmental issues are here. Which level to fix, which level not to fix is the critical, most important issue in spine surgery. Many a time atlantoaxial instability is frequently, mark my word, frequently associated with multisegmental degeneration. Compression is not the issue. Identify instability and stabilize C1, C2 along with subaxial spine stabilization. In severe degeneration, when a patient comes on a wheelchair, on a trolley, many a time C1, C2 fixation is necessary. No decompression from front or behind. Decompression, in my view, is clearly negative operation. Lumbar canal stenosis, this word stenosis is an absolute misnomer. When you talk of stenosis, you talk of decompression. Look at this paper of mine in Neurosurgical Focus where we say that analyze the role of stabilization and futility of decompression. This kind of word has never been used in neurosurgery. So lumbar canal stenosis is not a stenosed canal. It is a multi-level unstable canal. These bulges are not primary. Decompression is not the treatment. Whether to remove osteophytes or not is the issue. The whole world of spine is focused on removing the osteophytes. I'm saying don't remove, don't touch. Osteophytes are divine interventions. Osteophytes are adaptive, they are protective, and they are reversible. Deformities are secondary. Identify which segments are unstable and do stabilization. You please read, there is no role for decompression in prolapsed disc is secondary to unstable spine. Instability is the issue in prolapsed disc. There is no question the whole world will do decompression and remove simple operation, but I'm saying disc removal is not the treatment. Identify which segments are unstable and stabilize. This disc will spontaneously disappear in no time. So this was my paper on cervical spine. This was my paper on lumbar spine. And you have to read. Ossification of posterior longitudinal ligament, the most difficult chapter in spine surgery. My answer is ossification needs only stabilization and there is no role for decompression. This kind of ossification can be a dangerous tool for decompression. Atlantoaxial instability is very frequently associated. I wish you read my articles on this subject. Atlantoaxial and subaxial stabilization can revolutionize the treatment of OPLL. So, my dear friends, I am introducing a new concept. I am introducing a new version of spine surgery. And I have no hesitation, no doubt in what I am saying. Compression is not the issue. Compression is not primary. Decompression is never the treatment. Thank you very much.
Okay, so thank you, sir, for introducing me, and thank you, Professor Sinha, sir, and the Neurotrauma Committee Jaipur for inviting for this August gathering. I slightly, introduced the term challenges to make it more attractive for the younger people who are following us day in and day out. And it's always very difficult to speak after Professor Padkar and Professor Goyal, So CVJ trauma or the upper cervical spine trauma, we all know it has been divided into these 6 types for didactic purposes, and it's different from rest of the spine, the subaxial cervical spine or the rest of the spine, because the upper cervical spine basically is made up of bones and ligaments, and it doesn't transmit weight through the disc spaces. It transmits weights through the joint capsule and through the bones. And if you look at the occiput and the C1, it is basically the bony integrity, and the C1, C2, it is basically the ligamentous integrity that defines the stability and the instability. So we take this one by one and go to the guidelines and the challenges. So what radiology is needed when we assess a patient of upper cervical spine trauma? Radiology, as per ATLS protocol, a full lateral plane radiograph is an acceptable first-line screening tool, assuming that the entire cervical spine can be visualized. But the problem is the sensitivity of these type of X-rays are still only 50%. And the patients which are admitted after cervical clearance of getting a radiograph, they tend to decline in their neurological status. So 18 to 20% fall has been reported. So the gold standard nowadays is the CT scan with coronal and SAG reconstruction. So my word of advice for all the young people who are sitting over there, always try to have a coronal and SAG recon of the CT images before going for cervical clearance. And flexion and extension images are not recommended nowadays. So these points you have to remember in clinical practice what the guideline says, that ADI, anterior ADI of more than 3 mm and posterior ADI of less than 13 mm are basically indicator of your instability of the TAL. And rest of, as we go, we see how it falls. So that's what we have discussed. Coming to the occipital condyle fractures, there was Anderson classification and Tolley classification before, but it is based only on data of 6 patients and 3 patients. So it's not of huge. So Muller later on combined properties of both these and has classified into 3 types, that type 1, type 2, and type 3. So type 1, obviously, there is no displacement, one-sided, type 2, both sides, and type 3 associated with atlanto-occipital dislocation. So both these types, type 1 and type 2, they don't require any surgical intervention. You can only apply a rigid halo collar, a rigid cervical collar, or a halo vest, depending on your situation, and that patient is supposed to heal in 6 weeks to 12 weeks of the time. And AOD is an independent factor for the poor prognosis. And mainstay of treatment of all these patients is occipital cervical fusion. So occipital fusion still has a role, at least where the trauma is concerned. Now coming to the atlanto-occipital dislocations. The sensitivity of, as I have told earlier, the sensitivity of X-ray images is only 50%, and CT is very mandatory, 96%. CT sensitivity is 96% and specificity 100% for ruling out these trauma. And the historical, the classification scheme based over the power ratio and rest of these is not recommended nowadays, because you can see this all is depending on the measurement of atlanto-axial integrity also. So if you look of the atlanto-occipital dislocation, the problem is if there is this AAD also, this all will change. So nowadays, and then you come to the trend-list classification. It is divided into 3 types: the anterior distraction injuries and the posterior dislocation only. The problem is these 3 types of injuries can happen in any of the patients, depending on the head position. So if you put the patient head in flexion and get a CT, you can get a different type of classification. If you put it in extension, you can get a different type of classification. So nowadays, the recommendation of WFNS spine committee is to go for condylar C1 interval or condylar CC sum only. And if it is more than 2 mm in adults and more than 5 mm in children, it is diagnostic of atlanto-occipital dislocations, and it requires occipito-cervical fusion. So the statement is, if the patient is having severe TBI, lower cranial nerve deficits, or spinal cord injury, atlanto-occipital dislocation should be suspected. And if it is proven on CT scan images, you have to fix it. Now the challenges. So when we go for occipital fusion, what we find? If you see the literature, the problem of putting up the occipital plate is enormous. in one of the studies, they tried to put, bicortical screws to get a good purchase, and the results are, 8 to 10% of these will result into CSF leak or major venous sinus bleedings. To rule out this, and the screw loosening. In our own series of first 16 patients, what we have seen that screw loosening occurs in one patients, and the screw failure was in 2 patients. And overall literature also was of occipital plate failure and suggests that it occurs in 7 to 8% of the patients. So what is happening, throughout the years? They started with 2 holes, then 3 holes, 4 holes, 5 holes, and now multiple holes. Does it going to solve the problem? It is not. So what's now? So there is a publication from Turkey. They used an occiput hook, which goes from inside out, and they tried to include it into cervical fixation to, give it a good strength. But the problem is the upper end is not rigid. You can see upper end is not rigid, and it doesn't provide, sound fixation. So after a few cases, they just abandoned it. And there was publication in 90s by Al-Mafti group. They used the lateral schema of the occiput for making an inside-out plate, but the system again is problematic. It is a single rod system with having multiple holes. And they tried to connect the occiput with the rest of the cervical spine based over this, and the problem is they use the lateral schema that is already very thin. They reported out of 13 patients, they report fracture in 2 patients of the lateral occipital schema. So what we did, that's our plate, that we have patented and published it. We use that same technique, but we use the midline occiput. Okay, so in this particular plate, you can see there is an inside occiput screw which is going from inside, coming outside, and by using this plate, you can see the test. The torque stability is 12 times more than the previously existing occipital plate system, and the pull-out strength at 9 mm, in fact 9 mm of stretchability is 4 times higher than the previously existing occipital plate system. And we are for past 7 years using this type of occipital plate, and believe me or not, we have not encountered a single failure using this type of occipital plate, because it is utilizing the midline of the occiput, that is the most thickest part of the occiput. Second part, you can put an occipital plate with outside occipital screws also, and you can apply a washer which can be used as a locking device. So this is our device. Second problem, you have heard about vertebral artery sacrifice on one side, and most of time you just think of that vertebral artery one side. If you divide it on one side, that is non-dominant side, is not going to create problem. But what is happening to these patients after 20-30 years? I mean, there is no data regarding that. Maybe Professor Goel sir can say this, because he has seen too many patients since 30-40 years and is operating upon them. So there is no data yet of the patients of CVJ in whom one side of vertebral artery is compromised during surgery. They do fine, but later on when their blood demand increases after their 50s and 60s, what is happening to them? So stay away from the vertebral artery. So how can you stay away from the vertebral artery? Vertebral artery reside in the groove between the C1, C2. And if you want to go and do the subperiosteal dissection to reach at the joint, it is always a chance that you can actually injure them. So what we have done, we have devised this technique that is called C2 superior facial osteotomy. And actually without going into groove, you can see actually without going into that groove and without touching the C2 nerve root or the vertebral artery, by drilling a part of the C2 superior facet which overhangs the C1 lateral masses, you can go into the joint and you can put up your screws and do whatever you want to do. You can do drilling of the joint, you can prepare the joint, you can augment with bony fusion, and you need not to touch the vertebral artery or the C2 nerve roots. So that's one thing that we have published and we are very proud of. Now, coming to the isolated C1 fractures. The stability, again, there was a rule of Spence that we all are reading since our residency days, if there is more than 7 mm of dislocation. But it is not true actually. So again, you have to go for the CT, and CT is the gold standard. Jefferson and Dickman have classified these fractures again, but one is based on the bone integrity, one is based on basically on the ligamentous integrity, and now the Gabeler has combined both of these, and this is a most practical value. So again, if you go for type 1, type 2, type 3A, type 4, type 5, that all can be treated with hard color, and only type 3B requires fixation. Odontoid fracture, a lot had been talked about. I just want to emphasize that this classification is false. This classification should not be taken into account, at least in our country. The problem with this is that it has not taken into account the dislocation or the time span that has passed. So even a case of type 2A fracture, if comes to you with non-union after, I say, like 2 months, what you are going to do? Are you going to, put again collar for 6 months? No, it has to be operated upon. Class 1A, if there is TL integrity is not there, what you are going to do? You have to operate. And they don't talk about the dislocations. Again, odontoid screw, you use 1 screw or 2 screw, doesn't matter. Okay, that's what I want to show you. So what we have introduced a concept of reduction screws for the C1 lateral masses. For cases like this, where you can see there is a pseudo-arthrosis of long duration and you have to go very anteriorly to get the purchase of the C1 lateral masses. How can you do it? I need 1 more minute. So the reduction screw concept is that you can actually, by concept, it is the downfall of the occiput and the C1 that goes anterior and downwards. It is not that C2 is going up. It is actually your head that is falling anterior. So by concept, you have to pull it back. And that can be done by reduction screw. You put the heads of your reduction screw deep inside the cavity and let the screw do all the work. And that's how you can treat that sort of complex scenario very easily. And again, the TO is not abandoned. You should learn to do the transoral odontectomy. Like in this case, a neglected odontoid fracture came to us after 1 year, young child. If you go for posterior fusion, that spike definitely is going to create a problem and create neurological injury without doing TO. Or like in this case, this is only 9 kg weight. The weight of this patient is only 9 kg, 6 years old patient. If I am going for transoral in this case, wound is not going to heal. So we simply did posterior C1, C2 fixation. There is small movement, the small anterior movement of C2 post-surgery, and that created wonders for this child. Hangman fracture, again, the classification scheme is not going to support you. You have to go by stability. Okay, sir. So this is my last slide. Atlas and axis fractures, if you see in totality, the main treatment protocol is basically decided by the type of the C2 fracture pattern, and that should be taken into account. I have not discussed about the anterior transarticular techniques, DCR technique, and absolutely everything is, of course, everything is relative. What I am describing or what everyone is telling today may not be true tomorrow, but that's the reality of the project. Thank you so much.
Now we are moving forward, and I would like to invite Dr. Jatin Bajaj, who is Associate Professor Neurosurgery in NSCB Medical College, Jabalpur. He is an editorial member for Neurology India, Indian Journal of Neurosurgery, with 3 books publication, 55 book chapters, and 77 articles. He is going to discuss about his newer technique for rocker technique to reduce atlantoaxial dislocation with or without bacillary invagination. Welcome, Jitin.
Thank you, respected chairpersons, Professor V.D. Sinha sir, Goyal sir, Patkar sir, Deepak sir. It's an honor and privilege to stand in front of you. So I'll be speaking on a simple technique to reduce AAD with or without basal invagination, and I'll be showing some cases of both irreducible and reducible AAD. So we know that AAD is a not an uncommon pathology, and it often needs surgery, and there are various techniques to catch this. C1, C2 fixation, as described by Professor Atul Goyal sir, has become the workhorse for most of the cases. What I have found in my little series is sometimes when if you can see the left picture, which is the pre-op, and the right picture is post-op, in doing the distraction, if we do not realign the atlantoaxial C1, C2 joint, sometimes the BI reduces, but the AAD sometimes doesn't reduce, or in fact sometimes increases. So we thought of making a simple technique. Of course, there are various techniques, and these are various established techniques. And But somehow I thought of making a simple technique which has a simplified instrumentation without any complexity. It should be a very powerful technique to reduce the atlantoaxial dislocation, and it should not require any additional implants. So this is a typical case of AAD, where in left case you see oblique joints and basilar invagination. So this is rocker instrument, and this is a commonly available instrument in almost all spine sets. The beauty of this instrument is it has knobs, it has a base which can be used as a fulcrum, and the long lever arms can be used according to the physics principle. So we can attach these knobs to these screws, which goes into the occiput or C1. I mean, when the C1 is assimilated with occiput, or when it is not, directly into C1. And the fulcrum of this instrument can be, this base of the instrument can be used to push the C2 screws ahead, and the lever arms can be used to correct the dislocation, like shown in the right lower image. So it was a prospective study of 55 patients. 32 patients had basilar invagination. And the procedure is similar to what Goel sir has described already. That is, firstly, joint preparation. The C2 osteotomy has to be done sometimes to get into the joint. We have to really drill the joints right up to its anterior margin, open up the joints, and then the rocker is applied, followed by rods. So many times I have used the MEPs and SSCPs, particularly in complex joint orientation. And I'll be showing this maneuver basically through this small video. So this is a typical scenario where the C1 screw is quite ventral after putting the C1, C2 screws. So you first put a small rod in between the joints. First tighten this C2 screw head. Then you apply the rocker through the knobs. You catch hold the C1 screw, and through the base of the C2, this base of the rocker, you use it as fulcrum, correct the rotational anomaly, and slowly correct the deformity. Tighten the C1 screw head again, C1 screw to head, and then you apply a compressor to fix the joints in the compression state, as it is the basic mechanism in any bony surgery, that if you fix the joints in the aligned position as well as in a compressed position, the fusion will be better. So we could apply this technique in 53 out of 55 cases. In 2 of the cases, the vertebral arteries were severely anomalous, precluding us to go through this technique. The mean age was 40 years. There were 30 reducible and 25 reducible cases with 32 basilar invagination. 18 cases were of traumatic and 17 congenital, and rest were others. So there was significant reduction in atlantoaxial dislocation, and BI could be successfully reduced in all cases. Also, there was improvement in the clinical criteria using modified Ranawat grading. So I'll be walking through some of the cases, starting from simple case, where there was no occipitoatlantic assimilation. The joints were nearly horizontal. And this was a post-traumatic case. So the AD and BI, both AD was nicely reduced. Second case, the pre-op imaging I have previously shown. So in this, there was occipitoatlantal assimilation. There was pseudo joint between the occiput and C2. So we had to do C2 facetal osteotomy, go into this joint and do drilling up to the anterior margin. And then we could place the C1 and C2 screws, C1 pars and C2 pedicle screws. And here you can see there is still AAD, and after application of the rocker, the AAD is reduced, as can be seen in the lower image. As I said, in some of the case, I did MEPs and SSCPs, and whenever I find that with the correction of the MEPs reduced, so I at the same time I did foramen magnum decompression from posterior side, and I could find that there was improvement of MEPs with the joints in aligned position. And if you can see, this occipitoatlantal facet is sitting directly over the C2. We don't put bilaterally, and we never put the cages because there was simply no space for placement of cages, and I also think that there is no need of placing the cages. Another case, here vertical joint on the right side, the vertebral artery was very thin on this side. Oblique joint on the left side, the vertebral artery was dominant. So because of this vertebral artery which was dominant, we didn't open the C1, C2 joint on the simpler side. We opened it on the vertical side. We placed the C1, C2 screw, and after application of rocker, we can see in this image there was nicely reduced basal invagination as well as correction of atlantoaxial dislocation. This was a more complex case. This was a pediatric case, bilateral vertical joints and severe atlantoaxial dislocation and basal invagination. So bilateral C1, C2 screws were put, C1 pars, C2 pedicle, and then again the rocker was applied. And in the lower image, you can see the joints are realigned now, and the BI and AD are also reduced. So there were a few complications of surgical site infection, occipital ulcers. However, there was no neurological deterioration and no mortality. The advantages of this technique is it is a simple technique, it is versatile, and it's very cost effective. You don't need any other implants or instrumentation. However, it is not a panacea. Sometimes we may need occipitocervical fixation as seen in 2 of the 55 cases. The joints have to be opened and drilled up to the anterior margin, and so technical skill is required in this. We haven't studied the rotational anomalies yet, and we haven't compared this with established existing techniques. So to conclude, this is a safe and effective alternative for managing AD with or without basal invagination. It offers a promising solution for both simple and complex cases, even with challenging joint orientations. However, it warrants further investigation to solidify its role. Thank you, sir.
Thank you so much for your beautiful presentation. I think that just in case the coffee break is confirmed, that we have to stop here, and in 15 minutes we return back to start the second part of the session. Do you confirm, Virendra? I think yes, coffee break. Okay. Okay. Okay, go ahead.
Well, we can use this time to do some questions. I'll open the floor for questions. Anybody has any questions?
Yeah, please.
My question is for Professor Atul Goel. My name is Ahmed Al-Fei. I'm from Egypt. I just noticed that the case that you showed about cervical disc, the double cervical disc with disc prolapse, what I understand from your philosophy in stabilization is that we correct the cause of instability. So in this case, precisely, why not to apply the same concept for discectomy, especially that the degeneration occurred at the disc space, which is about 2/3 of stability of the cervical spine, plus that there is disc prolapse, which may cause compression symptoms, like what we use, for example, in large aneurysm. If we do surgery, if it is thrombosed, we do decompression not only for the cause.
So that is the difference in my concept. That is the difference. And that is why I say revolution, game changer. That is what I'm saying. You know what? Just to explain to you, if suppose there is a disc herniation or disc herniation, see, you give a collar. The standard treatment for acute disc herniation is give a belt, observe for 3 or 4 weeks. If the pain goes, there is no need for this treatment. Agreed?
Yeah.
When you give a belt or when you give a collar, you stabilize. You avoid any movement because that movement is not good for the patient. You do your little movement and there is acute pain. In the night, you remove your belt and there is acute pain. Movement is the problem. Instability is the problem. When you lift heavy weight, there is disc herniation. You lift heavy weight, you make it unstable. That is my concept. My concept is disc herniation is due to instability or disc herniation causes instability. Instability is the problem and stabilization is the treatment. For your information, in next month, I am operating for 1 week in Egypt. You please join me and I'll show you some of these cases in Army Hospital of Egypt. Yeah. And I wish that you can join. And there are several fellows from Egypt who have worked with me and you can discuss with them maybe these concepts. They are different, but believe me or not, they are the future. For OPLL, for Chiari malformation, if somebody argues with me on Chiari, no, I like decompression, we have been doing for decades, I will say, you do whatever in the world you are doing wrong. Absolutely. Now I'm talking on Chiari for more than 550 cases with magic results. Decompression in Chiari, foramen magnum decompression, which I was doing. Transoral decompression is somebody is doing. Transoral decompression for craniovertebral junction instability. He has to learn how to open the joint, how to do stabilization. If somebody is doing C1 occipital fixation for atlantoaxial instability, I will say you learn how to open a joint in a complex kind of situation. So the story has changed and so whatever I'm saying, I'm talking on the basis of my 40 years of experience, and I'm absolutely positive. So you please go and read some of my articles on the subject, and I'm sure you will find some new thoughts.
Thank you.
Professor Goel, our congratulations. Everybody of us is very impressed by your lecture. We saw some cases of cervical spondylosis treated by only fixation. Did you have any experience in another pathology that is very more challenging for neurosurgeon, that is the thoracic disc herniation?
I will say I will not be able to talk to you on thoracic disc herniation at this point because my experience is not very big and I have not too many cases on thoracic disc. But if you talk to me on cervical spine, for lumbar canal stenosis, there are at least 200 articles of mine in literature, and I wish you read multi-segmental degeneration. If you ask me one question, what is the main or critical issue in degenerative spine surgery is identify which segments are unstable. It is not just radiology, you see compression, those are unstable. It is clinical also, clinical. It is also based on intraoperative observation, like adjacent segment instability. When you talk of adjacent, it is unstable right from beginning because degeneration is due to muscle weakness, and muscle weakness does not happen at one level. It happens at multiple levels. It may manifest at one level, but instability may be more than one level. So most critical issue is identify which segments are unstable, and when the patient comes with myelopathy and severe myelopathy, C1, C2 instability is almost always present. So I have introduced a new technique of C1, C2 fixation in that situation where I don't include the arch of Atlas. So that also is a beautiful technique.
Thank you so much. And now we conclude the first part of the meeting by inviting Professor Dell'Itala, yes, to present odontoid fracture in elderly, how to improve the outcome. Professor Dell'Itala has been the president of Italian Society of Neurosurgery, the president of Mediterranean Association of Neurological Surgery, honorary member of Serbian Neurosurgical Society and Southeast Europe Neurosurgical Society, and more than 10,000 neurosurgical activities were performed in his career, and now he is a scientific director of neurosurgical unit in Rome, San Carlo di Nancy. Please, Alberto.
Thank you, Massimiliano. My challenge today is to speak after Atul Goel and after this so challenging presenter. So my speak will be how to improve the outcome of odontoid fractures in elderly. Of course, everybody of us know well the anatomy of craniocervical junction. And the anatomy of craniocervical junction is made especially by the ligaments. If we take care about the ligaments, we can have the visual of a sailboat in which the mast is broken and the wires are broken. So this is a system, I can say cruciate system. And also the vascularization is, the blood supply is very important because the odontoid the odontoid bone take vessel, take vascularization by anterior and posterior vessel by vertebral artery and some cleft perforating vessel from carotid artery. It is very important because this is a vascular supplies borderline, and it is very similar to that of the femoral vascularization. And you will see why I make this similitude. The modification of the classification made by Grauer is very important to state if one type of fracture can undergo to surgery and to which surgery. And again, note the similarity by these odontoid fractures and the intertrochanteric hip fracture. They are very, very similar. So the treatment strategies are no surgical, but also no treatment at all. And anterior min-invasive or percutaneous are very similar, posterior transarticular. And in the last years, many papers have been presented about the conservative treatment of the type 2 and 3 fractures in elderly. And this meta-analysis by the group of Netherlands and this other one very similar by US, they stated that while surgical treated patients show a higher union rates than conservatively treated patients, no clinically relevant differences were observed. So there is a kind of re-evaluation of non-surgical treatment. And also these other papers by US and by Germany, they conclude that in a follow-up range up to 5.8 years, none of the 141 patients had experienced a neurological event. So there is a re-evaluation of conservative treatment. There are no guidelines, but this recommendation of the German Society can help in the decision make. And so they pointed out that Anderson 1 and 2 without dislocation, if they are stable, follow no surgical treatment. If they are unstable, you can choose which surgical treatment to underwent. But so, how riskful is pseudoarthrosis for Anderson 2 fractures? You have to consider that the non-union rate in elderly, also after stabilization, is more than 85%. This is by vascular supply borderline and the ossification and the grade of dislocation and the angle of the dislocation. Our experience is based on a series shared with the group of Geneva with Enrico Tessitore, and we studied especially 32 elderly with a mean age of more than 81. And the non-union rate was not completely indifferent. So we face with patient also well treated, also with a good anterior approach, but with not completely fused. And the degree of arthrodesis shows a good recovery in 70% of the patient, and it is due by the timing, especially by timing of surgery. So bone quality, the age of the patient, and the timing of surgery are the factors that influenced the result. We treated some cases not suitable for anterior fixation, like these 5 cases of type 2C. And also in these cases, the alignment was not good, but the fusion was good. And so such technique can be used also in borderline cases. We have to learn by other specialty. We have to learn by orthopedics. The guidelines in hip fractures recommend early surgery within 24-48 hours. But some authors suggest a shorter time to surgery within 12 hours. This is due. This is for the similar vascularization by the odontoid vasculature, and so this work by University of Rome by Professor Racco and other authors pointed out that the timing of surgery is underestimated, and whenever surgery is selected for treatment, it should be performed within 1 week from injury, and surgery after unsuccessful conservative management might not be as effective as an early procedure, and they recommend, and we too recommend, to perform surgery within 48 hours from the trauma. So the messages are surgery provides a significantly higher fusion rate than conservatively, higher degree of arthrodesis, but in elderly patients, fibrous pseudoarthrosis with radiological stability can be considered a good outcome and does not require any reintervention. For older patients, the alternative of local anesthesia made early treatment possible, and ultra-early surgery also in local anesthesia and a good layout can facilitate the surgery and the recovery. So the alternative is or mean-invasive anterior screw fixation or no treatment, because conservative treatment is no treatment. And if someone has the possibility to come to Rome in May, you are welcome to follow our Congress of Vertebral Society in Rome between 9 and 11 May. Thank you very much. Can we have the microphone? Come here. Okay.
A lovely presentation, sir. I just wanted to ask if you're going for a non-operative treatment, you'd apply either a Halo or a Philadelphia will do, number one, and if so, how long?
Well, we use it to apply halo, but in the recent literature, many authors say to apply nothing. So go in pseudoarthrosis.
No, I was very intrigued on seeing your presentation. You said one is no treatment and one is screws. See, my issue is with odontoid fracture is treat when it is unstable. Treat when the region is unstable. And what is unstable in odontoid fracture is atlantoaxial region. Atlantoaxial instability is the issue. And my treatment now, currently, for last several years, if there is atlantoaxial instability, you do posterior fixation. Anterior fixation has an advantage that you don't tackle the joint and you can retain the movements. But the possibility of failure in anterior surgery is there. May not be very high, but is there. So my issue is now clear as far as I am concerned. When the region is unstable, when you have to treat odontoid fracture, treat by posterior surgery. This is my current protocol.
Yes, the older patients are more than 85 years old. And we, in such cases, recommend the screw odontoid fixation when you success with bicortical perforation of the odontoid. Thank you for your question.
I think we are missing one point, that all odontoid fractures are not unstable. Most of the time, odontoid fractures are operated for anticipated instability. Because the cruciate ligament is intact in many elderly patients, the odontoid fractures can be treated conservatively or with surgery. There is no problem about instability. The cruciate ligament is intact, but there's a possibility that there will be avascular necrosis in the future and there will be catastrophic instability. So we have to identify these two separately, those which have instability and those which don't have instability. Those which don't have instability can probably treat it without surgery, and those where there is overt instability, of course, some kind of fixation is necessary.
One question, Professor Cantala, to say about doing it within a week. With your skills,
if we have established instability, now with recent MRIs, it is very easy to study the ligaments. If you can do a good MRI and prove that the cruciate is disrupted, there is no point in waiting.
Well, thank you. We think that in the last years, probably the risk of pseudoarthrosis was underestimated. And so in the elderly patient that do not play tennis or do not make any particular sport, probably also non-treatment should be an option. Because we have to remember that surgical treatment, we did not have any death, we do not have any complication, but there are in the literature. When you deal with an 85 or more older patient, you have to deal with complication and you have to speak to the patient. In Italy and I think in all Europe and the US, the legal litigation are very, very frequent. And the lack of a guideline, of an international guideline in such cases is a problem. So sometimes follow the nature and go in pseudoarthrosis is not bad.
Sir, just to put a comment, actually the 1 week surgery timeline has been described by Chow et al. In his study of more than 100 patients. And they have established that there is 70% non-union if odontide screw is used in these patients after 1 week of surgery, 70% non-union. And what they have seen, even if you do posterior surgery on patients which are non-reducible, and if it is perfectly aligned after the posterior C1 surge to surgery, then again, the odontide fracture is not going to heal in 40 to 50% of the patients. That we should keep in mind. So obviously, if the 1 week time has passed, you should always take these patients with very caution, and posterior C1 C2 surgery along with C1 C2 fusion has to be indicated. We should not rely on the odontide union alone.
Professor Matkar, I have a question for you. When you do the anterior surgery that you described, how many of these patients will need either tracheostomy or some sort of airway bypass?
I have not yet had to do tracheostomy ever. This question has always plagued me. Everybody has asked me this question. Everybody feels that like subaxial cervical spinal surgery, you retract the esophagus or the trachea. This surgery is in the nasopharynx. It is much higher. See, traditionally, the posterior C1, C2, all the fixations were described first by Magel, then by Gallies, and all these people were essentially orthopedic surgeons who were not using the microscope. Then Smith Robinson came on the scene and they started doing anterior cervical spinal surgery with the microscope. And we moved up to C2-3 disc and we stopped at that. The atlantoaxial joints are just 1.5 centimeters above the C2-3 disc. 1.5 centimeters. But traditionally, everybody stopped at the C2-3 disc saying that there is going to be a disaster. But with the microscope, with right angle retractors, it is just one more centimeter of dissection. But tracheostomy, never.
Thank you.
Just a quick question, Patkar sir. Do you have any implant failure? Because I'm also concerned about the instability and only anterior. So biomechanically, it's like one column rather than 2 or 3 columns.
Like I said, 2 issues. When you do posterior surgery, your connection between the screws is floating. It is behind. When you are using anterior surgery, the principle of orthopedics for fixing fractures is that the fractures have to be, the plate or whatever you put should be on the fracture in compression mode, which is possible in anterior surgery. Regarding implant failure is function of many things apart from technique, implant, and the bone quality. I have had implant failure in a case osteoporotic spine where I had used a plate without a locking mechanism on the screw and the screw walked out. Of course, now I don't do that. I don't use. See, this evolves over a period of time. So initially when these plates were made by Geon, they were without a locking device. Now they come with a locking device.
And regarding your screw and the plate system, you mentioned, I believe it's like one is a variable angle or both are the variable angle, like cranial caudal screw.
The screws have got a play where when we did the calculation on more than 350 scans, the lateral mass of the atlas is a square block. So, and the best purchase would be when the screw passes at 45 degrees. But all our lateral masses are not same. So you must have 5 or 10 degrees plane passing that. And regarding the C2 screw, it must always be bicortical. When we pass the screw in the C2, because you're passing it just above the end plate of the C2-3 disc, that screw has to be bicortical.
Thank you, sir.
Thank you.
Thank you very much. It's an excellent session. Thank all the speakers for their time as well. Now, it gives me great pleasure. I'm sorry. We're starting the next session. It gives me great pleasure to invite Professor Massimiliano Sergi, our co-chair, who's going to talk on the modern social status of the cranial junction injuries. Now, Professor Sergi, of course, doesn't require any introduction, but for those who haven't met Professor Sergi before, he's a native of Rome. He's professor of neurosurgery at the Catholic University in Rome, but also visiting professor at a number of institutions such as Shanghai, in London, Mumbai as well. He's a winner of a number of awards, but I think the one that he's most proud of is the competitive professorship in neurosurgery, and also becoming director of the special course and second degree level international master. Is this something like the 14th Dan Professor Suchat last week's he's, of course, chairman of a number of committees, including the Neurorehabilitation Committee of the WFS, he's board member, of course, of the Trauma Committee. He has served with great zeal successfully in a series of sites. He's also not very far behind Professor Goyle in his publications. I think he's reached over 400 publications. So research is nothing new. And he's also editor of a number of journals, chief editor, published 7 books, and Professor Toshi, it will be a pleasure to invite you to the presentation.
Thank you so much for this beautiful introduction. I apologize, my presentation was supposed to be at the very beginning of this workshop, and that's why I will repeat some concept well expressed by my colleague. Thanks so much to Professor Virendra Singha for having allowed this important workshop. I like to start with the pyramid of evidence and to underline that only systematic reviews and meta-analysis fulfill the criteria to elevate to class 1 evidence all the scientific information. Otherwise, class 2 are for non-randomized cohort studies, and class 3 practice option only for case series and expert opinion. We will speak about class 1, class 2, and class 3 evidence in this presentation. I like to underline that when we deal with craniovertebral junction trauma, we have to perform neuroradiological assessment and to identify the site of the lesion, exactly the type of bone ligamentous injury, and the bone displacement with listhesis, angulation, subluxation, and ligament rupture. We start with occipital cervical dislocation, which are much more frequent in the childhood and are virtually deadly, since they are consistent with the bulbomedullary junction when transverse ligament is compromised. How to know when transverse ligament is compromised? We know it when we measure the distance between the basion and the tip of the odontoid, or the basion and the posterior aspect of the odontoid, and the distance between the posterior arc of C1 and C2. All these are indirect measure of instability. And in atlanto-occipital instability, we have the maximum concentration of lesion, spinal cord lesion, fracture, extra-axial hemorrhage, muscular injury, ligamentous injury. Mainly when we have a damage in tectorial membrane and that side, we can have instability, but also epidural blood, and also laceration and destruction of the ligament, driving to a very deadly, potentially deadly instability. The shaken bandage syndrome can be associated with the atlanto-occipital dislocation, and according to the neuroradiology, we can find associated also hematoma, subtectorial hematoma, epidural or subdural hematoma. How to correct this condition? By surgery, no doubt at all. And we can perform C0, C2 surgery, instrumentation, and stabilization procedures, or C1, C2, C3 instrumentation procedure. But when we deal with the condyle, we have to keep in mind that across the condyle, the hypoglossal nerve as well as the emissary vein runs together, as demonstrated by this video in skull spacement. You can see how on the right side, the hypoglossal nerve and the emissary nerve run together, while on the other side they are separated. And that is important in order to plan surgery and to avoid mistakes. Three types of condyle fracture are well known. Number one is comminuted one. Number two, basilar skull fracture. Number three, avulsion. Surgery is indicated when fragment displacement is more than 4 millimeters, when more than 25% of condyle is involved in the fracture, when subluxation appear in dynamic X-rays, and when we have the evidence at CAT scan and CT scan of a compression of the bulbomedullary junction. When we move to the atlas fracture, so-called Jefferson fracture, we have to remember the three main classification. Type 1, single arc; type 2, double arc, anterior and posterior arc rupture; and type 3, lateral mass displacement and fracture. Especially when we deal with the displacement of lateral mass, we can find some syndrome associated with. Spencer rule states in the 70, according to the CAT-SCAT measurement, that displacement of lateral mass more than 7 millimeters was associated with transverse ligament rupture. But MRI examination confuted this hypothesis. More than 3 millimeters is enough to be associated with a damage of the transverse ligament. Sometimes when we have a dislocation of the lateral mass of C1, we can have an impingement of the foramen lacerum components, jugular vein, cranial nerve, the 11th, the 10th, the 12th cranial nerve, and we call this special condition as Collet-Sigard syndrome. We measure the displacement of the lateral mass, and we can see that the narrowing of the distance between the styloid process of the lateral mass is consistent with the Collet-Sigard syndrome. So keep in mind this special condition associated with the C1 fracture. Odontoid fracture, nothing to add to what in a wonderful manner was presented by my colleague, just to remember that elderly is the problem. And elderly was highlighted by Professor Dell'Itala. According to the literature, the association with the mortality rate was more consistent in a patient more than 70 years old, treated with anterior screw fixation, and dropped down to 33% with Allo-Vest conservative treatment and 13% with hard collar immobilization. On the other hand, I completely agree with Dr. Packard and Dr. Atul Goel statement that the C2, type C2 fracture in the elderly can be a good candidate for a posterior C1, C2 instrumentation and fusion. We have to consider also transcervical approach for C2 fracture, the classic transcervical approach that can be easily reached by C4, C3, C4, C5 skin incision and an upward direction of the screw. But sometimes, despite the beautiful presentation of Dr. Packard, in very old, in very chronic C2 the deformities, no space for a reduction, but also for a removal, in this case by transoral approach. This was a patient with a long-lasting non-union with bulbomedullary contusion, and after surgery the problem was solved. The hangman fracture, obviously we have 4 degrees. I don't remember to you what you know better than me, but just to underline that the Judet screw is indicated only for Levine grade 1 fracture. In all the other, the risk of dissection of vertebral artery damage is very important and should be prevented by posterior or anterior C2, C3 plating. And I conclude my presentation with this dislocation, axial dislocation of C1 on C2. As we remember, we have a 4 degree. Number 1, the pivot is the odontoid, and it is a reversible condition. Number 2, the pivot is the lateral mass. Number 3 and 4 is number 2 with destruction and of the ligament and the dislocation. This was the case of a young lady undergoing to maxillofacial surgery, and a few months after surgery she developed this torticollis, very impressive and very painful for the patient. So we perform a pre-op CT scan 3D reconstruction showing this impressive rotation of C1 and C2. The patient was candidate for a surgery and was intubated with the nasotracheal endoscopic assisted procedure. The midline continuous line is the ideal midline of the sphenios process, while the dotted line was the one that we palpated through the skin, and C1 was kept firm. C2 was hooked and entered to the spreader, metallic spreader, so to realign the subaxial spine. And after manual reduction, goal fusion was performed with the head of the O-arm, as demonstrated by this post-op examination. And the patient did well. The implant was an hybrid one with ismic screw in one side and laminar screw in the other side. And again, the Golgi fusion underline the trajectory of C1 screw, and after surgery, this is the results. Thank you so much for your attention.
Yeah. Thank you. Now, now I'd like to invite our co-chair, Dr. Girish Solanki. He is a consultant pediatric neurosurgeon at Birmingham Children's Hospital, Birmingham. He is immediate past chair of British Pediatric Neurosurgery Group and is co-chair for Adult Committee Executive Board of ISPN and serves as faculty for ISPN, ESPN, and WFNS. His contribution to multicenter clinical trials with about 3,370 citations over 127 reference article chapter, and the largest number of citation at 685 with H-index of 27. Welcome, sir.
Good afternoon. I'd like to thank Professor Diosina and the organizing committee for giving me the opportunity to be here. Such a wonderful place. And what I want to talk to you today was to highlight the pattern and outcome of cervical spine injuries associated with head injuries in children. So there's a percentage of children that not only have head injuries, but they seem to have quite significant neck injuries. So we wanted to see whether there was a particular association. For example, is a mild, moderate, or severe head injury, and what would be the pattern of such injuries? How could we prevent those or intervene, and so on? A significant part of the head injuries in children, of course, as you know, is non-accidental head injury. And recently we had a very sad case of a child that came in quadriplegic, is actually ventilator dependent on the ward. Everybody thought it was a road traffic accident because the car was actually, it was found as a road traffic accident. But what they found is the baby was several meters out of the car in the winter, and the family told us that the child had flown out of the window, and all the windows were closed. So there's a serious suspicion that this child, which is has got transection of the cord, that somebody has actually wrung the neck. So it's very important, children, to be aware that all you see might not be all that it is. So we know from experience, for example, in the West Midlands is a population of 32 million with 5 million children. We are the regional pediatric unit. We know that falls is the commonest injury for us. It's about 63% of admissions and 41% are girls. But significantly more injuries take place inside the home. And we know this because children under the age of 2 go out accompanied. So they are usually, when they get into trouble, they get in trouble in the home or they fall out of a window. But for children under the age of 15, road traffic accidents account for about 15% of the injury admissions, particularly in males. And sadly, those are the ones that are associated with severe head injury, and they could be associated with severe trauma as well. Now, the good news is, of course, the overall incidence is not high. So the literature talks about 1.5% of cervical spine injuries in head injuries. But radiographic evaluation is often difficult in children. And a lot of speakers have alluded to that. And initially, some of these children might actually undergo conservative treatment because of lack of knowledge that the child actually has undergone a serious neck injury while it's being treated for a head injury. So what we wanted to do was to look at the gamut of craniocervical injuries and see whether, what is the incidence in our own practice. I don't have to tell this august audience the various types of the injuries. Previous speakers have alluded to this, but in children, occipital-atlantal dislocation is actually quite important. Condylar fractures, very rare for us. Atlas fractures, odontoid fractures, posterior axis fractures, probably far more frequent. And of course, ski-warren in children under the age of 2, which may go unnoticed for some time until the MRI scan is done. I wanted to highlight this table again about occipital cervical dislocation, which I think was Trinellis who made this classification. And occipital cervical dislocation is very frequently encountered in children with very severe head and neck injuries. So the other point that I would make before I start is that a lot of these injuries in children, for example, the atlanto-occipital dislocation, the cruciate ligamental tear, you heard today Professor Patak alluded to that as well, that if you get the tear or avulsion of the cruciate ligament, then that is an unstable injury. Ligamentous injuries, subaxial injuries, all of those are unstable, and it doesn't matter how long you treat them conservatively, they will remain unstable, so you need to consider stabilization, and probably sooner rather than later. So way back, we're talking nearly 30 years now, we did a 10-year study in 1995 to 2005. In that study, we found the basic information that we wanted. But 30 years on, we wanted to see whether anything had changed. So I then extended that study all the way to this year. And this is the data that I'm presenting, the findings of the data I'm presenting to you today. It's just under 1,600 patients. And we looked at the usual demographic data, patterns of injury above, the axial craniocervical junction, and then the subaxial spine, the mechanism of injury, and then, of course, the management. So what we found is between 1995 and 2005, we had 445 patients with significant head injury. Of those, about 2/3 were boys or males with a mean age of about 8 years. In the 2006 to 2024 group, interestingly, we had 1,133 children with head injury. 2/3 still male, with a median age which is just mean age which is just about the same, about 9 years. Now, what we found is on the first 10-year study, 2.5% of our significant head injuries also had an associated severe neck injury. And the ratio here, as you can see, is 7 males and 7 females and 4 males, which is not consistent with 2/3 of boys suffering from head injuries. And then if we look at the current group, 2.6%. So the percentage of children with cervical injuries in severe head injury has not changed. And the ratio between boys and girls is also not the same as head injury, is 1-to-1. And I think one of the explanations for that is that a lot of these injuries occur in road traffic accidents where you don't choose who is in the car, whether it's a boy or girl. So they tend to, in fact, the latest data, which is much larger, is 8 and 8. This is an example of a child who had transection of the cord. This child was just under 2 years of age, a road traffic accident. What we normally do is we fix them at the beginning, and when they're stable, because a lot of them have cardiorespiratory instability, you can't do anything with them, you can't touch them. And then after that is done, we then go and do a fixation. One of the things I wanted to point out is that children under the age of 2 years, actually, their heads are still growing. And this is an example of how the head had overgrown the halo. So they need change in the halo ring as time goes by. And then, of course, the child had the open ring put in. So this child, the father absolutely refused the fixation. And for 5 months, we kept the child on the halo. And the day we loosened the halo to see whether there had been an ankylosis, arthrodesis developed, the child had a cardiorespiratory arrest. At that point, the father realized that a fixation was necessary. And during the surgery, you could very clearly see how unstable the fixation was. This is, again, the father refused to have a metal implant, so actually used nylon sutures, and by using a bone graft, sutured nylon or sutures over. And then you can see the before reduction. And then in this case, I used bone morphogenetic protein. And it was amazing that within 4 weeks, bone fusion developed without using any implants. So in very young children, you sometimes have to think out of the box, be versatile, and use whatever you can use. But by 8 weeks, there was very gross fusion, and the child then came off the halo, and it's done very well. This, unfortunately, child died, so a lot of the children, 1/3 of the patients will not reach the hospital. This data is of in-hospital patients, but a lot of the children will die on the scene, and we will not be involved. This is an example of a child with C6-7 fracture dislocation. You can see a complete transection of the cord, and there was nothing that could be done on this child. The child had associated C1, C2 rotatory subluxation, which you can see here. So when they come like this, there is significant injury already at the cranial cervical junction. This is an interesting case, and I treated this child 10 years ago. The child was 2 years and 2 months old at the time, had a road traffic accident, severe intraventricular bleed, and the child was actually brought in with following the cardiac arrest and resuscitation into the ITU with a severe head injury. At the time, they didn't realize, because child was intubated and ventilated, that the child was actually quadriplegic. So he underwent management of the brain injury, and the CT scan then raised the possibility there might be a neck injury, and then the MRI scan showed quite a significant cord signal change, suggesting a transection of the cord with atlanto-occipital distraction, a 3-column injury, a C3, C4, so quite a number of things. As usual, we couldn't do anything for the first month. The child was very unstable, so we normally put them on a halo or some other form of immobilization until surgery can be performed. So once the surgery was performed, which was a C0 to C2 fixation, and then a C3 to C5, like being a plate immobilization, the child went to rehabilitation, did very well, and then 10 years later represented with severe hypertensive crisis and postural hypotension. In this sort of cases, we normally tend to do, the technique of fixation, so I'm not going to go into details on that. But just to show you, this is the preoperative picture. You can see on the rectangle that there is an increase in the C3, C4 height. And that then we put in a plate, a Leibinger plate, because the facets were so small they wouldn't take normal screws. So after that, the child went on to rehab, and then these are just pictures at the time, and then came back 10 years later with this fracture. So that we thought was the instability. Now, when we looked at the scans immediately after the surgery in 2014, there was some evidence of calcification. This was 4 months after the surgery, calcification of the disrupted C3, C4 disc. And looking at this now, 10 years on, you can see that there's a massive calcification of the osteophyte poking the spinal cord at this level. And there is failure of fusion at this level. You can see the block fusion above, block fusion below, but not there. So C3, C4 remains unstable. And on the MRI scan, you can see the significant cervical kyphosis at the level of instability and quite a large serings, which has developed below the level of the compression. And I'm in no doubt that this is because of the compression. So we then had to consider the various, you can see the serings is on the left side is a focal serings just below the level of the compression. So at this point, we had a child that had come 10 years after the initial surgery with an unstable anterior segment, an unstable posterior segment, and also significant serings and compression by the osteophyte. I sent to a lot of opinions, and most of them suggested we should do an anterior approach with the corpectomy, drain the serings, take the osteophyte out, and fix from the front. In children, I tried to avoid destructive procedures, and I felt that I should possibly try to do it from the back. And in the end, that's exactly what we did. We did a posterior spinal fixation, extending the fixation to include C3, 4, 5, laminar decompression, aspirated the serings from under the ultrasound guidance, and then with the space that was created, we were able to go around the cord in a slack tickle sag and drill this osteophyte from behind, and then extend the fixation to C4-5. So you can see the pre-op image with the kyphotic deformity and the post-operative image following the posterior surgery, correction of the kyphosis, and then extended segment fixation with a new rod. We disconnected the occipital rod because the fusion was already there. And this is the pre and post-op increase in the canal distance. So I'm going to conclude now to say that over 30 years, the incidence of cervical spinal cord injury in head injuries remains about 2.5 to 2.64% in nearly 1,600 children. The important thing, the take-home message here is that it's the upper cervical injuries that are the most prevalent, about 90% in our series, and that upper cervical spinal dislocations, atlanto-occipital dislocations, C1, C2, subluxations or injuries occur in about 2/3 of this group, mostly in younger children than 9 years, and the C1, C2 region was affected in about 70% of these cases. And of course, this carries a significant mortality in the head-injured patients. So our initial management was initially mobilization, and then, and of course, non-operative management at that point, and then subsequent fixation to craniocervical and subaxial injuries, resulting in a good outcome in those patients, the majority of patients. So I conclude by saying that the prognosis of neurological recovery is, of course, based in the severity of the initial neurological injury. And the Glasgow Coma score is a great predictor of that, and is much less related to the method of management. There are predictable patterns of cervical spine injuries in children, and the strategies for prevention of the cervical spine injuries in children should be based on these well-observed patterns. And I want to thank the team, and thank you for listening.
Thank you very much. Now is the time of Dr. Shanshak Sharad Kale, New Delhi. Is he in the room? No? Okay, we move to Dr. Delitala. Minimally invasive surgical treatment of odontoid fractures.
So Massimiliano, please skip all the things, and I go very quickly to some technical notes about the odontoid fixation, anterior odontoid fixation. We spoke before about the results and the indication. Now I want only to add some tips, some trips. So it's very important to have a double C-arm to avoid any retard in the action. As suggested by Antonino Raco, we put a gutted cork in the mouth, and you have to have the foot switch of the C-arm, double foot switch to the surgeon. It reduces time by 50% and avoid continuous movement of the C-arm. We performed the 6 cases in local anesthesia and in sedation, because our anesthesiologists were very cared about the intubation of the patient when there is a odontoid dislocation. And so we started to make them without intubation. The skin incision is very small. Someone called this percutaneous. We prefer to call it minimal invasive. We use the finger. We put the finger into the betadine and use betadine as a lubricant, and we enter. The muscles of the elderly patient are very relaxed, and someone has degenerative adipose degenerative variation, so is more easy. After the thin dissection, we inserted the tubular retractor, and then the Kirschner wire and the screw. Oh, this is the video, but as you can see, is completely inverted. Sorry. And the screw placement should be jointed the posterior cortical. So if you can be bicortical, should be better. And you enter with this line. And it's very important to use a double foot switch so the surgeon can regulate the images. And when the screw, when the Kirschner wire is inserted, you can put the screw. Which instrumentation? Someone proposed endoscopic, but we think is completely useless. The Synthes instrumentation is no more on the market, unfortunately, because the screw is very cheap, and they had no convenience to sell the product. Actually, only Medtronic is on the market. It's very good, very easy, and still very cheap. And so this is one case in which theoretically, the line of fracture contraindicated the wire, the screw fixation, but we can do the same with the correct use and with the bicortical screw. So the messages are the same that we spoke before. So remember that the competitor of such operation is spontaneous arthrodesis or pseudoarthrosis. Thank you very much.
And now is the moment for Dr. Salvatore Chibaro, consultant neurosurgeon scalp base in Strasbourg University Hospital, France, consultant neurosurgeon scalp base La Boursière University Hospital, Paris, and finally professor at the Siena University in Italy. He will speak about conservative management of type 2 odontoid fracture in the elderly, a prospective multicenter study. Please.
So good afternoon, everybody. First, I would thank Professor Bisocchi and Professor Signa for the kind invitation. And actually, my title is a bit different. Is what's the best management? So the answer is who knows. But about the elderly people, we started this study when after 2 or 3 patients in a row, we did the first anterior screw, the second one, and the arms, and the people were still symptomatic. So the problem is that nowadays the best management is still controversial, as I know this. I said that the lower fusion rate and the higher surgical risk of elderly patients. So we performed a prospective study on a cohort of patients, 260 patients over 75 years of age, in 10 years, in 9 tertiary European centers, and we looked at the global functional outcome, the fusion rate, and the needs for late surgery. So actually, we included only pure type 2 odontoid fracture. So patients with concomitant fracture or pathologic or traumatic or polytrauma, they were excluded. And what actually we did, the protocol said we should give only 6 weeks of Philadelphia collar, 6 weeks of soft collar. And actually, we found mostly women and with a median age of 83 years, and only 5 patients needed a salvage surgery. And we actually classified our patients in 3 groups. The first group, there was 45% of patients had a stable bone effusion. The group 2 had a stable fibrous non-fusion, and the group 3 was the patient that were still symptomatic 3 months after the conservative management. So, what is important to say is that all patients were mobilized immediately. Somebody within 24 hours, somebody else went home just after we fit the collar. And what is important is that there was no statistically significant difference about NDI, about VAS, about SF12, I mean, quality of life between the two different groups, the group 1 and group 2. And what is also interesting that 93 patients, so 36% of our patients actually didn't wear the collar. Somebody used to wear the collar just 2 weeks, and afterwards they discontinued, or even they didn't wear it at all since the beginning. So we had a very low and maybe not very major complication. I am not sure that the DVT was related to the pathology, as all the patients were immediately mobilized, and also there were 2.3% of chin sore. So, sorry about it. So this is a few cases. You see, this is a 82-year woman with a mechanical falls. She had this fracture, and we used 6 weeks Philadelphia collar, 6 weeks light collar, and we see as it fused very nicely. And this another one is a 85-year lady with a mechanical fall, and she actually had 2 weeks of light collar and 2 weeks of 2 weeks of semi-rigid collar, 6 weeks of light collar, and she was not symptomatic at the end of the treatment. And this is the last one, is an 89-year-old lady that actually she had just 6 months Philadelphia, and at the end, that was worse. So what should have done in this case? Just keep going with the collar. We don't know. Actually, we have taken off the collar, and the lady was very, very well. So we used these tools, these complex tools, the ACS tools, that the surgical risk calculator, and this complex but very useful. And oh, sorry about that. I don't know what's happened here. Anyway, what is important to say that this patient had a 86% risk of indefinite hospital stay, so we decided to treat it with a Philadelphia collar. We went home 2 hours after the collar fitting, and it was very, very, very well. So, in conclusion, we think that the conservative management of stable type 2 fracture is something that could be a good option, and very few patients required late surgery, and that we believe that a partial bone fusion maybe is preferable instead of perfect bone fusion, but what is important is the patient outcome. So I have to thank also Professor Goel, as the problem is maybe this new concept, or maybe this new paradigm. The problem is stability. So we have been trying to treat images and not sometimes patients, and I discovered that in many centers, they don't do dynamic test, dynamic X-ray, so people are scared to do dynamic X-ray in type 2 fracture that we could do easily, and that is maybe the key. If the fracture is stable, they don't need 75-year and older patient to be treated by surgery. Now, this is our paper was published that I would thank all the contributing center, and although it's not related to my talk, I invite all of you to contribute with paper with this special issue on traumatic chronic traumatic encephalopathy. And well, maybe the question maybe later. And I would thank you and invite you to come and visit Siena, and especially for this nice and crazy horse race. Thank you.
Thank you, Professor. Now I would like to invite our next speaker, Dr. Corrado Icarino from Italy. He is going to deliver a lecture on posterior wiring with sublaminar polyester bands titanium peak fixation system for C2 fracture. Welcome.
Thank you. Thank you. Good morning, everybody. Of course, thank you, Virenda, for this special occasion to share our experience and for your warm hospitality. I'm the last, so I avoid to insert all the slides about the literature, about everything of to prepare how to choose this kind of solution, because all the slides, all the argument has been treated until now, especially with the presentation of Professor Delitala. And so we present this paper that we had published this year about this solution. There is a very simple solution, and I think there is the further last proposal option in this kind of fracture. It's a simple, flat and flexible polyester bands with a band tensioner and a fixed with titanium peak fixation system. Very easy. It's a posterior wiring, nothing new. The only new is the material. So it's a posterior wiring with this band in polyester, very thin, so very easy to pass under the lamina. And after, with this system of tensor, we can fix the bands, and to fix the system, we can fix C1, C2, we can fix C2, C1, and C3, so C2 in the middle of C1 and C3, like point of anchorage. And this is how it works. This is the intraoperative X-ray. So it's clear the first is before tension, after passage of tension, and when we close by manual tension the system, the fracture is reduced, and so we can close the system. So it's very easy and fast. Where we have done, and which patient we done. For example, in the failure of a conservative treatment for transverse course of C2 body. Is a male, 69 years old, and emergency CT scan show a C2 fracture. At MRI, no ligament disc, no disc, and no spinal cord injury. And after 1 month of wearing a rigid Philadelphia cervical collar, we observe increased fracture diastasis. So we decide that this is an unstable fracture. I mean, the conservative treatment failed, and so we decided to propose this kind of treatment to the patient. And this is the results with the reduced fracture. Or we apply this surgery in a failure of a conservative treatment for Anderson-D'Alonso type 2. That in 2 cases, case 1A is a male of 37 years old, and case 1B is a male of 76 years old. Both of them have the same kind of fracture. And the first case where the collar 3 months, the other case is where the collar, Philadelphia collar, for 11 months. At a CT scan, we observed a worsening, so increase of fracture diastasis. For the first case, we tried to treat in a conservative way for further 6 months. Observed further increasing of fracture diastasis. And so we proposed the treatment. And the first patient was discharged in 7 days, and with 1 month of rigid cervical collar and 2 weeks of soft cervical collar. The other case about the same treatment. This is the two cases, the two fracture with increased fracture diastasis. And this is the post-operative control, 12 months the first case, and 3 months post-operative control in the second case. Or we proposed this case in this lady, 80 years old lady, with a Jefferson type 1 plus Anderson-Donaldson type 3 fracture. And the emergency CT scan showed this situation. The first column is the preoperative. The woman was obese with DOAC, chronic obstructive bronchopathy, and moreover, it was a mother-in-law of our intensivist, and all we know how is huge prognostic factors. And so, talking with our intensivist, he saw about the tension band, and he proposed also for his mother-in-law this solution. And we was in agree with this solution due to the real obesity of the patient, a really short neck, and the chronic obstructive bronchopathy, so to reduce the timing of prone position. And this is the control at the first postoperative CT scan, 3 months postoperative CT scan, and 1 year postoperative CT scan. So with the reduction of the fracture and the good healing of the fracture. Even the C1 fracture that, to be honest, I was about skeptic on the solution of this kind of fracture with this kind of solution. The last patient is a young patient, young female patient with this kind of fracture, and there was no injury of ligament, disc, and spinal cord, and it was proposed this kind of surgery because the patient was highly scared about the vascular and nerve risk of injury, the risk of injury of vascular injury, nerve risk injury. And this is the control, 6 months postoperative CT scan with a good resolution of the fracture. So our results, duration is about 128 minutes, with the maximum fracture reduction is an average of 2.4 millimeters, few blood loss, hospitalization is no more than 10 days, and postoperative pain was well controlled with painkiller during the first days. All the patients who had worked prior returned to work. So the advantage was very simple. So we do need a specific spine surgeon for this kind of surgery. We do not have a microscope, the need of microscope. We do not have need of navigation, and very few lateral dissection of the muscles. Disadvantage, of course, is that there is a need, a tailored indication, and we can discuss about the need of external collar. Is much more for surgeon than for patient, and it's reported in literature that the posterior wiring is associated to dural injury, but the material is polyester, very thin, very fat, is impossible to damage the dura. The key findings, so that we have to think about the solution not like first choice of procedure, of course. This is a low-cost solution, and I think that in some kind of environment it's possible to propose this solution. Is proposed for fragile patient, elderly patient, and mainly could be a rescue procedure that could be possible to have in our operating theater this kind of solution that works in some cases, especially when the conservative case failed. Thank you.
Thank you very much. And now we open the discussion of the presentation. First presentation is Modern Surgical Strategies in Craniovertebral Junction Traumatic Injuries. Any question? No. We move to the second presentation, Dr. Guirish Solansky, Pattern and Outcome of Cervical Spine Injuries Associated with the Head Injuries in Pediatric Patients. Any question? Atul Goel and Andrew Schleiser, please.
Syndromic patients, in some syndromic people, like if there is a even minor head injury, you have more deficit in with hyperflexibility of joints and things like that?
No, this is it's a very important question, and I should have clarified it. This is all of these head injuries that are associated with neck injuries are all severe head injuries.
I wish to also know from you, because of your experience, how many children you have seen syndromic, having occipito-atlantal instability with trauma or with any kind of issue?
Yes, so to answer the second part of the question is, in this study, we're only looking at acute medication, but we had one death in a child who had MDS 4, and it was an emergency breakthrough attacks in the child with instant death. We're not included in the series because we didn't require treatment, but you're absolutely right. So the children with pre-morbid conditions, they are seriously at risk of neck injuries. Thank you for highlighting that. So classic children, controls, those genesis imperfecta, just to name a few, they're very much at risk.
Thank you.
Thank you. Gurish, a fantastic study. Gosh, the length and depth of that study is quite amazing, and I can't wait to read it. I have many questions, but I'll just stick to one. We've had a couple of cases where, as you said, upper cervical spine injuries are difficult to diagnose initially on just plain radiographs. And we've had a couple of kids that were recognized to have an upper cervical spine injury by some subtle and sometimes not so subtle posterior fossa only bleeding. Sometimes it was in retrospect. Any comment on that? The question being posterior fossa bleeds as a tip-off sign, red flag that there may be upper cervical spine injury. Did you look at that in your series?
So I appreciate that question, and I think the Professor Associate Control Committee is doing to highlight the importance of appropriate investigations, essentially. I think, like everybody else, we have also been found of failure to identify these cases. And I highlighted one particular case where, in fact, it was the child that was reoperated. That child had a road traffic accident, cardiac arrest at the scene. The emergency team was all about necessitating the cardiac arrest, the mobilization, brought to the hospital, and went straight into a scan. And what the scan showed was interventricular hemorrhage, and as the reversal signs of severe ischemic usually happens after the fact. What's your experience on this?
Yeah, I mean, again, an astute resident, astute radiologist sometimes will phone us and say, you better pay particular attention to the upper cervical spine. There's, as you said, some subtle blood in the craniocervical junction. There's a little subarachnoid space, prepontine or premedullary, and that really is the tip-off that there may be an upper cervical spine injury, and those are really upper cervical spine injuries until 100% excluded, whatever technique you take to exclude them. There have been one or two disastrous cases, quite frankly, where we didn't recognize it, and in retrospect, we should have. It was there, so it's gone both ways.
Because of the same mechanism, very heavy head, very small neck in the children. Again, some others have pointed out that it's really important to do a whole MRI of the spine in the eye, because you often find cellular blood in the cul-de-sac at the bottom of the spine, or on the clot at the level of the corners, and presumably the blood gets stuck at the spinal corners, and then falls a clot there. So I think all of those things are signs that something serious is happening.
Totally. Thank you very much.
Any question for Dr. Delitala, minimally invasive surgical
Sir,
treatment?
can I ask one more question, sir? Can I ask one more question, sir? Good evening, sir. From Dr. Solanki again, sir. Sir, I just wanted to ask, very nice series and your this thing. I just wanted to ask, have you had experience of children who have had severe head injury and severe spinal injuries, and where you require surgery for both? Have you had such cases, and if yes, or if no, either way, and if such a situation is there, how do we proceed? What are your thoughts on it, sir? Thank you, sir. Yeah, you clarify. Sir, if both are there, surgery requiring for both, then how do you go about it?
Absolutely. So essentially, we immobilize the spine as best as we can and do the most important thing, which is the brain. So we do craniotomies, compressive craniotomies, EVD, bring the cranial pressure down with immobilization of the head. So there's one patient is in ITU or the ICU. We don't put a collar. We put just sandbags on each side of the neck to reduce the intracranial pressure that goes on with the position of the collar. But at the earliest possible opportunity, we put in a halo to immobilize the head and spine. Often not possible, because if they have to undergo craniotomies and other things, then we delay it until it is possible. That's my experience. But Professor, we have seen this year, so there's lots of people who have a lot of experience with this. It would be nice to hear from you.
So is there a role of traction there? Is there a role of traction in that case, since you can't put a halo and all that?
Yes, we don't use traction on very young children. The halo immobilization is adequate to stop movements, but you can do some traction if necessary with the halo. Having said that, most of the patients we have already had atlanto-occipital distraction, so doing any traction on that would be counterproductive.
For Professor Delitala, any question? Minimally invasive surgical treatment of odontoid fracture? No? So we move to Dr. Kibaro's presentation, Conservative Management of Type 2 Odontoid Fracture in the Elderly, a Prospective Multicenter Study.
Thank you, Salvatore, for your presentation. And I want to ask, I saw that 36% of the cases did not wear the collar. Did you follow them anyway, and which are the difference between the other group?
Comments to Dr. Iaccarino's presentation last one, and I will ask a question.
So all the patients were followed up with 24 months, and there is no difference in the outcome and about the patient having a stable bone effusion and a fibrous non-stable, a fibrous stable non-fusion. And what actually we do now is we put a soft collar for 3 weeks just for to avoid pain, and we do a dynamic X-ray, and if there is no instability, we take off the collar.
Thank you. Now we are moving for questions for Professor Icarino about the presentation of posterior wiring with sublaminar polyester bands.
I have a question and a comment. Congratulations for your innovative presentation. As far as we know, we stopped to use wiring technique with sublaminar old-fashioned titanium cables, and now we move successfully to polyester wires. My question is on the surgical indication of 2 special cases you showed us that very impressive and very interesting to comment. Angman fracture and type 3 odontoid fracture. My question is, for type 3 odontoid fracture, what about the conservative treatment, Allovest, not surgery, but just wait and see? First question. Second question is for Angman fracture. Angman fracture is mainly a subaxial disease, not an axial disease, since the problem is between C2 and C3. What about the possibility to fix C1, C2, C3 with polyester cables instead of only C1, C2?
No. The second answer is most rapid. C1, C2, C3. The fixation of C2 is the wiring is C1, C2, C3. So the first question, in case of failure of conservative treatment of type 3 fracture, the fracture type 3 that I show you is in case of failure. So in case of failure of conservative treatment, depending on the classification, I mean, if you treat a patient with a conservative solution and this solution was failed, the question that I ask to myself is how, due to this new solution, how long I have to wait before to define failure? Because you see, the second patient is 11 months of collars. Another patient wear collar with 3 months, and after additional 3 months. I think that after 3 months, the bone done what he have to done. And so it's a question that I move to our colleague. I think that due to this solution with polyester band that avoid all that problem with the Titan wiring, maybe in case of failure after 3 months, if I see in postoperative CT scan control widening fracture, maybe I can propose much more earlier.
Thank you so much for your complete explanation. I think that with my colleague we can conclude this beautiful section. Please, Girish.
So if I can give you just one question, it's not a question, it's a comment really. I think you do a brilliant job with the guidelines, and the difficulty is in very young children. And I think if we can work, I know that Andrew is here as well, Professor Singh is here, if there is any opportunity for us to try to move that dialogue forward, to identify some markers, tips, whatever, to add to the guidelines of the grades.
Absolutely.
Just I want to ask experience of anyone about the prefabricated 3D models for practicing day before the surgery for this CVAD or BI or trauma of spine. We do prefabricated models and we practice before surgery. It helped in number of patients. So anyone experience and
Preoperative or intraoperative? So a lot of
Yeah, 3D printing.
Yeah, 3D surgery. What most people are doing now, these custom, using the MRI CT scan, they will do a 3D printed model of the, this is for perioperative care. And then they would use specific markers that allow you, for example, near perfect screw implantation through little additional holes that they would make on the, the pre-operative 3D model. So instead of using image guidance now, you can do a 3D printed model with the holes in the model, so you know exactly where to pass the hole and the hole. One of my colleagues in the UK has published a paper on 34 cases where they use this technique with success.
For our experience about the 3D model and 3D printed guide, basically you are asking for there are two things. So one is model, which is used for like pre-operative planning and all. Second is what we are discussing about the 3D printing medical patient-specific guides. So we have experience, we are going to publish our like 3,500 patient of thoracic and lumbar. Now we have experienced around 100 patient of the cervical spine, but all in adult deformity. The main problem with this is the accuracy. So thoracic and lumbar 3D printed guides are like almost 100% accurate in our study, 99.9. But cervical cases, I will say it's 50-50. Especially in the deformed spine, especially in the mobile spine, it is very unreliable. So this is our experience about this one. So because in thoracic and lumbar spine, basically these guides specific are used for, has a definite marker at each level. Suppose like TP, transfer process, or the spinous process and the lamina below. In cervical spine, it is deformed, so you are not able to fit most probably. So fitting is the one problem, and if the 1 mm of like mobility is there, then you are done. So you are not able to use this one. So that is the problem. There's a practical problem actually.
So I invite my colleague to conclude with me this beautiful session, hoping that in the future, in the ICRAN Congress, will be always a section on craniovertebral junction injury. Please.
Thank you to everybody for an absolutely fantastic session.
Thank you very much.
So
good evening to everyone. At the outset, on behalf of World Federation Neurotrauma Committee and AASNS, let me express my warm welcome to this Pink City of India, Jaipur. I am grateful to all the dignitaries who has joined this meeting from different part of country and from Bird. I am grateful to them, and they will share the burden of neurotrauma solutions in more effective way. The skill of neurosurgery, neurotrauma is beyond the convention form now. The minimal invasive time has come, so it will be very good for us. So their knowledge share will be implemented on our patient. And finally, I cannot forget the contribution of Dr. Andrew Reisner, Dr. Kate Drummond, Dr. B.K. Mishra, and Dr. Andrew Rubiano, who helped us for last 1 year in planning and managing this event. And I hope you will have a very memorable time. You will carry good memories of this meeting. And thank you very much.
Thank you, sir. I now request Dr. Andrew Reisner to share his overview for this conference.
Thank you very much. On behalf of the Neurotrauma Committee of the WFNS, I cannot thank the organizers, Dr. Sinha, Dr. Chakraborty, Dr. Gupta, enough for their hospitality, for the effort they put into this conference. And it's been an absolute honor and a pleasure to be here. And you should be very proud of yourselves, because we are very, very proud of you. If you don't mind, just for a moment, we sort of transitioned the chair of neurotrauma to Dr. Andres Rubiano just an hour or two ago. And it was a bit of a bittersweet moment for me. The sweet part was working with so many outstanding individuals, some of whom are in the room. And I'd like to quickly give a shout out and a huge thanks to Dr. Rubiano, Laura Lipper, who's not here, my predecessors, Dr. Hutchinson and Tariq Khan, who's not here, David Adelson, Gurish Zelansky, Corrado, Ahmed Al-Fiqi, Salvatore, Corrado Icarino, and apologies for anybody else I've left out. The WFNS, the mission of the WFNS is to spread knowledge worldwide. I think that the individuals I've mentioned have been exemplars of that, and I'm so honored to have worked with them. Thank you all very much.
Thank you, sir. I now request Dr. Kate Drummond to share a few words.
Thank you very much. The Asian Australasian Society of Neurological Surgeons is the largest continental society of neurosurgeons in the world. And we serve 2/3 of the world's neurosurgeons, caring for 2/3 of the world's population. And one of the great reasons that we do that is because India contributes so much. So we're really excited to be partnering here with India, in India, for this neurotrauma conference. We know that neurotrauma is a very big problem in much of the world that is part of the Asian Australasian Society. And so I think having this conference here is incredibly important because it's in countries like India where neurotrauma advances are going to come with the large population and the large burden of disease. So I think it's fantastic that the conference is here, and I'd like to thank Dr. Sinha and Dr. Gupta for the fantastic organisation and the wonderful hospitality. Also Dr. Reisner, of course, for the WFNS contribution, and Professor Misra for his long and standing contributions to WFNS and AASNS as well. I hope you all enjoy the conference. It's been a pleasure for us to be involved in the organisation of it, and thank you all for coming.
Thank you, ma'am. Now I request Dr. B.K. Mishra to share his words of wisdom.
Good evening. I am also a host and a guest. As a host, thanks to Dr. Sinha, I'm the national advisor he has put me as. So thank you very much. Let me first congratulate you for a great meeting. Sinha, Joseph, usually, have a focused meeting today with so many webinars around, so many meetings around. You had 350 people. Incredible efforts. Thank you very much and congratulations. I also, as the national advisor, like to thank Andrew, my dear friend, and Kate, my colleague for a very, very long time. We worked together in ASNS for a very long time. And Dr. Gupta, organizing secretary, for making this a great success. Thank you very much, guests who have come here all the way from different parts of the world. Jaipur is one of the most beautiful cities we have, so take some time out, go out and see some places, have memories. If this is your inaugural trip to India, come back sometime and spend time in India. And again, on behalf of the WFNS Foundation, I also congratulate again Dr. Sinha. Virender, well done. Thank you very much.
Thank you, sir. I now request our organizing secretary, Dr. Ashok Gupta, to share his vote of thanks.
Good evening. On behalf of ICRANT 2024 Organizing Committee, thank all the delegates, speakers, and chairpersons for sparing their valuable time and coming to Jaipur. Today has been a good academic discussion and learning. I thank the WFNS and AASNS for their valuable collaboration and help. I also extend thanks to the Neurotrauma Society Jaipur. I am thankful to SMS Medical College and the Neurosurgery Department. This event could not have been possible without our core team, scientific team, sponsors, Mohan Foundation, Jaipur Citizen Forum, and Muskan Foundation. I may have missed some important people. Thank you once again. I request all of you to join for dinner. Thank you.
Thank you, sir. Now we will begin our musical night and the dinner.